Please join me in welcoming President of the Lown Institute, Vikas Saini.
Good morning. Test, yes. Good. Welcome, everyone. I'm Vikas Saini, and I'm president of the Lown Institute. So, as Judith said, we're delighted to have everyone here. I think it's going to be a great day, hopefully full of incredible conversation. I hope some arguments, but we'll see. Let me tell you a little bit about the Lown Institute for those who don't know. We're a Boston-based think tank founded by Bernard Lown, who was a Harvard cardiologist, social activist, and Nobel laureate. He invented the first working defibrillator, built some of the early coronary care units. So he was really comfortable with technology, but he understood how much it can be a double-edged sword. In fact, his motto was, do as much as possible for the patient and as little as possible to the patient. And in his clinic, he did everything he could to hold back the tide of expensive technology. And he taught his trainees, including me, that the heart of healing is really in the relationship. It's what patients want most is to be seen, to be heard, to be understood by a caring and competent clinician. So at the Lown Institute, we believe in that kind of care. We think that's the least costly care there is. And so that's our DNA, and that's why we're here today with you. So a few thank yous. First of all, to KFF for this lovely space. We're really delighted and grateful that we have this opportunity. And then next, the Lown Institute wouldn't be here on this program today if it weren't for Noam Levey of Kaiser Health News. Noam, where are you? So his excellent and passionate reporting was the trigger for our involvement. And it was he who conceived and inspired the project that we'll tell you a little bit more about later. I also want to thank Arnold Ventures for their generous support, not only for this conference itself, but also for the work that my colleague Kelsey Chalmers will be presenting later. And then, of course, most importantly, I want to thank the members of the working groups that helped put this together. There were two working groups, one for this conference itself, and another that wrote a comprehensive reference paper that we'll be releasing in a few weeks. I'm not going to list them all, but just so you understand, this was a real collective effort. And so on behalf of the Lown team, I want to ask all of them if they could stand up. Anybody who was on those calls for the last year, you'll see quite a few people. Great, thank you. I just wanted the rest of the audience to see you, acknowledge you, and know where to send the hate mail. So let's talk about why we're here and what the day is going to look like. Our first panel will begin with the ending. We'll toss out some solutions and give you some answers even before we start asking questions. That's because I think you'll all agree everyone in this room has some idea of the story, so why not just dive in? After that, we'll learn a little bit and a lot about what we know about medical debt with some incredibly knowledgeable researchers. And then we're going to take a look at the nitty-gritty with a couple of visionary hospital leaders and some key advocates. And then the rest of the day is going to explore a wide range of solutions with an amazing group of thinkers. So Judith also already mentioned the format. We really want this to be interactive, so feel free to start writing your questions and comments down now. So in the last few minutes, I just want to exercise my prerogative to sort of set the stage in the way I'm seeing it. First of all, my background is pretty eclectic. You can read about it online. I'm not sure it makes any sense except maybe as preparation for this moment today. But I studied politics, philosophy, and history as an undergrad. Then I became an internist and cardiologist, training at Hopkins and Harvard after med school in Nova Scotia. So I'm a damned Canadian. I practiced cardiology for 35 years, both in the ivory tower and in the lovely community setting of Cape Cod. And I've held positions with many different vantage points in the system. I did animal research in a lab at Harvard. I co-founded a medical device company, raised money in Silicon Valley, and started first for that company corporate research around the country in academic medical centers. I founded a primary care network that took global risk, upside and downside, successful group, and with that learned how to negotiate with health plans, hospitals, specialists, and you name it, as well as getting my colleagues to figure out how to operate on a fixed budget. And these days at the Lown Institute, where I am now, our task is to develop bold ideas for the kind of healthcare system that everyone in the United States says they want, which is one that is effective, affordable, and just. So we're going to be talking a little bit about the causes and solutions of medical debt. We'll be doing it all day. But I think we have to acknowledge that medical debt is a symptom. So you can take an aspirin, Tylenol for your fever, that doesn't make it go away. The symptom is of the deeper affordability crisis in the country. So any permanent solution, if we aspire to permanent solutions, have to look at the underlying drivers of high costs. And there's no mystery about what those are, and I think everybody in this room could probably name them. So let me just do that. In no particular order. Consolidation and monopolies, relentless technological innovation, some of which is near miraculous, but too much of which is capital intensive and a waste of time. Wasteful administrative costs from a ridiculously complex insurance system. Then there's Baumol's disease, the Princeton economist William Baumol, which is the tendency of service sector costs to rise relative to manufacturing costs. The increasing prevalence of chronic disease, which is getting its day in the sun with Bobby Kennedy, with mixed results in my view. An aging population, and maybe there's a fix for that. And then something the Lown Institute highlights every year with our annual Shkreli Awards, and something we shouldn't be afraid to say out loud: a growing culture of greed, grift, and rent-seeking. So obviously we're not going to get to all this today, but we should remember these things, because otherwise we're going to be condemned to a perpetual game of whack-a-mole. Every time we try, we'll fall short. So finally, let me just say that medical debt is not a Democrat issue. It's not a Republican issue. It's an American issue. When we're healthy, we, the living, forget our mortality. But when illness shatters that illusion, the kind of anxiety it triggers, whether you're aware of it or not, that anxiety is not the time to be worrying about money. So for the wealthiest society in history to impose financial fear on the sick, to me, is just grotesque. A nation whose people are forced to choose between medical treatment or food, housing, or heating cannot call itself a great nation. So let me just say that neoliberalism's answer to all this, co-pays and deductibles, is a failure. In over 35 years of practice, I've seen almost no one come in for care just for kicks. Charging $35 a visit to someone making $15,650, you can look that one up, that is not going to fix the system. So let's be serious. As my friend Rashika Fernandopoulos once said at a Lown conference many years ago, patients already have skin in the game, their actual skin. So if you look at the various crosstabs of the KFF surveys, which I did preparing for this talk, I actually was flabbergasted. Working on this issue for a year, looked at some of these numbers, I found them hard to believe. So I hope the methodologies are good. But here's one: 44% of insured working age adults had experience with some form of medical debt, current or otherwise. That means out of roughly 217 million working Americans under the age of 65, over the age of 18, something like 95 million are in that group, and that does not include seniors. And here's one thing that's easy to forget, because medical debt is usually reported as a rate in various populations. The rates are higher in people with lower incomes. They're higher in younger people. They're higher in blacks and Hispanics and in women. Not exactly a surprise. But make no mistake about where the largest numbers of people with medical debt are. With the KFF numbers, I calculated that anywhere between 90 and 130 million, I don't know, 90 to 130 million out of a total population of 255 million white folks in America have now or in recent years experienced some form of medical debt. That is to say, medical debt is a key problem in the lives of non-college educated white working class people, particularly women. Need I point out that Donald Trump won that constituency by 28 points? I think Senator Josh Hawley seems to know that, given what he's been saying lately. So we're all here because this issue really is a moral stain on the fabric of the country. We're here because too many of our friends and neighbors, our brothers and sisters, our parents, our children, too many of them are grappling with a difficult, sometimes intolerable situation. So if we're going to be declaring national emergencies, maybe this is one. But we're also here because if we want to fix this, we can. So thank you for listening. Let's turn to the first panel now, and I'm going to invite them to the stage. Fred Cerise, Patricia Kelmar, Dave Shuster. So this is meant to be a kind of rapid fire session. We're not going to give long lectures. This is the lightning round right at the start. So let's get started. Fred, to my right, Fred Cerise is CEO of Parkland Health, which is a safety net health system in Dallas, and he's the chair as a physician of the American Board of Internal Medicine Foundation. Patricia Kelmar, far to the right, is the Senior Director of Healthcare Campaigns at U.S. Public Interest Research Group, which I think everyone knows is a consumer advocacy organization with affiliates in 24 states. And Dave Shuster is the President CEO of Horizon Goodwill Industries, a not-for-profit social enterprise in Hagerstown, Maryland, that strives to remove barriers to social mobility, including healthcare costs. So for each of you, what brings you here to the conference today?
I'll start. Medical debts has been an issue that I've been sort of dealing with for my whole career. I've been in public health systems my whole career, and so it's part of our work. We followed your work, Vikas, for a long time. ABIM Foundation is interested in this, and I think I'm one of many who's struggling to find good answers for real deep systemic flaws in our system.
Patricia?
Well, first of all, thank you so much for inviting me today, and it's great to see so many strong advocates on this issue in the room today. So U.S. PIRG is a consumer advocacy organization, and this issue actually merges two of our key campaigns, our key priorities. That is financial protection, right? Making sure that credit reports reflect accurately the information about our financial history. And trying to fix, we helped stand up the CFPB, the Consumer Financial Protection Bureau, which is really a key agency to help us prevent our credit scores from tanking because of errors. So And then on the healthcare side, which is the area that I focus on, we've been really looking at the high costs of healthcare. We want to empower consumers to actually know real prices, to hold those providers accountable to real prices, and to make sure that we get costs closer to prices closer to costs. So medical debt ends up when we don't have good pricing and when we can't protect ourselves from overbilling.
Dave?
All right, so first of all, here's a shocker. Horizon Goodwill, not a healthcare agency at all, as you might imagine. What we are, though, is a nonprofit organization that's got about 550 employees with a team that gets incredibly frustrated when we encounter systems that take advantage of people and negatively impact their lives. So somewhere around 2015, when we started to see escalating costs in all of our traditional healthcare medical benefits plans that we were operating, we did what most businesses do, which is we started tweaking those copays, changing those deductibles, trying to make the numbers work, because as you might imagine, in the nonprofit space, we don't have unlimited margin to absorb these costs ourselves. After about 2 years, quite honestly, part of my language, we said, to hell with this. This is a bad choice. It's negatively impacting our folks. We reached out and we found a broker, and we basically started dismantling all of our traditional medical plans in favor of completely alternative solutions, really, that at this point, thankfully, work in favor of our employees to help them get access to better quality and more affordable care.
So let's just go back around in reverse order. Dave, can you just pick that up and say, can you tell us a little bit about what the success has been? What have you seen?
Sure. So we do a lot of different things, but one of the most recent and most important success I think we've had is that about 3 years ago, we added direct primary care as an option for our employees. And so in this case, it's now probably most everybody's familiar with it, but for the way we implement it is a membership fee that we as the organization pay. Our employees then who opt into that system have unlimited access to a primary care physician via multiple modalities for whatever treatment they might need. And the reality is, when we first learned about this, it resonated and made sense that these are physicians that have completely given up on this system, right? To go back to exactly what the purpose was, which is getting to know and adequately treat the patients, right? And not have to deal with all the hassles and all the other things that we're dealing with there. I will say, as an alternative model, in the first year that we did this, we did not have particularly great uptake from our team members, because quite honestly, they said, "What is this?" Right? We have no idea what this is. There's no copay. How does this work? We have somebody who we can text. They had no idea. So what we did is we actually got the physicians to come to all of our open enrollment, introduce themselves, because this is part of their model now, connect with our employees, and the uptake in the last 2 years after we've done this has been substantial. And we'll talk more about some of the benefits of that a little bit later on.
Great. Patricia, in the work you've done, tell us about some successes.
Yeah, so there is one great success story that I'd love to share with you, and that's part of the No Surprises Act. You may not be aware, but besides getting surprise billing out-of-network protections, consumers also now have the right to get a written good faith estimate, and that estimate is accountable to the provider's bill. So I'll just tell you a quick story. If you're a cash paying customer, you actually can ask for and get a written good faith estimate. So Dylan called me up. He was in California, a brand new job, first insurance. He was very excited to be able to have a salary, to be able to get his pilot's license, which was kind of a lifelong dream for him. So one thing he needed, because of his past medical history, was to get an EEG for the FAA license. And because he knew it wasn't medically necessary, he was going to have to pay out of pocket. So being, fresh in the workforce, not having a lot of savings, he called around and got some estimates. And he was given an estimate for $661. And so he signed up and he got his EEG, and you can imagine his surprise when he got a bill for almost $8,000. He called me up in a panic. I explained to him that if he had gotten that estimate in writing, he would be able to hold that provider accountable through the No Surprises Act good faith estimate provisions. So he used the patient provider dispute resolution system. He showed that through the patient portal, he was given this $661 estimate. He got his money back, or actually it got forgiven. And so he took that $7,000 in savings and he used it to pay for his pilot's license. And he sent me a picture of him in the cockpit. So that's how it can work. We get upfront prices and we hold the providers accountable.
Great. Fred?
So Parkland is the safety net for Dallas County, public system for Dallas County. And one of our community health workers sent me a note a few weeks ago about a patient said she encountered at one of their focus groups, and the topic of medical debt came up. And he told the group that Parkland saved his life. And so I asked if I could talk to him, and I ended up calling him and talking to him and kind of understanding the story. And I will tell you, it's a good story for this individual. It's not a great story for the overall system. But he said, 62-year-old guy, was living in California. He was an educator. He divorced about 20 years ago. Said he was intermittently pretty depressed, living in California, doing various jobs. His mother died, so he moved back to Dallas about 4 years ago. Was unemployed, living in subsidized apartment. He said that was running out, so he described it as squatting for the past 6 months. And his plan was when he had to leave, he was just going to walk until he passed out. That's what he told me. That was his plan. Identified a mass on his head that people were worried about, said he needed to go to the doctor, but he said, I was not going to do that because debt had crushed him for the past 20 years, and he was not interested in getting into any more debt. So he had resigned to not deal with it. Eventually, he self-treated. He said he sterilized a knife and cut it open himself and created quite a mess, as you can imagine, and ended up in Parkland's emergency room. Got connected. He said the doctor connected him to a financial counselor. At that point, he was shocked to know he was eligible without having to, as he said, document his poverty, and became eligible for treatment. Ultimately, has gotten chemo. He's scheduled for surgery, but his whole attitude on life has changed, and he's like excited. He's positive. And it just shows how much that issue was weighing on this individual, and the relief of that, how he now has a new lease on life. Great individual story, but highlights the problem, right?
Yeah, I was going to say that's a definite feel-good story, and then points to all the different places in the process that need attention. So we know things are possible. We know that certain individuals, certain kinds of leadership, certain kinds of practices can have a huge impact. So for each of you, what's a key impediment, or is there a thing that's really most frustrating as you think about this issue from where you sit? Dave?
So you can't be disruptive without hitting speed bumps, right? I mean, these things happen. So for all of our folks that don't opt for direct primary care, and then for all of our major medical services, we use an open network Medicare reference-based pricing model to pay all of the claims, which we're based in Maryland. And if anybody's familiar with healthcare regulation in Maryland hospitals and Maryland providers generally sort of get this because we've got pretty good pricing controls in Maryland. However, we also have employees in Virginia, West Virginia, and Pennsylvania. The systems that we interact with in those states, when they first see this, like, what in the actual are you talking about? Is this even insurance? Like, what is this card? It's not. It doesn't have a blue thing on it, right? We don't know what this is. And so what we end up doing is getting into protracted arguments with usually it's the major systems. Small providers, we usually are able to find somebody in their billing person and talk with them. But our claims adjusters end up having to go round and round and round with these major medical systems still to try to resolve these claims. And as everybody knows, meanwhile, we don't get the collections notice, right? As the employer who's working on behalf of the employee gets all that scary paperwork in the mail, and and they start freaking out, and they start pinging all of our team members about whatever the $60,000 bill is that I'm getting that I can't pay. What are you guys doing about it? The good news is that we have now at this point a protocol internally where, as to borrow somebody else's language, never pay the first bill, right? So send that to us. Bring it to us. We're going to take care of it. We realize that this is stressful and anxiety producing right now, but we got you, and we do. And every single one of these, we ultimately end up settling in some capacity. Twice, I think we've had to get lawyers involved to deal with it. And so, as you'd imagine, there's still a lot of frustration on our part in that one, because that goes back to some of this pricing and lack of transparency and all this billing. But we also did within this find a positive solution, and that is that most of these systems ultimately got tired of us eventually and were willing to direct contract. So for most of them now, for all of our folks, we have negotiated sets of pricing so that we've actually eased that pathway. It also helps that I've recruited 2 of the systems to have members on our board of directors, which is that once they find out what's actually going on, like, wow, why are we such a pain in the you-know-what to everybody else in the world? I think just from the employer standpoint, you can do all of the things, and it still causes challenges for the folks that are at, the patients and the folks that are under our care when they actually go out and still interact with this system as it exists right now.
Patricia?
Well, maybe I'm kind of cheating a little bit, but I would just say the whole billing and payment system is the biggest impediment, right from the beginning with the prices, right? Our insurers, the employers aren't able to really work to get in a consolidated system a decent payment, a decent negotiated rate. There's a lot of cost shifting, right, for co-insurance, co-payments, and then the claim denials, right? We're seeing AI is denying claims, the claim denial system for the consumer, the patient who gets that denial, trying to figure out all the paperwork they need to file. And they're left arguing whether or not this was medically necessary. I mean, what kind of information does a patient have, right? So, and the provider steps back and say, hey, that's the insurance company's problem. So I think it would be the whole system in general is frustrating. And it ends up meaning that consumers either have a really large bill that they have to pay in 90 days. They might be marketed extremely high medical credit card in the doctor's office or on the hospital website billing page. And if there's an error, there's a good chance it's going to end up on their credit report. And then they have to decide, should I just pay it to save my credit score? So I think it's just the whole billing and payment system that's a huge frustration.
Yeah, so I think you're going to hear a common theme today. And in addition to cost, it's the complexity of the system and the fragmentation of the system. So from the hospital perspective, when we want, which we desperately want to simplify this process on how we deal with it, the fragmentation of the system makes it very difficult. When we see patients, what insurance do they have? What are those copays? Many of them have very high copays. Do your discount policies, can they apply to those copays? Each one of those has to be a negotiated thing with the various insurers. Are people in network or out of network? For us, we have a county-based program that provides a lot of support for people in Dallas County. We get a lot of people from surrounding counties. Are they in county or they're out of county? If they're out of county, they're not eligible at the same level that they are if they're in county. Are they eligible for other programs? Did they apply? So if they're eligible for the exchange, did they apply for the exchange? Because as a county program, you want to be the payer of last resort. And what happens if they didn't apply for that and they need care right now and they're in front of you? And so the fragmentation of this the system makes it incredibly difficult for patients to navigate, and even for provider systems that are trying to simplify this. It makes it tough to put one program in place to address the problem.
So a real challenge is the complexity. I think we all know it. We all hear it. Anybody who deals with the system, either as a patient or a clinician, knows how weird it is, weird and complex it is. So how do we change this? How do we fix this? I mean, Dave, your day job is not fixing American healthcare, is it? So, but I guess I would still ask you, if you thought of a solution, something in your day-to-day as you grapple with this Is there one, two, or is there anything you've seen either as at a policy level or as a practical level or some other way that you would embrace?
Sure. To your point, 10 years ago, I never thought I would end up knowing as much as I do about the entire healthcare industry. And unfortunately, this sentiment will probably resonate. The more I learn, the more disappointed I get, unfortunately. So from just a personal instinct standpoint, part of me just wants to sit up here and say we should dump the whole system and start over, put the mic on the floor and walk off the stage. But that's not really a viable solution. And also, I will acknowledge I only know what I know, and it is complex. But what I will say is I want to go back to the direct primary care for a second, to sort of that simplifying the system that we just talked about up here, especially. One of the things that we have learned in the past 3 years about this is that, interestingly enough, our ultimate claims cost has gone up some as a result of this. But here's what happened. As a Goodwill, we're a workforce development agency. We work with a lot of folks that are in lower income brackets, quite honestly. These are folks that until they came to us and were offered direct primary care, neglected their health because they were very scared of the cost and the not knowing how to navigate the system and whatever the case may be. So now they have access to a primary care physician who says, well, wait, we really need to treat this thing that maybe if we'd gotten this 10 years ago wouldn't be what it is now. But now we're going to take care of it. Where we've actually seen most of that increase, honestly, is in our pharmacy side, where we end up with folks that are now on various maintenance medications for conditions that those physicians have identified. Now, I'll also tell you, we completely dumped all traditional PBMs for this thing. We use a concierge pharmacy system that, quite honestly, most of our employees get their meds for free. There's some that we end up still paying for, and we actually are able to incentivize our employees who sign up for that program with a cash bonus, actually, when they're willing to put in the extra effort on their part to qualify for it. But I think my solution, at least, would be, from an employer standpoint, to seek out and engage with direct primary care physicians as part of your overall medical benefits package, at least right now, because they're out there. They're more than willing to do the work and help solve some of the challenges that we're talking about here, at least at that initial care level. And the reality is that we know that if you get these things early, right, the downstream cost and the downstream need generally decreases through preventative medicine instead of having to deal with it later on when it becomes an absolute crisis. So that would be what I'd suggest.
Patricia.
Well, besides solving the root cause, which is high prices, so that will be easy. We'll do that tomorrow. We should really be giving consumers, in the meantime, really strong tools to know and hold accountable providers for any care that we're scheduling in advance. We also need to solve the problem of really complex medical bills and the difficulty of claim denials. And then finally, we need to get that medical debt off of credit reports. This is not an indication of a consumer's unworthiness of getting future credit. This is a situation where people have gotten sick or they've been in an accident. And unfortunately, although we've already won that, it looks like it's really not going to go into effect. So we'll still have that on our plate and list of things to do.
Yeah. So first, I love your direct primary care, and that sort of intensive primary care model is a great approach. We've seen the same thing. However, as we've pushed more people into that model, our costs are going up too. I expect that that's going to level off and come down. But just like you identified, we're identifying people with chronic disease. The GLP-1s are just, from a cost perspective, have really been a killer for us. And we're having to relook at that, even though we're covering them for people that have, other chronic conditions besides just covering it for obesity. It has been a big issue for us. But I think that's the more sort of primary care intensive you can get to manage things. I think it's a better solution. I'll give you two perspectives. One is kind of I think we're going to chip away at this in a bunch of different pieces and it's hard to just ignore the fact that our system fundamentally is not going to solve this problem as long as we have this market-based variable coverage that just does not address the entire population, and it's got serious gaps in affordability and in coverage. And as long as we're relying on that to solve the problem, we're going to continue to struggle sector by sector on how to cover it. And so, at a high level, we've got to be able to address a common solution for everyone. First dollar payment for people, whether it's a public option or whatever you want to call it, but something that covers everybody. As long as we look to the sectors, which I think we have to do. Look at the hospital sector, look at the payer sector, look at the providers. We need to do that because there's a lot of work to be done in those spaces. But it also creates an opportunity to point the finger to other areas. And without a consistent set of rules on how to address this, you're going to squeeze here, that's going to bulge out over there. And so the real answer is some fundamental change in how we provide coverage in the country. Now, from a practical perspective and what we can do, and I look at our sector, I think simplifying things, a common application for financial assistance that everybody could use, a common set of rules, eligibility, what are the expectations, reporting requirements, things like that, rules around you can't sue people, you can't report to credit agencies because people get sick. Those things should not be allowed. Max pricing for unfunded, uninsured people that's, maybe tagged to Medicare or something like that, but put some kind of restrictions on that. Things like community benefit expectations across the board. Hospitals have this expectation, but then it's incredibly vague on how do you fulfill that expectation. And so giving some more direction and guidance on that could achieve some consistency, across the industry. And I think, I may be optimistic, but I think you would get more sort of participation and responsiveness if there was more clear expectations of what hospitals need to be doing in this space. It's a piece of the overall solution, though.
Thanks. So I think we're going to open this up to questions. And just to rile things up, let me give you some of my ideas for solutions. Going back to the drivers of costs, if we go down that checklist, I think we need much more aggressive antitrust enforcement. I think we need a much more aggressive FDA, not one that is a rubber stamp for kind of stupid and very lousy clinical trials. So I'm kind of with Marty McCary on that one. No question that, let's just call it what it is, Fred. We need universal coverage in the country. And I'm with Joe Rogan. It should be socially funded. Come on. I think that is a key part of a solution. We're going to get there one way or another, but it's going to take more or less time in the conversations about how much suffering on the way. But beyond that, I think Medicare for all, without some understanding of the volume-driven nature of our current system and how deeply embedded that is, Medicare for all ain't going to be sustainable. So you are going to have to go to budgeted systems, capitated payments, direct primary care, an overhaul of how you deliver care in that way and how the funds flow. And let me just say, that can't be done by intellectual elites. This has to be done as a process democratically in the country to understand. And I'm on record as saying, if the American people in their wisdom want to spend 100% of GDP on healthcare, it is their sovereign right. But I also believe that nobody's that stupid. And in fact, we will get some real common sense about what the limits are for healthcare spending. But people have to be involved in that. Otherwise, you're going to get the backlash that's inevitable. From a policy point of view, and I'll keep talking until there are questions. So do we have questions? Okay, good. The last thing I'm going to say is we got to move beyond, clinical effectiveness for coverage decisions. We got to look at cost effectiveness. It is just crazy when you're at 20% of GDP that you're not going to think about what the cost effectiveness of a new treatment or technology is. So if Congress wanted to do something radical and major in a way that would solve things and probably unite left and right, I think, that would be one of them. Let's actually start looking at that before we start paying for proton beam therapy for stuff that really doesn't need it. Or when we have, 5 bariatric surgery programs in one town. I mean, I could go on and on. I'll stop.
Hi, good morning. Adam Fox with the Colorado Consumer Health Initiative. As participant in the work groups here for the project we've been working on. Sort of 2 questions, one for Fred and one for David. For Fred, I think you called out a lot of things that would be really helpful, and sort of to Vikas's comments, you didn't comment about Medicaid expansion, which is lacking in your state. And so I'm curious if you can expound on a little bit on that front. Obviously, there's the federal context that we're all having to bear in mind, and the potential cuts there, which would be devastating and explode medical debt. So hoping you can speak just a little bit on that front. And then David, I think it sounds like your model is a little bit different, but I think what we see in Colorado oftentimes with direct primary care, don't disagree with it in principle by any stretch. That's how it should be structured. That's why we've put first dollar coverage in the Colorado public option plans that we have in our state. But I think what we see is oftentimes direct primary care is not paired with major medical. It's not sort of built in to the overall health coverage. And when we're talking about medical debt, hospitals are a huge driver of that. It's less the primary care side of the equation. And so what we see is often patients and consumers, if they are pulled into direct primary care, they are either doing that in lieu of major medical or they are paying for both. And so it ends up adding costs when it should be part of their coverage. So I'm hoping you can speak just a little bit about that and how you are thinking about getting direct primary care as an integrated element.
Well, so for Medicaid expansion, so Texas is one of 10 non-expansion states. I don't get to make that call. If you took a popular vote in Texas, people would support Medicaid expansion as they do across the country. It's the state leadership that has not supported that. And as you know, that is one of the things that really can make a difference in terms of this medical debt issue, right? It just does. Texas, we have probably 5 of the top 6 or 7 large counties in the country that have the highest amount of medical debt, and it's not coincidental. I mean, it is related to the fact that we do not have Medicaid expansion. So, the cuts that are being talked about right now, who knows where those things will land, but that's certainly a threat to all of us. The more that access there gets cut back, but to your point, it is one of the things that that all states could do, state and federal governments, to enhance access to Medicaid, because that will have a real impact on individual medical debt.
So in our case, we opted that those employees that sign up for direct primary care, they have no cost out of pocket for that ever. We actually pay the entire cost for those folks. So that's sort of the first threshold in keeping that cost for them down. And quite honestly, it comes back to sort of math at that point. We realized that the membership fee, so to speak, that we would be paying for that was in fact cheaper than having to adjudicate claims if we sent them through the other side of the house. So it saves all of us money in the grand scheme of things, the organization as well. I will say we use a lot of integrated tools when folks end up having to navigate from the direct primary care to some kind of major medical thing. The first thing is that all of our primary care physicians will work with the patient to attempt to find particularly depending on what the circumstance is, and we also have a couple of referral tools for this to find locations that have the highest quality outcomes at the lowest cost that we can refer folks to. And so when you opt for one of those, it dramatically reduces what your patient contribution for the cost would be if you choose one of those options. You can certainly go anywhere you want to. We're not restricting folks' choice in this case. And even if you don't choose one of the recommended places, When you compare our plan design at this point, because of the lower cost model that we're using, to any other place, we have the lowest copays and the lowest out-of-pocket deductibles of just about any plan that we compare ourselves to anywhere else. So there are levers within the way that it's designed where we're able to sort of manage that entire cost for the patients when they're seeking care. I hope that helps clarify a little bit.
Well, believe it or not, we have to move on. Thank you all. This has been a great kickoff. Hope it whets everybody's appetite. Let's keep talking. So I want to introduce Chris Goodman, who's going to moderate the next session. Chris is Clinical Associate Professor of Internal Medicine at the University of South Carolina, and he'll be moderating the panel, What We Know About Medical Debt, a Review of Recent Evidence.
All right. Well, thanks for that introduction. I'm excited and honored to share a stage with these folks. There's a lot of knowledge here. We're going to spend the next close to an hour talking about the research or evidence base surrounding medical debt, what we know, and perhaps in some ways what we don't know. And we're going to spend about half our time in conversation together and about half our time in conversation with you all with Q&A. I'd like to make two small notes before I introduce our panel, just to plug the writing document that a number of us have been working on. That's meant to be sort of this omnibus document about medical debt. We have not finalized that document yet because we knew that this would be an important time together to learn together and sort out how we can improve on the document. A lot of you have already contributed as reviewers. So bend our ear, seek out me or someone from the Lown Institute, and of course we'll be listening and editing based on what we hear today. And then a personal note in getting started, I'm here in facilitating this panel with my research hat, I suppose, and I've spent time investigating charity care policies at hospitals and the role they play in medical debt, but I'm also a clinician, and I really appreciated some of the stories in our first panel because I think that's what drives us. I spend my time mostly in inpatient and primary care, and I see up close and personal the effects of medical debt with my patients. Did training at Emory. I practice at USC Prisma now. These are both large safety net hospitals in their areas, and I think to practice medicine, and it seems like it's more and more each day, is to encounter the problems of the cost of care in our medical system. Okay, without further ado, I'll introduce our panel here. We've got Fred Blavin, a senior fellow in the Health Policy Division at the Urban Institute. Kelsey Chalmers is the Director of Research and Data Science at the Lown Institute. Noam Levey is senior correspondent at KFF Health News and the lead writer on Diagnosis Debt, a multi-year project exploring the scale and impact of America's medical debt problem. And finally, Matthew Ray is the Associate Director of the Program on the Healthcare Marketplace at KFF. Fred, I believe you're up first, and you've brought a few slides for us. What can you tell us about the prevalence of medical debt and how big of a problem is it?
Yeah, thank you, Chris, and thank you everyone at Lown for having me here to participate in this great panel and for organizing everything, and for Arnold Ventures for their support. Yeah, I just wanted to provide a little bit more context on the medical debt problem and maybe hone in on a few of the data points that have been mentioned so far. So as this slide highlights, there is quite a bit of variation in estimates out there on the share of the population that has, or share of adults that had medical debt, and this is all estimates from 2022. So on the highest end, there's that 41% estimate that Vikas referenced, I believe, from the 2022 KFF Healthcare Debt Survey. And this is kind of the broadest definition of medical debt out there. So this includes medical debt or dental bills that are past due or unable to be paid, are being paid off over time directly to a provider, are owed to a bank, collection agency, or other tender, are debt that's put on a credit card and is still being paid off over time, or any debt that's owed to a family member or friend who borrowed that money. The other estimates out here, the other survey estimates from the SIP, the Urban Institute Health Reform Monitoring Survey, are lower, about 15 to 17%. And the SIP question captures whether or not an individual is unable to pay a bill in full during the past year. The HRMS measure at 15% is a similar question that asks if anyone in a family had any unpaid medical bills that are past due. A smaller share of the population of adults with a credit record had any medical debt in collection. That is at 12%, and that's based off of data from one of the major credit bureau agencies. And on the far right side is the kind of the most restrictive definition of medical debt on here from a National Health Interview Survey that found that 6% of adults had medical bills that they were unable to pay in full at the time of the survey. We also know that there has been a relatively downward trend in the medical debt problem. So, going back to 2017, from three of the measures that we just went over, medical debt, there has been modest declines in medical debt from 21% in the SIP survey down to 17%, from 2017 to 2022. A decline in that NHIS measure from 8% to 6% from 2019 to 2023, and a decline in the share of the population with medical debt and collections. And I'll expand upon that in a little bit and what we're seeing in 2023. This steady decline goes back even further. As you can see, starting in about 2014 during the implementation of the ACA and the Medicaid expansion, we see a fairly steady decline in the share of adults with any medical debt and collections from 18.8% in 2011 down to 13.9% in 2021. Now, there were some voluntary changes made by credit reporting agencies. I think the most impactful in this instance being, stop the ending of reporting of medical trade lines under $500. And that's really why we're seeing this very large decline in 2023, where only 5% of individuals had any medical debt and collections. Now, all those individuals had trade lines above $500. I also want to highlight a little bit beyond just the prevalence, just kind of the variation that we see in medical debt. So this is from a study funded by Arnold Ventures, where we highlighted some of the county level of variation and disparities in medical debt and some of the drivers behind this variation. So in this study, we found that that 99 out of the 100 counties with the highest prevalence of medical debt were located in the South. As is not a coincidence, 77 of these 100 counties with the highest levels of medical debt are in states that had not expanded Medicaid. An additional 12 were in counties that had expanded Medicaid 5 years after the initial expansion option in 2014. Also, as part of this analysis, we found that the strongest predictor of medical debt in the county is the health status, essentially, of the county, the prevalence of chronic conditions. We also found that other factors associated with high medical debt are the low-income population share of the population that's uninsured, the share of the population, and the share of the population that is Black. But by far the largest predictor that we had found was kind of the health status of the county. This is very consistent with individual level data. Oh, some of those aren't here. But individual level data from surveys on the SIP that looked at individual characteristics and looked at populations that are more likely to have medical debt. And those also found that, low income, race, ethnicity, health, self-reported fair health status, insurance status are all strongly related to the likelihood of having medical debt, not just medical debt and collections. And I think I'll pause there.
Okay, great. Thanks, Fred. That was a great introduction for us. And Noam, I think you've got the the challenging follow-up question to this that we struggled with in our writing group, and that's these wide-ranging prevalence estimates. Can you unpack that a bit for us?
Sure. Is that working now? Yes? No? Yes. Okay. So I have to apologize from the outset because the extremely talented members of our polling team could not be here because they're at a conference. So you're having to deal with the backup player here. But I'll talk to you a little bit about why we designed the survey the way we did and came up with a considerably higher number. And I would actually submit to you that part of the reason for that is precisely because a lot of the other measurement tools don't capture the real lived experiences of the way people are going into debt. And so, for example, not to dump on credit bureau data specifically, but for example, a very small subset of medical bills that people don't pay actually end up on people's credit scores. And that is in part because there have been changes in the reporting practices and the practices of the credit reporting agencies. But it's also just because some hospitals and a lot of providers don't report you if you don't pay your bill. So a lot, yes. And when we looked at hospitals, for example, we did a separate survey of the collection practices of hospitals. Only about a third of hospitals across the country have policies. I'm sorry, 2/3 have policies that allow them to actually credit report. I think the other thing to keep in mind is that there's an extremely high prevalence of, increasingly, and for hospitals in particular, of things like payment plans. People are signing up to pay a bill over 2 years, sometimes now even longer. There's a growing industry that handles this sector of revenue cycle management, as it's called, as I'm sure you know. People are asked, if you have a bill you're not paying, they might say, no, I'm paying this off. But I would argue you're in debt. You're in debt in the same way you're in debt if you're paying off a car over 5 years. Similarly, if you've borrowed money from friends or family, not typically maybe something that you would report I'm not able to pay, but extremely disruptive for the real life experience of I as a patient if I had to go to mom or dad or my brother or sister or what have you. So I think that, and finally, I mentioned credit cards. Because again, I don't think people necessarily, if they're asked about, were you able to pay this? If I put this on my credit card and I don't pay my credit card off as a regular practice, which as many of you know is pretty prevalent for us, we might say, well, yeah, I paid the bill. Never mind the fact that I'm carrying a several $1,000 balance on my credit card just as a matter of course. And so we designed our survey specifically with the idea to get at the real lived experiences of people out there. And that is why I think primarily our number was so much higher than some of the other survey data, some of the credit card data. And of course, we also include dental, and some other people don't include dental. So anyway, I'll stop there, but I hope that's helpful.
There's almost no easy sentence here, because when we say what percent of people have medical debt, we're not clear what is medical. Is dental included? What's included? What's not? What's debt? Is credit card debt? And who is the person? Like, is this debt for me? Is this debt for my cousin? Is this debt for some other people in my household? So it all becomes complicated. And how you prime the respondent and the way you ask these questions is what drives a huge variation we see amongst the federal surveys and KFF survey. I still don't think I'm on.
Well, just a little. I mean, one thing I know, like for the HRMS, the urban survey that we have, there are prompts similar to you. We ask, to include medical, to include dental, include medical debt that was paid on a credit card, for example. So they're not all, they do include a lot of these. It's not as explicit in terms of all the items that are in the KFF survey.
That's right. But I think one thing you can, and I don't want to hog all the time defending our methodology here, but if you do look at other data sources outside of actually some of the things that you mentioned, and particularly industry-based sources, you find that the frequency with which people are paying their bills is increasingly very low. So for example, if you look at research that's done in the hospital revenue cycle space, I was just looking at some research by one of these patient financing companies that found that currently the amount of patient bills that hospitals are recovering after they submit for insurance, so what the patient's responsibility is, the copay, the coinsurance, et cetera, like now it's down near a quarter. So think about that. 75% of what patients owe to hospitals now are not being collected. This is according to sort of one survey. And if you look at another survey that Gallup did, actually just asking just whether people borrowed in the last year, in the past 12 months, have you borrowed money to pay for a medical bill? You get 30 million people. So that's just in the last year, we found 100 million people have medical debt currently. So I think when you put all those constellations together, I mean, I'm obviously very invested in this being a big problem because I think it is. But I think Matt's right. It's complicated because you have to sort of get at these things in different ways. But I mean, I think we're all here because we think it's a problem. So in some sense, maybe we don't need to argue about it.
Well, Matthew, if you could carry on that thread that was started there about the different ways that debt shows up in someone's life. It's not just a number on a bill. What happens as a result of medical debt?
I mean, am I on yet? Okay. So, I mean, Noam should weigh in on this as well because he's written a small library of stories that talk about medical debt in people's lives. So if you haven't seen it, there's probably 100 or so stories to read up on. But, I mean, across the federal surveys, we know a fair amount about how debt affects people. I mean, it's pretty clear across every source that people in medical debt end up deferring care. And I think a big part of that is either they're afraid of the complexity of going into the health system and getting more debt, not understanding how to navigate the system, some of the issues we hit in the first panel. And we know that people who are similar in terms of race and age and income are more likely to delay and defer care if they have medical debt. Now, the harder bit, and there's less evidence, I think, but I think more people are working on this issue, is how medical debt impacts sort of household finances and what are sort of the long-term consequences to that. So the FinCar Foundation has a great survey called the National Financial Capability Survey. They find sort of just risky is probably the wrong word, but people in medical debt have astronomically higher shares of them are using what were called potentially risky financial instruments, using payday loaning for their banking, using pawn shops, 5 or 6 times more likely to use a pawn shop if you have medical debt. Sort of all that makes sense. And the other thing that sort of we're starting to see more evidence on is how it affects you over the long term, how incurring medical debt at one point will lead you to have less assets over time. So the panel survey of income dynamics sort of tracks how households who have medical debt even 10 years later end up with less wealth than a household that doesn't, holding constant sort of the litany of things that you'd want to hold constant in that. So, I mean, there's immediate sort of health impacts. There's sort of longer term financial impacts. Which households end up being able to finance the debt and which households are not really plays that out. I mean, one more point, just to jump on what we were just saying. The other thing that matters a lot here is how much debt you have and how capable your household will be at paying that debt off. So while we see huge shares of people who have unpaid bills, some of those will be able to finance it relatively easily, and some of them, even a small amount, will be enough to sort of derail them and spin into more and more problems.
If I could just add one sort of finding from our survey as well, was when we asked people whether they ever thought that they would be able to pay off the debt, people, not surprisingly, with high levels of debt say they never think they're going to get out from underneath it. Which, I mean, there's psychological effects to that. There are health effects to that. There are obviously economic security effects of that, which are pretty profound.
You got about 3 million people in the United States who have more than $10,000 of medical debt.
And this wasn't a topic that I think we discussed beforehand, but it's I'm curious, linking the conversation you heard before, thinking about ahead of what policy changes do you want to see? How meaningful is it to frame this as a problem that's worsening, or as a problem that's improving, and how might that impact the policy decisions that we make? I'm going to start with Fred on that.
So I just want to also kind of follow up a little bit on some points that were just made. So there are a lot of studies that look at, the relationship between heavy medical debt and other outcomes. I think, I don't want to turn this into a methods discussion in a panel, but just be cautious that a lot of these are just looking at correlations within the data, so that people with medical debt are more likely to have this, but it's not necessarily a causal impact. I think, there's recent evidence from an experiment from, Undue medical debt on loan forgiveness, and I think a lot of folks in this room are probably familiar with that, and found that, that experiment didn't have any impact on any positive effects on improving credit access, financial distress, or mental health on average. I think there are a lot of reasons why that could be, and it kind of maybe gets back to Noam's point where you have you mentioned 1/4 of medical bills not being paid at the hospital level. And so, like, why is that? Is it that is it gotten to the point where patients just they realize that there aren't necessarily consequences to paying their medical bills, or it's a lower priority in terms of other debts that they might have to pay off? I think that is potentially something that I think the authors have brought up as a potential reason explaining the results. And also, this forgiveness occurred a year after those loans were forgiven. So I think we're in an interesting space, though, kind of going back, that we do have this steady decline in medical debt problem. I think a lot of it is driven by the Medicaid expansion and certain policy choices, which, if certain decisions are reverted, or if Medicaid, if there are significant cuts to Medicaid, we can see at a point right now where there's going to be a rise in medical debt, and this is going to continue to be an issue moving forward. So, it's a little bit of both. I think we're on the right track, but it's since we're not really addressing kind of the underlying causes of it per se, it's going to continue to persist.
Thanks, Fred, and to keep us on time here, I think, Kelsey, you maybe have a few slides here that we'll look at that is going to dig into the role that hospitals and especially billing practices and policies come into play here.
Chris. Oh, yeah, it's on. So I'm here to talk a little bit about a project that the Lown Institute has been working on for the past 2 years, thanks to Arnold Ventures, as Vikas mentioned earlier. So one of the solutions, like probably a very small solution to medical debt, is hospital financial assistance policies and what they offer to patients who are low income. And of course, hospitals can sort of set their own definitions of who is low income in their communities. So this data set, we have a group of research assistants led by Paula Smith here at the Lown Institute, have visited 2,500 hospital websites, downloaded their policies, and extracted the data. And that is currently live on our website. You can download a spreadsheet and look up hospitals. But at the end of this month, I think on May 28th, we're doing a big launch of a new website where you can interact with the data a little bit more, look up hospitals. We collect information about their financial assistance income eligibility thresholds, which I'm going to go into now, and also on what their debt collection practices are. So do they engage with any extraordinary collection actions, or have they committed in their policies or in their communication with us that they don't do this? So I mentioned I was going to dig into the income eligibility criteria. So most hospitals describe this as, who can apply for free care. 100% of their care will be covered. They describe this as a percentage of either the federal poverty guidelines or federal poverty level. There's a little bit of a difference there. The majority of hospitals set this at 200%, no matter where you are in the country. It's just sort of a standard thing. There's a cluster of hospitals that set it really low, so you have to be below 150% of the federal poverty guidelines to qualify for free care. And then there's a really small group of hospitals that have quite generous policies at greater than 450%. That said, there are other eligibility criteria that's not included here, things like asset tests and other things that you can find in our data set. So I'm going to bear with me as I really dive into the data here. Each of these points is an individual hospital. On the vertical axis, we still have the same income brackets for their eligibility criteria for free care. But now we're looking at what is the median county income in these areas. So we were curious, do hospitals sort of think about who lives around them? Is it a poorer area? Is it a wealthier area? And you can see that there is a lot of variation here. So let's dive into those group of hospitals that mostly set the majority of hospitals which set their income criteria at 200%. And I'll just pull out two hospitals here. So we have, like I said, two hospitals, same income threshold. If you're at an average family making $53,000 a year, one of these hospitals is in an area with an income of $50,000 a year. So a lot of people in that area can apply for financial assistance. On the other side of this, we have hospitals, same policy, you know, they've picked it at 200% FPG. But it's in an area where the median income, I'm guessing maybe San Francisco, has an income level of $200,000 a year for the family. And this, you know, just to go back to this graph again, this variation goes in both directions. So we've got areas where the income is exactly the same. It's $100,000 across all these different hospitals and counties. And we have a hospital in an area where the median income is $98,000. But their income threshold is very generous for free care. A lot of people in this area may be receiving financial assistance. We need to link that data to be sure. And another hospital where the income threshold is set at $40,000 a year. And some of these hospitals are in the exact same area. So this is an example from where the Lown Institute is based in Boston. Two hospitals which are a 9-minute walk from each other. At Beth Israel, you can be a family making just below 400% of the federal poverty guideline, which is $106,000 a year, and still qualify for free care at the hospital. Meanwhile, at Brigham and Women's, you have to be making below 150% of the federal poverty guidelines. We've started to publish this data. Like I said, there's a database. Will patients be able to shop around a little bit? Maybe, but I think it's important for people to be informed on this. So I'll leave it there on the data, and please play around with it if you have the chance.
And Kelsey, we'll keep it with you. Why is this meaningful? Why does this matter for medical debt?
For medical debt, I mean, yeah, like I said, it's probably a very tiny solution, but we know that a lot of people fall through the cracks when it comes to people who could be eligible for financial assistance and don't apply for it, either because they don't get the information in time or it's too burdensome to apply. The hospital doesn't have things like presumptive eligibility screening in play. And the other aspect is that because there's no regulations in most states or federally on who can apply for financial assistance, and hospitals are able to set that criteria for themselves, we get a lot of variation, and I think that's part of the reason why people are able to fall through the cracks, because it's not consistent, because we don't have standard applications for financial assistance even. So we hope with the data, like, people take that meaning away of the variation. And when it comes to things like what happens to people with medical debt, so the collection actions, the legal actions, the credit reporting even, we hope that we can start to hold hospitals a little bit accountable as well as to what they're committing that they're not doing using this website too.
Yeah, thank you. Yeah, Noam, actually, I was going to pitch it to you.
Oh, well, I was just going to take one issue, Kelsey, with your characterization that this is a small thing, because I think this is actually really, really important. We'll have a whole panel on it actually coming up. But
it started with your original project on from KFF Health News, which had 500 hospitals roughly. So we've expanded that to 2,500 now.
Yeah, and I mean, I think hospitals obviously play an enormously important role in our system, and we know from the data that they're a huge source of medical debt. And I know that you've also looked at billing and collections, which I would also say, while most people are not sued or even reported to a credit reporting agency, it's hard to overstate just how devastating that experience is. And Vikas alluded to this in his introduction, that if you step back for a second and just think about the picture of a system designed to make people healthier, driving them to levels of stress that literally are killing people, I would argue it's actually vitally important.
Yeah, and expanding on that, I mean, we found that around 3 out of 4 adults who had medical debt owed some money to a hospital. So that just really kind of highlights that it's not just a hospital problem, but they're a major component.
Yeah, Fred, thank you. That was what I was going to raise too. We know where's this debt comes from bills. Where do these bills come from? And a large portion of it is hospital. I was surprised at how much was listed in looking at this data and with our writing project, how much came from labs or was listed as labs. But a lot of these labs now are also related to hospital bills as well. I think those were the majority of the sources of medical debt. The other side of the coin is insurance coverage and benefit design. Matt, do you want to talk about this one for a minute of how we know that the role that it can be contribute to or protect from medical debt?
Yeah. So what we know is that the vast majority of people who have medical debt have insurance. Obviously, if you're uninsured, you're more likely to have medical debt, but there are way more. 90% of people or so have health insurance, and we all know very well how many people have medical debt now, so lots of those people are insured. I mean, I think there's a couple of different pathways here. I think that there's sort of, you go to network accidentally, you go to network intentionally, you end up getting a service that's not covered, the dental bills, which may or may not be included in your medical package. But the other piece is the cost sharing. And what we've seen is sort of a precipitous increase in cost sharing over the last 10 years or so. So the average person with employer-sponsored health insurance is on the hook for a deductible of $1,500 before their plan pays for most things. If you've got a family, you end up having much higher deductibles. Often case, this is well in excess of sort of the typical assets that a family has. So of people who live by themselves with employer-sponsored health insurance, about a third have $2,000 in savings, all their assets put together. That's pretty close to what the average deductible is. So it doesn't take a lot in cost sharing for some households to really mess them up. And I think that's kind of reinforcing a lot of what was said earlier, is that people who end up with medical debt are people who, they use a lot of services, or they use services, and that's enough to hit them, especially when they have sort of high cost sharing. How plans are designed can make a difference here. And I do think I hear more employer plans thinking about what they could be doing to help low-wage workers with employer-sponsored health insurance, make the cost sharing more affordable. After so much talk of more skin in the game, I think there is general concern that we're spending so much on employer-sponsored health insurance and the plans aren't affordable for many people who are enrolled in them. There's lots more to say on this. I'm sure everybody has something to say on this.
Can I just add one thing? Because I think, Matt, some of the work that you're doing, particularly looking at the connection between medical debt and wealth, is just so important. Because we did some work looking particularly using some of the urban data to look at racial disparities in both medical debt and wealth. And we looked specifically at a community in Tennessee, Knox County. And, if you overlay we did, in this case, we looked at zip code data with Fred and Breno at Urban, and the maps of zip codes showing the concentration of African American communities and where the medical debt is are pretty damn close. And those are also places where there's not a lot of wealth. There's not a lot of property. There's not a lot of savings. And if you think about medical debt, at the end of the day, what medical debt more than anything else is, it's a reflection of not having wealth. I mean, you don't have the savings to pay a large bill, so you go into debt. And that with your medical bill, you don't. But I think one thing that people may not appreciate is sort of the cascading effects that has in people's lives, in the sense that if you're not able to pay your medical bill, you sink into debt, you don't go to the doctor, maybe you get sick, that hurts your ability to go to work, or it hurts your credit, and it makes it harder for you to buy a house and build wealth. And so you basically have a situation in which the burden of medical debt acts as this incredible weight on people's upward mobility economically. And I think some of the work that Matt's doing and others are doing too, looking at sort of these connections, is really vital in sort of understanding that this is more than just sort of an unpleasantness. It's actually playing a really important role in affecting economic mobility in our society.
Yeah. And on the other side of that burden coin is the price of healthcare. And so, yeah, you have low incomes that can be contributing to having medical debt, but also the high costs of medical care. And so, my colleague Breno Braga, also at the Urban Institute, and I, we're trying to explore what this potential relationship is by looking at the relationship between market concentration, which is associated with high healthcare prices and medical debt, and the share of the population with medical debt collections. And we found a strong correlation between the two, similar to some of the correlations that we found in our county level analysis, not to the extent of the health of the county, but some of the other markers that we looked at as well. And then on, beyond just the commercial side, when we think about Medicaid, I think it's been spoken about several times in the slide I showed earlier and in the previous conversation, but there's also really strong causal evidence on there on the effect that Medicaid has had in reducing medical debt, not only just medical debt collections, but other measures of financial distress that could be associated with wealth, accumulation of wealth over time. And so there's a couple authors, Kyle Caswell and Tim Wademan at the Urban Institute, and then others had a similar study and found that basically, Medicaid expansion, those who newly gained Medicaid under the ACA, for those individuals, it reduced their average medical debt collections by about $1,100. So that's for the lowest income, more vulnerable populations.
Okay, we're going to popcorn this question real quick. So one final question, and then we're going to go to our Q&A. And that's, what research or what data do you feel like is missing? What would you like to see? Where would you like to see the research go on medical debt? Fred?
So something that Noam and Breno and I have been trying to get is being able to link like credit bureau data with healthcare claims data to get a better sense of what events are triggering medical debt and get a much cleaner picture of what's happening, kind of linking the clinical and administrative side with the final outcomes in terms of medical debt and collections. We've tried but have been unsuccessful so far. It's kind of a difficult linking process and finding the right partners in order to do it, but that's one thing on my wish list.
That's on my wish list too. I'd love to see that.
Yeah, all right.
Let's work together here. I think that we talked a lot at the beginning about survey data, and survey data obviously has a lot of inherent weaknesses, but it is difficult to get this clear data from claims or what have you. One area that I sort of think a lot about is credit card data too, where we're just asking about it. We know tons of people are using their credit cards to pay for medical care, but it's very difficult. Even if you have credit card data, we had a sort of aborted, or not really aborted, but ultimately underwhelming research discussions with JP Morgan Chase Institute, and for a number of reasons they lost interest where but they were not super forthcoming with a lot of their data. But these credit card companies can get very granular in terms of looking at what people are obviously spending, and then more interestingly, sort of what happens to their balances afterwards. And I would love to, if I could wave a magic wand, get at that data somehow.
I mean, I think medical debt isn't one problem, it's a lot of problems, and people end up with medical debt for multiple reasons. And I think both of these solutions are doing the same thing. They're trying to figure out how do people end up in debt, and that's going to be what we really need to figure out what is the right policy instrument to solve the problem.
I'm just going to touch on two really quickly. One is, what is industry doing and planning that's going to impact medical debt in the future? So Chris and I wrote an article that came out this year just thinking about what are the consequences for AI in revenue cycle management. And is that going to be a driver of medical debt in the future if patients are sort of being kicked off their opportunity to get financial assistance because of these AI tools? The other thing, speaking as a non-American, is some country comparisons. I know the Commonwealth Fund does a lot of work on this, but I think there's like I don't know if anyone saw Donald Trump's speech on the pharmaceutical price executive order that he just made. And he told the story about how the pharmaceutical prices for Ozempic were a lot cheaper in the UK. And why was that? So there may be an opportunity there to stress some of those stories. Not to say that people don't have medical debt or unaffordable care in other countries too.
Can I just add one thing to the Kelsey? Because I think that's such a great idea to look at other countries, and I think particular people in the United States who may historically have been reluctant to look overseas are increasingly desperate and may actually be open to those kinds of conversations. But one of the things that we did when we started, speaking of gaps in the data, when we started our project, I was looking to find medical debt data in other wealthy countries. And so Germany doesn't even collect that information. And you would think the Germans, and I'm a German citizen, I can dump on the Germans here, but you'd think the Germans would gather this data, but they don't even ask about it because it's sort of not really part of the picture. And in the UK, where there is a very extensive financial security survey that they do, they have asked about debt in some ways. And the incidence of medical debt there is actually lower than the incidence of gambling debt in the UK.
Wow. Yeah. And I've used healthcare and participated in delivering healthcare in Mexico and Costa Rica, and very little conversation was being had about the cost of care, on both sides of that. And I think I'll plug one thing for data needs, and that's hospital data on people that apply in the screening process for financial assistance policies, just to kind of overlap on a theme here. All right, time for our Q&A.
Right, we see Bernita over here.
I just have a quick comment and sort of a plug for a later session that I'm moderating. But the other countries question, I'm glad that that's mentioned. We will talk about it later. I will add one caveat to Noam's point, that it's very important to look at non-wealthy countries as well, based on what you just said as well. Because even in my experiences in Ecuador, for example, this just doesn't even come up as a talking point. But stay tuned later. We will talk about other countries.
Hi, I'm Michelle Sternthal with Community Catalyst. Two quick questions. Has there been any disaggregation by facility fees versus actual fees, or looking at what proponent of those add to the medical debt? That's one question. The other is any data on cost of coverage or type of coverage as it relates to health outcomes. My dad is my focus group, and he, as a doctor, is from Montreal. And so they'll say, oh yeah, on the one hand, it'd be like, yeah, of course we should have a different system. But if we were in Canada right now, your grandmother might have died already because of the wait list to get on. So thinking empirically both about the cost, but then also the trade-offs, and to what extent are they actually real versus fear-mongering the data.
Who feels comfortable with that one?
I do not know of anybody who's trying to separate out the cost of professional fees and facility fees on how that's leading to debt. We do know that facility fees are going up for a lot of services, and they're going up for a lot of services faster than professional fees, especially for like EDs. So we've done a lot of work on that. So, I mean, if you want to make the leap in your own reading between what Fred was saying about prices and facility fees, that piece is done. But how that leads to debt, we don't specifically know.
Yeah, we don't have that information in the credit report data. We just know we don't even know if it's at a hospital or not. We just know it's medical debt. But that is something that we're trying to get at in a very early stages of kind of some proposal work in terms of getting more at side of services in terms of looking at utilization in like a hospital outpatient department relative to a physician office. How does that affect the likelihood of incurring medical debt? Trying to get more at potentially high areas that have high site of care utilization.
And I think the second question was trying to get at this linkage between cost of care and health outcomes, basically. Trying to return to that idea. Yeah.
Very sick people or other things, it's better to be in the US or there's a population level. And so just looking at like, where's the data to be like, no, actually, it's okay.
I can speak to that a little bit. Maybe not the Canadian experience, but the Australian experience. So I don't think the data exists. Again, we could add it to our study, which we'll do. With some funding, maybe. But on a population, I think it's, on a population level, it's not working in the US, but it works in other countries. But I have seen cases where if you have a rare genetic disease, if you have something, you raise money, you go to GoFundMe, this is in Australia, to go to the hospitals in Boston. But does that work on a population level? And it goes to Vikas's point before about earlier this morning. We could spend 100% GDP on healthcare. So everyone gets that intense level and prices skyrocket and everyone has every single healthcare thing that they ever want, but it doesn't work. And so countries do have to make those decisions and consider cost effectiveness.
I am Canadian, and my mom says exactly the same things. What we see with the data, at least, which I don't share with my mom, but we recently put out on our Peterson Kaiser Health System Tracker, is we see relatively similar utilization of the services people typically care about across sort of the OECD suite of countries. Use is pretty much the same for a lot of things. What's really different is the prices. So we just put this up, or this week or last week, or it's coming out next week.
There is some Commonwealth Fund. Here, but okay. There we go. Commonwealth Fund does actually do regular international comparisons across the dozens of metrics, and one of the sort of set of metrics that they do look at are outcome-based measures but their main one amenable to healthcare, which is a debate, as many of you know, is a hotly debated metric for measuring sort of how do you capture sort of what is the function of the health system versus the broader society. It tries to disaggregate those two, but it as I said, it is debated.
Hi, Ernie Davis with the Leukemia and Lymphoma Society. On the question of hospitals engaging a bit less in collection practices, I guess my question is, has there been any data in regards to the reason they're not doing it? And is it because they're selling the tranches of the debt to third-party collectors who are engaging in some of the more egregious collection practices?
So you're sitting next to two of the experts on this topic, so I should probably let them talk to you about this. But from a data perspective, I mean, this is one of the holes, as Chris mentioned, in terms of understanding not only kind of what hospital policies are, which is what we tried to do and what Kelsey's team has done a much better job of doing, but also actually what does that translate into in terms of what percentage of financial assistance applications are actually approved? What are the income levels of those people? And folks are trying to get that. I know $4 is also working on trying to get at some of that. We don't really have a good way of doing that. Some of this claims data is another kind of way to get at this. We really wanted in our research initially to try to understand, well, if we have a couple of hospitals in town, can we figure out whether or not like MedStar or Georgetown, or like I said, let's say MedStar or Hopkins are more or less responsible for putting people in debt? We just don't have that really good data for that. The interesting thing is that the data is out there because the revenue cycle management industry, which doesn't usually participate in these kinds of exercises, they just sort of run with a different crowd. They have this information, and for obvious reasons, they don't share it.
Hello, Marceline White, Economic Action Maryland. 2 questions. One is, when you are looking at the data and you're looking at the number of people who are using credit cards, are you disaggregating between whether or not they're using healthcare credit cards or more traditional credit cards? Because I think that is one thing we're certainly seeing in Maryland, and there are different challenges with the healthcare credit cards in terms of their use. So I'd love to see that data. And then secondly, this is a little broader comment, but at some point when we look at healthcare costs broadly, I'd love to see some sort of study about kind of opportunity cost. And I was just thinking about that because I just looked at my Care First insurance before I pulled this up, and I was like, for people with chronic health conditions, there's a lot of things insurance doesn't cover, so people are paying out of pocket. So, I was like, okay, if you're spending $7,000 over a certain number of years, you're talking about, hundreds of thousands of dollars of like opportunity costs or savings. So when you're thinking about wealth building, I think writ large, that's a pretty significant loss of income that's going to healthcare. So I'm just wondering, like more broadly, it would be interesting to see what that looks like for working families and everyone.
Yeah, on the first one, that's a question that we've been trying to get at, and I guess the short answer is no. Like we haven't been able to find data, at least with our credit bureau data or even on our survey data, just combined any credit cards, and we haven't even been able to get at medical debt that's paid on a credit card that's ended up going to debt and collection. So I don't know if anybody else has had luck on that, but I think that's an area of.
We asked in our survey about medical credit cards specifically, but it was sort of unsatisfying in the way that, because I'm not sure a lot of people understand necessarily that this is a medical credit card. Maybe if they have care credit, that's obvious, but yeah, it was sort of frustrating.
And thanks for that comment too. I was really struck by that story of the that we heard earlier about the pilot license, and that's where the money went. And that that's really got to come through good reporting and good qualitative data, and we need more of that.
Sorry, let's take the question down there first.
You sure? I'm okay waiting. Okay. So I'm Lauren. I'm from the Indiana Community Action Poverty Institute. We do some work at Indiana level for state advocacy for policies related to medical debt. And one of my questions, I have 2 here, related to kind of the low end stuff. Do you have any insights into why there is variability in charity care, like eligibility policies, not just at income level, but we do qualitative work. So you're mentioning that. We do that on medical debt, on low income clients in particular. And we find that there's still very much variability in the paperwork requirements. Like some require sometimes like their titles for their cars, their deeds of the house, like if they own a house, like some require tax returns. So any insight on that would be lovely. And also in relation to medical billing errors, we find that happens a lot in Indiana as well. I personally experienced that, triplicated charges in an ER visit for 11-day hospital visit. And it took me 8 months of arguing with the medical facility to get that adjusted. So I can't imagine somebody who's not in a position I am dealing with that. So any efforts that you know of how to define those duplicate charges as fraudulent charges. I know that there's been some efforts in Indiana, maybe just sending it to the AG's office and collecting information, be like, this charge, I'm not paying for it.
So any advice or insight on those?
I'll just touch on that first question a little bit. Not that I can't answer it, sorry. But I presented this data at a revenue cycle management conference recently, and I got the comment that, oh, I didn't know other hospitals set different thresholds. I thought we all did the same. So, yeah, I don't know how they make those decisions.
And I don't want to give too much away because I think Monica Kona from Georgetown is going to be talking about state policy, but there is a lot of variation in terms of what states are doing for their minimum financial assistance policy. So states have different minimum eligibility standards and different rules, specific rules in terms of who is eligible for them and specific, application rules.
And they can change it for different hospital types too as well.
Yes, most of them, some of them just apply for nonprofits, some apply to nonprofits and for-profits. So there's a really great report out there it's a Commonwealth Fund and Georgetown University fund that kind of goes at all the different state policies on that are out there and what states are doing in this area of financial assistance protection policies, but other consumer protection policies for medical debt.
Do hospitals vary within health systems?
That's a great question. You could answer it with our data, but we have not answered it yet. A lot of systems do have policies that cover all of their hospitals, although often you would find conflicting stuff between the system policy and what the hospital policy said if it was there. So which ones apply? We weren't sure. We had to make a decision at some point, especially if we were talking to someone at the system level who was telling us, no, this should apply everywhere.
I would say presumably yes, because especially when you have multi-hospital health systems that span multiple states, they're going to be under different regulations in terms of their financial assistance policies.
The other thing too related to that, and this happens with a lot of our data at the Lown Institute, is just mapping which hospitals belong to which systems. They're constantly changing. They don't update their policies in a timely manner either. So sometimes you'd find a financial assistance policy for a hospital and realize that they were no longer part of that system anymore. So it didn't apply.
I mean, in terms of data gathering, I know some of you here from state advocates know that, right, there have been discussions at the state level in terms of requiring more reporting by hospitals, not just of what their policy is, but actually what their practice is. I mean, as a journalist, I can say I'm just, rubbing my hands together, waiting for when and if that actually comes to pass, because then we're really going to see, why does the University of Colorado system only approve 10% of the applications they get, and why does another system 50%? That's going to be, I think, when you want to talk about what kind of information would move the needle, I bet that would.
I think we've got time for one last question, and I think Elisabeth was really working hard on hers.
I'll try and keep it quick. So, +1 on all the international. Lived and worked, practiced in Australia, obviously from another country where, has its problems. And a +1 for the Qualies commentary that you made, but that got politicized to death panels very quickly. My question to you is, the AI, I've worked on both sides of this. I worked with ProPublica on the PXDX piece that, showed that they were using AI to deny. I was one of those people. I fought and won. If we don't have both sides of the table here, and do we have anybody from the other side of the table at this conference, we're in a nuclear arms race of AI to use this, because we're using it on the other side now to fight those claims. How do we get them to participate in this? Because without them, I don't think we can solve this. Maybe I'm wrong. I'd like to be, but I don't believe so.
Yeah, you're absolutely right. I don't know that there's an easy answer to that,
Yes.
but certainly...
we're out of time.
Yeah, right. Yeah, things are changing rapidly with technology, and certainly AI is going to play a part in a lot of this, and hopefully we can bend it to our will in some way. That's part of what we're doing here. It's convening and finding ways to take practical action. So I'd like to thank our panel and for their time and their expertise.
All right, everybody, welcome back. Now I really get to control the situation here. I noticed that our next panel, I hadn't realized this before, but we get an extra 15 minutes. So just as I don't know if that's maybe because there's more speakers or because we're really going to stick it to the hospitals in our discussion of this problem. But we have a really great mix of folks up here to talk about hospitals and their role in the problem, but also the role they can play in addressing this issue. So let me go quickly down and introduce everybody. Fred Cerise, who you already met, CEO of Parkland Health in Dallas. Connor Coursey is the Senior Government Affairs Associate at Small Business Majority. Then Eva Stahl is the Vice President of Policy and Programs at Undue Medical Debt. Then Eli Rushbanks is the General Counsel and Director of Policy Advocacy at $4. And I guess when we get into the discussion, I'll ask you guys to talk more about what your organizations do. And then last but not least, Dr. Deepak Goyal is an internal medicine physician who's currently Executive Medical Director at Monument Health, which is a not-for-profit system in Rapid City, South Dakota. So we got into this a little bit in our discussion in the last panel, but I think one of the things that's great about this group is that we have sort of perspectives of folks who work a lot on the patient side and several folks on the provider side. And I thought for starters, we could sort of dig a little bit more deeply into kind of the experience that patients have financially when they go to the hospital. Because just to do a little bit of level setting here, we talked a little bit about charity care, about financial assistance, which, as many of you know, is a requirement for not-for-profit hospitals. It's more of a suggestion for everybody else, but nonetheless, it is common practice that most health systems provide at least some charity care. But I think everybody here would agree that that system is not working well for almost anybody. And so let me start with Eli and Eva to talk a little bit about kind of what you guys have seen from where you sit in terms of why it's not working for patients and how it's not working. So Eli, do you want to start? You work very directly in helping people try to navigate this. So tell us a little bit about $4 and kind of what you're seeing.
So $4 does a lot of direct services with patients, exclusively with hospital financial assistance policies. We have a screener that will screen for eligibility for any hospital in the country. We have patient advocates who will help the patients once the screener has deemed, yes, you're probably eligible at the particular hospital you went to. They'll submit the application, they'll help the patients gather documents, do whatever they need to do, and then all of the advocacy work, making phone calls, submitting the application a second time, a third time, a 10th time to get it processed by the hospital. And then we use our insight from working with these patients to do policy work around the country. What we see is that patients largely aren't applying for financial assistance. Like more than half, I think 51 or 52% of patients who are eligible aren't applying. The largest reason is they don't know these policies exist, they don't know these programs exist, or they fundamentally misunderstand what they are and how they might be able to help them. 65% of patients who are eligible and don't apply just said that they lack knowledge. 23% said that they were confused. Of the patients who do apply, like 14% of applications are never responded to. So there's a host of issues, but the biggest ones are patients don't know, and when they do apply, they can't get through the application process.
Eva, talk to us a little bit about, back up for a second in here and talk to us a little bit about what this is supposed to do. There was an idea here that there should be some regime that would presumably help people, right?
Sure. So I'm on the other end of the spectrum from Eli. So we talk to people as a result of debt relief. So we abolish debt in bulk by purchasing it from both hospitals in the secondary debt market for pennies on the dollar. And then we have an in-house anthropologist who is there to collect qualitative data and listen to the stories of the individuals we help, many times in long-form storytelling. But of course, the way that it's supposed to work is that people have an understanding that they are eligible and know that there is a possibility for some financial assistance when they enter into the system. We find too in our data, and we did polling with LLS and ACS CAN, that we have similar numbers that almost 50% of people don't know that financial assistance is an option. I would just highlight a couple of stories to illustrate this, and we had every Thursday we get stories from our anthropologist. She shares them internally. And one came across the other day from a woman named Christine. We abolished around $700 for her. And she works as a school teacher, and she has 4 children. And she did not know that financial assistance was an option because she was not told about it. But importantly, she didn't think it was for her. And we hear this story a lot, and that's because people are insured. And they think that their insurance is supposed to work, and it's not. So it is this, it is a predicament both in terms of thinking and believing that this is not something that actually is for you because you have insurance. But also then we had another story the other day from someone working minimum wage, which put them just above the threshold to qualify for charity care. So we also have sort of, and even though this person was insured. So we have this problem too of where these thresholds fall, as Kelsey pointed out, where people might just be on the cusp of being able to afford their care and they just can't. So we have an issue of cliffs as well. So, but in its model and in its intention, yes, it is supposed to be something that where the welcome mat is open, is laid down, right, and people can walk through it with ease. But it is logistically very difficult. And I would just highlight too that it was not necessarily designed in mind with having so many insured people needing this type of support.
And part of that is just because when we historically think about charity care, right, we thought about this being a system set up when we didn't have as much insurance coverage as we have today, right? And when deductibles didn't look the way that they do, right? Connor, do you want to talk a little bit about this from the perspective of your members? What kind of challenges do they face and for the people who work for them?
Yeah, absolutely. First, I want to thank you again for having me on here, and so thrilled to be joined by the real experts in this. So, Small Business Majority, for those of you who don't know us, we're a national small business advocacy organization. We represent primarily micro businesses, so the smallest of the small, those with 10 or fewer employees, and solo entrepreneurs as well. So the businesses that are more likely not to be able to offer healthcare to their employees, and solo entrepreneurs we know and small business owners are 3 times more likely to receive coverage through the ACA marketplace. So it's a large majority of small business owners in that solo entrepreneur micro business space that we represent. And I know most of you might be asking yourselves, what business do I have on this panel representing small businesses? It's because we can't really talk about healthcare without talking about small businesses, because the rising cost of healthcare is the #1 concern of all small businesses, or at least the ones in our network. We do national polling consistently that small business owners rank the rising cost of healthcare as their #1 barrier to sustainability and growth. And when you account for all the other barriers to growth that small businesses encounter, that's quite a damning statement. We've heard obviously the impact, or argued the impact of medical debt on credit reports. For example, Patricia earlier in the panel noted that the CFPB's effort to remove that debt from medical reports. We know that majority of businesses use personal credit in some form to get financing for the business. So the more likely, so when you pair rising healthcare costs, that puts more small business owners and their employees at a greater risk of medical debt. Pair that with the impact that debt can have on a credit report that ultimately impacts their ability to secure financing for their business. Just in recent months, we've talked to 2 business owners. One from Chicago who noted that her and her family recently incurred $60,000 worth of medical debt in the last year alone. She had to refinance her house or her mortgage, and she noted that she's going through a large chunk of her savings. Another business owner, she noted in 2016 that she had to declare bankruptcy because of the amount of medical debt she incurred, which completely wrecked her credit score and really put her business on hold for a number of years. And to kind of echo what Eli and Eva were saying, they just business owners just don't know about the assistance programs that are offered to them. So I think there's a real lack of knowledge and I don't know if that's, accounted for by the hospitals, the lack of, outreach efforts to the community. But I think, business owners increasingly, pin the rising cost of healthcare on hospitals. So in a sense, they think the hospitals are out to get them. So it's understanding why they wouldn't, think to go to hospitals for healthcare assistance, for medical debt assistance.
So we obviously do a lot of beating up on hospitals, which is fun. But there obviously are reasons why the system looks the way it does. And at least speaking from my own perspective, having met a lot of hospital executives over the years, they generally don't have sharp teeth and tails and what have you. But Fred and Deepak, can you talk a little bit about when hospital systems think about this system? And let's start, I guess, with charity care, and then we can think more about patient balances in general. How are they thinking about this? And it must not be a secret that this system's not working, but it's obviously not getting solved. Deepak, you want to start?
Okay, I'll go first. So there's I'm sure there's several things going on. One is, believe it or not, there still is some level of lack of awareness about these billing practices and the impact that they have. If you read Luke Messick's book, and he talked about going to his hospital CEO, and he's an ER doc who found out that his patients were being sued by their system, and he went to his CEO, and he wrote an article about it, and his CEO brought him in and fussed at him and said, that's not true. And he said, well, in fact, it is true. Here's all the court records, And so I still think today that there's a lot of people who they're just doing business. And, if you go to those rev cycle people, this is what they're trained to do. They're trained to collect. And so a lot of times I think that the leadership of the hospitals are not even that aware of the details of these the collection practices. I know when I started talking to you and diving into this a bit, I went to our own rev cycle people and said, tell me we don't sue people. Thankfully we didn't sue people. But as part of our collection practices, at some stage when we don't sell debt, but it would go to an agency at some stage, and they would report to credit agencies. And so I didn't know that. So now we don't. But I'm probably more interested in this than 99% of hospital CEOs. And so I don't know that there's enough awareness there. I mean, that's so our fault. But I think that's part of it. Another part of this, though, is we work in this system where, for all of us, perhaps for different reasons, but we still have to have patients prove that they are worthy of some kind of discount or free care, right? Other hospital systems may have their own reasons. I work for a county system. And so we need to show we tried to find a funding source for someone. Are they eligible for Medicaid? Are they eligible for insurance? Are they eligible for the exchange? If they're eligible for the exchange, why haven't they applied for the exchange? And what are we doing to make sure that they have coverage that they're eligible for before they come to the county for the funds of the county to support their care, right? And so it makes it complicated. If they haven't applied, why haven't they applied? Well, they're in between eligibility periods now, enrollment periods. And so they still need care today. Every hospital is going to provide emergency care because you have to, but they're not going to provide the other stuff that you don't have to do to treat and stabilize, which I think is a big piece that we haven't talked about yet, but that is, someone has a mammogram that's abnormal, and they're in between enrollment periods. This idea of application for non-emergent or elective type stuff, that person is generally not going to get care unless they they come up with their portion of the copay or their deposit up front, So if they have an abnormal mammogram, they're not going to get that unless, their extra views or their biopsy. And if their biopsy is positive, their chemo and their surgery. So these are all kind of barriers that are put in place. by, again, the fragmented system that we have. And so hospitals are they're going to look to, for their various reasons, to see what are the other possibilities of payment. For me, it's the county. For someone else, it might be their shareholders, to try to ensure that they've exhausted all that before they go to this charity care piece. And that ends up becoming a big burden on patients along the way. And you have different practices like, well, let's not advertise that we do this, because if we do that, we'll have less success up front. And so it creates a lot of sort of, dysfunctional behavior.
Does that jive with your experience, Deepak?
Yeah, first of all, thanks for having me here. I'm honored to actually be sharing the space with experts and the great work you're all doing. So I work at Monument Health. We are a healthcare system in the western South Dakota with our patient outreach into Nebraska, Wyoming, and Montana. And I'm a doctor, so I love to diagnose and treat. And I got myself involved into rev cycle management almost 4 or 5 years ago. And I diagnosed that our system is suffering from a phenomenon called tragedy of commons. Anybody aware of that? So that was an economic theory. When people think that resources are plentiful, even rationally, they tend to, as Dr. Saini had said, we care for patients, but also we do things to them, and without the mindfulness of cost. And the system we have is stacked very, I think, oddly against the poor people who actually deserve all the system that we have set up for financial assistance. They don't have a negotiated rate. They don't have advertise that you have all those things lined up, even though it's mandated by the federal government. And what I came to realize that those patients are suffering almost unbelievably high as compared to rest of the population. So I took on myself to design financial clearance process, which he was talking about, where clinicians make decisions as to how the care will proceed and how the financial aspect will be decided. And that's where it led to my discovery of that, how fragmented the system is. We have, this initiative of charity care or financial assistance per se. Charity care has almost a negative connotation to it. The financial assistance program we have, it has been pushed to a corner, like the very far end of the whole management. Actually, it is a part of the clinical care. When the patients have unpaid bills, they're not going to follow with the doctor when the care is needed. Then that care gets pushed to emergency care. Then that is way more expensive than the regular care. Then it gets to more medical bills, more bad debt, and it also creates strain on the people who are actually financially able to pay, the payers. So it's not a moral imperative that we have to solve this situation. It is a strategic advantage, in my opinion.
And so just to build a little bit on that, as you were trying to engage in this, what was I assume this took a little bit of time. What did you run into? And I mean, why your hospital, Fred, your hospital, most hospitals are set up to help patients, and yet here's a system that is clearly not working for patients. Why couldn't you just snap your fingers and fix it?
Hospitals get undue blame that hospitals are not doing enough, but there are some barriers which we have to understand. I would think there are 3 things that are creating those barriers. One is resources. It takes resources, and hospitals are already cash strapped. Where to deploy resources? There is so much of variation in interpretation of the rules from IRS. There is a regulatory burden onto that. Hospitals are concerned that if I say go above and beyond, is somebody going to come after me and going to say that it's an inducement? So that's another thing. And third, obviously, there is a financial constraint that, if we let go of this program or if we go above and beyond, is it going to decrease our collections? Is it going to create a challenge for financial sustainability? I think all CFOs would have concerns. And we have removed the clinicians, doctors, nurses from this process of discussing finances with the patients. First, they don't have time. Secondly, we don't want them to talk about money. So that we have an inherently disjointed system, in my opinion.
So, Eva and Eli, do you want to jump in here? You've worked with a lot of health systems in different contexts. What are your observations about what's stopping them from making this system work better?
So I would concur with that. That's a lot of what we hear is, there's regulatory constraints, and I think there's a lot of concern around revenue. And I think that, if we look at what's happening right now in the district, right, those concerns are just going to continue to increase. We actually are working on a small project with the Healthcare Anchor Network where we're convening a set of hospital systems to bring together leaders of revenue cycle and leaders of community benefit. And in those conversations, we're learning a lot about how these groups don't often communicate with each other, but need to because they don't speak the same language and they don't always share the same goals. But they can find solutions that we're finding where they can actually both reach their goals. And that's maximizing revenue where it makes sense and also making sure that you're addressing community need, because I don't think that they actually see each other and don't see those things working hand in hand, and they actually can. But there is a lot of fear around revenue, and there's a lot of fear around moral hazard, which is the inducement piece, is mostly what we hear.
Eli?
Lawyers saying no when they should be saying yes. So I'm definitely going to agree with you on that.
So the lawyers have tails.
I'll be the self-hating lawyer in the room. You all don't have to do it. And I think there's a lot that Dr. Cerise talked to about the executives in the room not knowing what's happening, but there's so much. It seems like from the outside looking in, it seems like there's so much siloed off sections within these organizations. I mean, these even like a single hospital is a pretty big operation, and the revenue cycle folks are churning along doing what they do, and the doctors are off churning along doing what they do, the accountants are off like doing what they do, and these entities, like especially in the rev cycle space, I'm maybe like struggling to figure out the words here because it's so they're looking at all this from such a 1,000-foot disconnected view from the actual patient. Like the doctor's seeing the patient, the revenue cycle person isn't seeing the patient. They're not even really the billing department. That's like a whole other separate group of folks. The revenue cycle folks are, you can see it in the terminology that they use, like revenue cycle management. I mean, what they're talking about is like charging people and collecting the money. They use these terms like charge capture, which is just like, another term for that could be price gouging. They use terms like reductions in accounts receivable. That's just squeezing more money out of patients. So they're doing their job, and they're probably doing it well, and like that's part of the problem. There's this problem of, I don't even necessarily want to say it's a problem of incentives because I don't think anyone's telling them to do that. It's more like a problem of inertia. Just no one's stopping them from doing it, if any of that makes any sense.
I think it does. So maybe can we differentiate between kind of real versus perceived barriers? Because I think it's worth maybe, I know this is a very knowledgeable audience, but maybe going a little bit further into the problem of inducement, which, I mean, there are laws in Medicare and insurance contracts that dictate sort of cost sharing and the requirement to bill. I mean, that seems like something very real. I also find talking to revenue cycle management folks that sort of everyone has a story about some tech bro who's going to roll up in his Ferrari if you don't charge the $150 copay. And, my sense is there are not that many of those dudes out there, but maybe not. But like all of you who sort of work in this system, what's real and what's imagined here in terms of barriers?
I mean, I think there are innovative things happening. And I think that that some hospitals are sort of catching up and that they can overcome some of these barriers. And I think we can talk a little bit about, presumptive eligibility and what are those tools and how they're being deployed. But I think what you can't escape is the increasing complexity of the landscape, right? So I think that Patricia put it really well, like this is crazy complicated. And the way that the workflow, if you really want to get down and dirty and you think about revenue cycle and how the workflow actually operates, when a patient walks through the door and they're uninsured, it's a simple sort of, oh, we should move you to financial assistance, or we should at least try to screen you and move you swiftly into financial assistance if you're uninsured and you qualify under the income threshold. If you're insured, there's an assumption that you can pay. right? And so it's much later in the workflow when you're going to try to figure out whether somebody may or may not be eligible for financial assistance. And we have to figure out, and we can figure out how to get over that hurdle. I think that, where the conversation is shifting, which is, I think, healthy and important, is around what is needed. Everything's anchored in income, right? And we've asked hospitals to be income verifiers. That's something usually the government does. So it's just, I think it's important to recognize that hurdle and think creatively about how to address it.
So Fred, Deepak, is that a real burden that you as hospitals need to be in the business of assessing people's financial wherewithal basically on a every patient basis?
It is like the worst part. It's the thing that drives me the most crazy at our place is that. Because our doctors, they just want to treat people that come in, right? And then this idea that you've got to be responsible and be able to sort of verify that somebody fits in the right bucket to be responsible and take care of them. And so this issue of having to verify income, to prove income, creates just an endless amount of work that ends up delaying access. And you'll hear stories like, I had a nurse about a year ago in one of our clinics who was lobbying for, we'll get these special cases to then change our policy around a special case. And, she told me the story, some woman who came in and said she needed a particular procedure. And she said, I can't document my income. Everything is in my husband's name. He gets paid in cash. I'm not going to be able to document that, right? And so that's one story, but it, multiply it times 1,000 times, because with whatever level of complexity these applications are. So yeah, it's a real thing, and you end up, like we do these endless workarounds. The doctors figure out workarounds. They'll admit people to the hospital from the ER that don't need to be admitted because now they're in and they're going to get their stuff done because they're afraid if they say go home and follow up in clinic in a week and we'll address this, then that they won't get past the financial screen. Some of them legitimately, a lot of them not legitimately, but they don't understand the process. So, it creates dysfunctional workarounds as well. So, yeah, it's a big piece of what we do, and it creates barriers.
Working? I completely agree. The thing is, we have created a system, and again, there is no point in bashing rev cycle people because they are doing what they're programmed to do, right? That's a system we designed, the system we created. And what we did at our place, we recognized all those things. Again, I'm not trying to come up with solutions. What I realized is there is a variability in understanding. The clinicians understand when we say the word financial assistance, they have a picture in their mind that might not align with the picture which operations have in their mind, which might not align with the picture which billing people have it, or it might not align which a CFO has in mind or the lawyers have in mind. So we created a very one-page algorithm from the very start that service emergent or urgent. If it is emergent or urgent, money is not the matter. We provide service. But if it is elective, we go through this algorithm. Patient has insurance, no insurance, qualify for insurance, ACA, does not qualify for financial assistance, qualify for charity care, end of story. So I think the point I'm trying to make is the more we move this process to the front side, align with the clinical care at the first point of contact, not all the way to the back. I think this is where a lot of disjoint lies. So we beat this idea to clinicians, to our doctors, to our operations people, to our logistics, to our rev cycle. So everybody's on the same page. I think that's where the change starts happening, in my opinion. And that's where the cause of and even at a fundamental level, it starts at the medical schools and nursing schools. We are not taught. There is no class on finances or patients' financial assistance in medical school. I've been to 2 medical schools and there is none. So I took it on myself. Actually, I took a class with the medical students. On 3rd year, it does not get tested on USMLE. But I took a class and I'm talking to the dean of the university that can we make it something that clinicians are aware that how to help the patients.
So I think I mean, not surprisingly, when we're talking at an event about American healthcare, complexity comes up as as a major barrier. I mean, so are we agreeing that a simpler system for assessing patients' ability to pay their bills would go a long way, probably, to addressing at least part of the problem, right?
Absolutely, the simpler we can make, because what's happening is, the guidance is that you should have a financial assistance program and a policy, and it should be on your hospital's website, and it does not absolve people of the responsibilities that, once we have done that, is it the end of the story? How do we apply those rules? I think that becomes to an individual level and individual hospital level, that how do we interpret those rules and how can we go above and beyond? And also there is no incentive, not even a recognition, more fear that if we do something, are we going to get caught in this jam?
Eli and Connor, both of you talked about sort of the challenges that patients have filling out this stuff. One thing that I've always wondered is, what is the rationale for having all these different standards for applying, not only qualifying, but then applying? Well, that's why we have you on the panel. But I mean, the part of this exercise is waving a magic wand. And is there a reason why there shouldn't be a more standardized system for getting assistance?
No, I think there should be a standardized system. I mean, I don't know if there's anybody who works for government agencies in the room. Probably, I'm not going to ask you to raise your hands, but please just start opening this data up for hospitals to use, tax return data, Social Security data, who's already enrolled in Medicaid programs. All of this data could be used to screen people for eligibility for these things. Right now, all of the burden is on the patient to learn about these things, to gather all these documents, to get through this whole gauntlet process that takes our trained patient advocates often months to get through this process at the hospital level for all these reasons we're talking about. If there was just an API where they could just, the hospital systems could just check at intake, against government data, is this person eligible? It would not just solve this problem, but a whole lot of other means testing issues across the country. So I guess if I can, grandstand for a second and advocate for that. I don't even know if this is answering your question.
No, it is, absolutely. I want you on the grandstand. Yeah, go ahead, Fred.
I think that would go a long way to one part of the problem. The other part of then you've got the data, so you can make a determination. The other part about standardizing, what are the expectations, would get a lot more people into the game at that point. Because right now, the example in Boston, where if I'm Beth Israel, do I want to put up a billboard that says up to 106% of poverty, you're good here? Or if I'm at Brigham and Women's, do I want to put up a billboard saying at 106% of poverty, you're good over there, right? And that's what, whether it's valid or not, every one of these rev cycle people are going to tell you, if we make it too easy, then people are going to selectively come to us, and it's going to be a disadvantage. And so if you had some common standard, then you take that away, and I think you'll get a lot more uptake quicker.
But in fairness, then you also have the rural hospital that says, I can't be up to 400% of the federal poverty level because that's my entire community, versus, a more like city setting that might, it make more sense. So we hear that a lot too.
Yeah, absolutely.
And certainly that, setting uniform standards has been a subject of quite a lot of debate in some of these states that have tried to set minimum standards. But I mean, what can we say about have we learned anything so far in those states that have in fact set floors? Or, I mean, many of these states that have done this have rural hospitals. They also have Cedars-Sinai on the west side of Los Angeles.
I mean, I think that's more of a Fred question.
Well, I mean, I can say, you certainly have groups with very big differences in what their capacity is, and so that's another. Now you've introduced a layer of complexity into a standard. But what is that? And then you've got, every state pays hospitals for uncompensated care in some form or fashion. And oftentimes, if you look, it has no relationship to the amount of uncompensated care that the hospitals are delivering. And so, now we're just making it up here, but I mean, you have some levels of standards that you match with your uncompensated care policies and reimbursement policies that cover a portion of those costs. One of my frustrations with just in general with our sector, organized medicine, hospitals, doctors, is we've traditionally opposed universal solutions, right? You go all the way back to Medicare, where we've opposed universal solutions, and then because we love the private market and optional services, but then the people that fall out, we were going to look to the government to pay for that piece, and we don't want to do that, and because we need to get paid for it. Now there's something there. You've got rules like EMTALA that say you have to treat everybody that comes in the emergency department, but by the way, there's no rule that says they're all going to be insured or that you're going to get reimbursed for it, which ends up feeding more of the dysfunction and the high cost because now we're going to cost shift and all that. So I think you have to look at perhaps categories of what hospitals, what standards you can apply, but then on the reimbursement side, if you just do this without paying attention to that, then you're going to have a revolt and probably not get anywhere.
I mean, the related question in terms of standards and behavior has to do with collections, of course, and states have obviously made some efforts to limit more aggressive kinds of collections too. And this also goes right at a perception by hospitals and revenue cycle management people in particular that if you don't have a stick, people aren't going to pay their bills. What do we know about how real that perception is? Anybody?
It's not real. I think there is some truth, but not as much as as is perceived. So we have this that people, once we have this, if we make this too easy, that people are going to abuse the system, or all the people who are into some sort of financial assistance are gaming the system, and that's not true. So when we looked at our data, I don't know if I'm supposed to share or not, but our collection rate was 10%. After the account has been turned to collections, it was 10%. It means one thing, that 90% of people are not able to. It's not a question of willing to. It's a question of able to. They are poorest of the poorest people, and all those challenges that have been highlighted, complex process, patient-initiated process, lack of knowledge, and all the hoops, the asset testing. Some of them don't even have a permanent housing, and we are sending them the bills in mail. How do we expect them to follow the system? So this is where I think, from my standpoint of view, and our hospital is not special in any way or form. I think when I say 10% collection rate, I am assuming it probably applies to all other hospitals. There might be 2 standard deviation left, right? So this is the amount of, I think, problem we are dealing with.
Anybody else want to weigh in on the real or perceived problem with patients not paying if they don't face dire consequences?
So we hear from patients all the time, like we're the ones pushing patients to apply for financial assistance. By the time they found us, they are like often pretty desperate. We have patients push back on us a little bit, largely out of like shame for not wanting to pursue financial assistance. In fact, 10% of the people in a survey that we did who were eligible but didn't apply for financial assistance reported that the reason was that they were ashamed to apply. So the idea, like from what we see from working with patients, we worked with, 35,000 patients or so far. It doesn't track at all that these are folks that are just trying to like game the system or get out of some bill that they could otherwise pay. It's often like a very difficult thing for them to do, to raise their hand and ask for help.
Fred, you said you stopped credit reporting once you learned that you did that. Like, what happened? Anything?
Yeah, I don't think anybody noticed. I really don't. We didn't go back and look. You know what I mean? We just, whatever our collection group was, we just said, don't do it, and cut it out.
But the CFO didn't come knocking on your door and said, Fred, what the hell are you doing here?
It's interesting, it's because we're about to run another experiment in our oncology clinic where, do we really need to sort of re-up people for eligibility while they're, undergoing courses of therapy? It's going to take several years. because you're not going to stop anyway. And we want to look to see what kind of impact something like that happens on your actual ability to collect, because we just, there's so much of what we do that probably your bang for the buck is very little. But we haven't studied it a lot.
We started a program. I don't know if it is the right platform to talk. Presumptive charity care means we started an automated system, and we noticed that difference. We have not been reporting our patients for almost 4 or 5 years to Credit Bureau, and we noticed this change of, it's not a lot, but 2% change. Our collection has gone to 2% higher. So it means that we were screening appropriate patients, and that was the concern my CFO had, that are we going to decrease our collection? And once we have this, I think everybody felt encouraged that it was the right thing to do from the start.
I mean, I think that's the point, right, too, is what are people actually able to pay, right? So we see this a lot in our data as well. So as you know, that when we buy a portfolio of debt, the majority of folks in those portfolios qualify for our program, which is under 400% of the federal poverty level. So, we see, I think we also need to be having a conversation of what, to Connor's point with small businesses, like what are people actually able to pay? Because a lot of people are being stretched and pushed when these thresholds are too low, right? And they're put into categories that, they can't pay these bills. And I think that's a concern with the growing rise in payment plans too, right? Is that people are entering payment plans when they couldn't actually pay in the first place.
Connor, let me ask you a little bit to follow up on something that you mentioned earlier about the way that some of your members actually think about hospitals, because that's something certainly that struck me in my reporting. I still remember interviewing a patient in California who, after going through some nightmarish billing experience, said, "I feel like the hospital's a predator, and like I'm not going to go there." Are you picking up on this feeling that people no longer see a hospital in the same way?
Yeah, I think so. And I mean, if you think about it, I think it makes sense. There you have the most face-to-face interaction with hospitals. You think that you're giving hospitals their money as opposed to the insurance companies. But in the past, actually, we've asked this question in Cerise for multiple years, and it has usually been, obviously, insurance companies are bearing the brunt of the blame, but now hospitals have steadily risen as well alongside that, along with the drug providers, of course. So I think it is interesting. I think, and we know around 50 or 60% of small business owners said the cost of their hospital visits have increased year over year in a survey we did last year. So I think it is, their face-to-face interaction with hospitals definitely plays into that. And I think, obviously the costs are rising, right? And, they're getting the bill from the hospital, or so I think that's kind of where their sentiments lay.
I know I want to get, I'm sure a lot of you have questions, but one last question to throw out to all of you guys. And again, I'm picking on our two hospital execs here particularly, but open it to everybody. I wonder from a sort of advocacy and strategic standpoint, whether when we think about what would actually change behavior on the part of providers, I think there's an assumption in the media, I think, that, well, if we keep writing stories about all the terrible things that hospitals do, that will prompt people to, stop suing or stop putting liens on people's homes. And I think there's some evidence that happens. But it's also true that all of this negative attention, I think, can also foster something of a siege mentality, right? Where well, why is everybody picking on us? And we don't design high deductible health insurance plans, and may make it even less likely that people in the hospital and the provider community are willing to listen and willing to engage in a discussion about this stuff. And I guess I throw it out to everybody. As you think about, one of the reasons for this gathering is to brainstorm ideas and think about how we can have constructive conversations with all stakeholders. How do we walk that line?
So I think the hospitals get a little bit of this unfair treatment in a way by saying that, hospitals are predators. I think it's going too far, because people who work in hospital, everybody wants to help. And this definition, very definition of charity care or financial assistance, it is defined by IRS, but most hospitals have to go above and beyond for that. The term is community benefits. You need to, for example, we would have a neurosurgeon on call, and there might not be a single case of head injury. So where does that money go? We have to maintain capacity in the hospital. So those things also go in community benefits. I think hospitals get this, and there could be this mentality. When you have this negative press against hospital, they tend to dig in their heels. So the solution, in my opinion, is again education, because people want to help, but how to help is the question, and that's where discussions like this play a big role. When we have business, hospital business people, executives, clinicians, policymakers, advocates, I think all in the same room, solutions would come. And we took a small attempt in our hospital to make a small change. And there is actually a strategy called oil blotting strategy. It's when you're an insurgent, how do you make a change? And maybe at some other time we'll talk the details. But once the change starts happening, and I see this change happening right here in this room, and more hospitals will learn and things will get better.
Anybody else want to take a shot at this?
I mean, you're asking from a hospital perspective, what would get people to engage? I've reviewed a number of responses to you, Noam, from hospitals that did not appreciate your stories. So that pressure campaign, I think there is something. There's something to be said about raising awareness. I mean, and that is effective up to a point. But I do think you end up with that siege mentality of this is we're why the hospitals, because there's so many other things contributing here, right? There's the insurance companies, and there's drugs, and there's you name it, right? There's a lot of other pieces to the system, and so it creates that that mentality. So how do you break through that? That's a tough one. I mean, I think because ultimately, in you say hospitals, but hospitals, as Eva just pointed out, that's a very broad range of things. You've got places that really do struggle and can't afford to not get paid. In Texas, we got probably more rural hospitals going out of business than anywhere else in the country. And so you do have that end. And then you've got, like in Dallas, which is a very expensive market, and some big systems doing very well. And so, that's the spectrum. So, how do you engage hospitals? It's it's not a homogenous group from to start. But then I think pulling in the other players too, which is very difficult because part of this price escalation is the insurance company, hospital, competition that goes on there. Hospitals acquire scale. Who talked about antitrust? Vikas, I think early on, we create scale so we can drive, get market share, drive prices up. But ultimately, you're going to continue to have the hospitals will say, well, it's not. Why do you come to us and not the insurance companies or the drug companies? It's always the ability to point elsewhere. And so, without including all the different pieces and the fact that we've got after all the pieces are included, we still have a health system in this country that leaves out the significant chunk of people who are either uninsured or underinsured, and then that becomes a health policy issue. So you've got to include that in the discussion as well. So I guess to get hospitals engaged, I think pull another, the group to the table, and then we'll all point to the government, I'm sure, and say that's the problem.
Eva?
I would just add one more, which is clinicians. I think that clinicians have a role to play. And we did a number of focus groups with clinicians last year. And I mean, they're very frustrated and overwhelmed because they're so close to the issue and dealing with their patients. And I think that much like you've noted around being a clinician yourself, right? Like bringing that financial experience into those conversations. I know that some are very adverse to that, but I think that that's part of people's health is their financial security. And so finding ways to have more of those conversations because physicians have more power within the system, that they can be influencers and important messengers. And then I would say second, we also need to find those best practices and encourage hospitals to share them, because they're often under lock and key as they try to figure those out. And that's because they're afraid of showing up in one of your pieces, right? So it's also trying to make sure we're creating those spaces where we can figure out what those things are and celebrate them so that they can be replicated.
Either of you want to jump in? Eli?
This comment isn't going to make the policy work I do any easier, but I think getting individual hospitals involved in policy conversations and getting the hospital associations as far away from policy conversations as we can, I think would help a lot. When we're working on bills, it's usually us and a bunch of advocate groups, and then there's the hospital association on the other side. And when that's the framework, it forces the hospital, so the entire hospital association to have like one stance and one position. And as we're hearing, it's a very diverse group of folks. I mean, that hospital association has to represent the large, massive nonprofits, the for-profits, the rural hospitals, and distill all that down into like one single position. And I think it leads to extremely watered down at best and ineffective policy at worst. So just bringing more, I don't know whose responsibility that is to get those voices in the conversation more, but that would help a lot.
Starting with the last word.
I don't know about the last word, but I'll agree with Eva and Eli. As an advocate myself and at Small Business Majority, we try to give the microphone to the small business owners as much as we can, and I think that holds true here as well. Bringing clinicians, bringing patients, bringing hospitals with success stories on financial assistance programs to the table as much as possible, and shining a light on those success stories, those best practices, on the impact this has on clinicians is obviously would do wonders for spreading awareness and providing examples for other hospitals and networks around the country.
All right. Well, I know we're standing between you guys and food, but I'm sure there are some questions.
We're down a couple microphones right now. So they're doing a tech reboot at lunch. But for now, if you can use the podium mic, and I'm going to run this around for folks. So, okay.
Hi, my name is Kelly Folkers. I'm a health attorney at the Community Service Society of New York. I have helped hundreds of patients apply for hospital financial assistance, saving people millions of dollars in the last 2 years. I just want to address the framing on hospital financial assistance in this session, which is not specific to what I've seen here today, just in general. I really dislike the term charity care. I don't like references to people gaming the system. The reason for that is hospital financial assistance is a legal obligation under the ACA and multiple state laws to help middle and low income people. When I tell people this who have insurance or who are uninsured and who have shame, it immediately evaporates because they understand this is a right I have as a consumer and people want to be treated fairly. I think that's a core value in this country that is eroding, but there is a real need for more procedural justice, and that is what hospital financial assistance is. Everyone has the right to apply, even people who aren't presumptively eligible. There are ways that they have a right to appeal. They have a right to explain their circumstances. So I think there's a really big disconnect between how we as consumer and patient advocates and then the people that we help see this and how hospitals and certain other groups are seeing this. And at the end of the day, this is a legal obligation to help people. It's not charity. It's not a system that can be gamed, really, if it's done fairly. So I don't really know if I have a specific question on that. I just wanted to point out our experience with this and also just, see if there are any responses to this framing and if there are any ideas about how we can bridge this gap between what we in the advocacy community are saying and how hospitals and other players are seeing hospital financial assistance.
I think it's more of a statement, and I completely agree.
Hi, Vardan Shmamian from Los Angeles County DPH, leading our efforts on improving financial assistance in California. And we did that, just brief background, multi-pronged approach, immediate debt relief, working with Undue, connecting with people such as Eli, Dollar4, and other national stakeholders to get feedback on how we can improve the systems, and set up a best practice committee that's coming up with uniform model documents for hospitals who want to voluntarily use it. But what I was going to say is the biggest thing that gets lost in California, we have a minimum of 400% of FPL, and it's publicly subsidized. So you save money on property tax, sales tax, and other incentives. So you have this social construct of, hey, we'll give you these breaks, but if someone can't afford their care, you'll operate in good faith. So, and just to ask Fred a question, what was the financial difference after stopping suing people? Like, was there a noticeable difference when you stopped going after patients?
Well, we weren't suing people, thank goodness, but it was reporting to credit agencies, and they said we didn't notice a difference.
So I've been asked to, I think, I've been having discussion with my friend here. And so the impact we had, after we started a program called Presumptive, again, I don't like the word charity myself, but it's a universally accepted term. So I have to use that, presumptive charity care. So what we did is we added two systems. One is a state-guided FPL, Federal Poverty Guidelines. Secondly, we created an algorithm working with the Collections Bureau because they have tons of information. They were our data, trove for me. So we created a system that is basically screening out patients. And the moment I find out that had this patient applied for charity care would have qualified, we basically write the whole thing off. And we have helped since inception in August of 2023, 5,265 lives that have been affected positively or impacted positively. So there is a lot of value. I think that was your question. And it's $15.6 million worth of dollars we have written off. I'm not again sure I was supposed to share or not, but that's a number we have as of yesterday. And it's growing every day. So that data point I've not tested, but I'm pretty sure there is a lot of, this opportunity cost is basically you're asking. So we did not calculate that, and I don't know what's the best way to calculate that. But what we have found is our collections have increased. So it means we were screening the right patients out to the right box.
Barack Richmond, Georgetown Law School. I'm sorry, GW Law School. God, my colleagues will be upset that I made it. And our graduates also. So I wanted to build off of something that Eli said about the political dynamic. I agree with him 100% that it's quite dysfunctional if you have the hospital association negotiating with everybody else. So two questions. One is, what's the relationship, I guess it's a question to Deepak and Fred, what's the relationship between your hospitals and your state hospital associations? Are there any opportunities to either, I imagine you're not big enough to affect the initiatives, but is there any way to perhaps noisily deviate from them? And this, a similar question to Connor about the relationship that his organization has with the chambers of commerce, which tend to be dominated by local hospitals. And that's something I've never understood, because the interests of the local hospitals tend to be fairly diametrically opposed to the interests of the rest of the economic community. So those are two possible ways that we could shake up the political conversation. And I was wondering if any of the three of you had any plans or experiences doing that.
So I've been in some of the conversations between the chamber or chamber-like organizations and the hospitals, and they tend to be very polite and not get at the consequential issues, because the hospitals are obviously big employers and big business, and so when they're in the room together, I noticed that with the business leaders, it just doesn't get down to like some of these core issues that are conflicts, as you note. In terms of being able to move or influence the hospital associations, we are not members of every hospital association that we could be members of for some of those reasons. I think they're just too broad and try to represent too much and too big of a point of their advocacy positions don't necessarily line up with ours. So so we're not a member of everything. The ones that we are, like your friend Steve Love, who's a good person who goes into the C's mentality. We have these conversations of the Dallas-Fort Worth Hospital Council. Good person, but has a very different point of view on this, like basically why you're attacking hospitals, right? So yeah, we have these conversations, but generally, we're not past the C's mentality.
Hi, go ahead, please.
I can add. I don't. I work at the federal level, of course, and I'd have to ask some of our state folks, how they are interacting with their local chambers of commerce. But I think generally we tend to have, a disconnect with, what chambers of commerce are advocating for versus what we are advocating for, just because I think some of the structures of the chambers and, what businesses they truly represent. And I think there's a disconnect because, being the smallest of the small businesses, the needs of those businesses aren't always elevated in chambers, especially with the U.S. Chamber, I think. So there's disconnect on that way, but on that sense. But it's a good question for my state directors that I'll take back to them.
For me also, I think this is a take-home point for me. I'm going to take it because when I get started on this thing, I didn't think of this, that it's going to get some sort of, that I'll be here. I just set out to make some difference in the lives that the patients we were serving over there. And but this is a good take-home point. So thank you.
Hi, and I'm Bethany Prey. I'm at the Colorado Center on Law and Policy. And we had a sort of question about enforcement, state level enforcement and implementation of those discounted care or charity care programs. And what we've found is we don't have much. We have some reporting that's very incomplete and not so accurate. Our colleagues at the Colorado Consumer Health Initiative did a survey of hospitals where they called to get information, and only about 11% of the hospitals gave complete and accurate information about our statewide discounted care requirements. And for Spanish speakers, the number was much lower. It was 3%. So, we know it's really hard to get that information. But then one other, comment really is that I think that all this discussion also points out to waste in the system. I mean, there is so much waste that goes into having to screen everybody, having to bill them, having to send them to collections, having to the scheduling even, because when people call and they don't have coverage or they have a debt, they don't get scheduled. So there's delay in care. I mean, there's all this waste also built into this, though that's not the way currently waste is being discussed.
Change is never sudden. It happens slowly. And, these discussions have started. I'm very hopeful that change, and I'm an eternally optimistic person. I'm hoping that change will happen. And the tragedy of commons I mentioned earlier in this discussion, there is actually a solution. So it was given by Miss Elinor Ostrom. She was a Nobel Prize winner in 2009. So she gave the theory of managing commons or governing commons. And the solution lies in that theory which she gave. I think you can just write down, search on Google. So it has to be a mix of governmental regulations, plus also the change has to start happening from inside. Because if it is just governmental regulations, it won't happen. People will always find a way around. And so that would be my take on that one.
I think some. Go ahead, Eli.
I was just going to, on the question of enforcement, there are a lot of this is regulated at like an ND regulation level, where it's rules for the hospital to be the specific type of entity or have a specific type of license. And there's another way to look at this, which is just a straight up consumer protection issue. And the enforcement mechanisms that are common in those two like legal approaches are generally different. From the entity level, it's usually some government agency who's checking boxes and seeing if someone filled out the right form, or in the case of the IRS, that's just not happening at all. But with consumer protection statutes, it activates Also government entities and states, attorneys generals, and then it opens up more like private enforcement by the plaintiff's bar, which let in this case, patients stand up and actually enforce a lot of these rights if we think about them as consumer rights as opposed to like a healthcare entity thing. So there's a lot of talk in this space around what's the best way to regulate the hospital. Another way to look at this is what's the best way to protect the patient, and to just say, here's the clear line, and there's going to be a pretty severe consequence in the form of like a class action lawsuit or something if that line is crossed. And that's not an extraordinarily common approach in this. Most state policies that we see don't have some sort of private right of action and don't connect these issues to the state like UDEP or Consumer Protection Statute, which I think is an untapped enforcement area. Washington's an example.
I have a question about co-pays and deductibles. To permit is to promote. Why are our health systems cooperating with the insurance companies so they can create a 23% overhead profit by not paying for health care? Isn't it time that our health systems refused to bill for deductibles and co-pays?
I'm from a provider, and I happen to be one of the rev cycle people, so I'm one of the villains in the room. But I have an interest in this stuff, and I can assure you that we would like to give more charity care. And I don't relish documenting this stuff. We have to because of Medicaid and Medicare policy, and we don't relish the role of asset test either. But that's a Medicare regulation as well. And there's too many lawyers that have given us advice, as was noted. But
Amen.
Look, the is not true. There's an asset test. Oh, okay. All right. Well, maybe we can talk afterward. For Medicare beneficiaries, yes.
We might be talking about the bad debt.
Yeah, I'm talking about the bad debt. Yeah,
might be Medicare bad debt.
Yes.
There'd be an asset test for if
Yes.
it's classified as financial assistance,
Right.
which would be different than Medicare.
Yeah, and we have
eligibility.
to support those claims to auditors. Yes. But anyways, many of the payers require that we do not discount copays. There's nothing more that I'd love to do is discounts of copays, but it would be potential for inducement as well. But it's just we cannot do it because of the managed care contracts. We've tried to get it taken out, but there's just not an interest on the payer side to doing it. So.
All right, I think we have time for one more question. Yep. Whoa, I think Christine had a question over there for a while.
Thanks. I know everyone wants lunch, so I'll try to make this short. Christine Chen-Zinner with the Americans for Financial Reform. I just want to thank everyone on this panel. I know it's hard. You're like a perceived target, so thank you for making yourself vulnerable. I've learned so much this morning. As we're thinking about right now, the levers that are possible to pull to make change, the federal government seems a bit incapacitated at the moment, including Congress. Who knows? They might name a few post offices, but I'm not sure what other bills they're going to be able to pass. So it seems like, in an ideal situation, IRS, HHS would be able to lead and offer some more guidance on what's required and making sure there's like proper enforcements to make sure hospitals and other stakeholders are following the law. And apologies, but it seems like, I think as consumer advocates, it's easy to pick on the hospitals because they are kind of the point of sale, so to speak. So my question is really at this moment in time, it feels like the industry stakeholders are the most well-positioned, unfortunately, to make change. Maybe fortunately, maybe it's an opportunity. And I'm curious for the panelists up there, and I heard Eva start talking about this event she's describing for next week. Do you think there's any place where the industry stakeholders, and I'm thinking hospitals, can come together and agree to some kind of industry standard or good practice, maybe encapsulated in some kind of uniform form that folks can fill out to better understand who could qualify for some of this care? We know there's hospitals who aren't doing it. They're not being the Deepaks and the Freds. They're not being responsible. So I'm curious, what can the industry do to kind of fill in the gap at this moment in time?
let me just real quick. I love what you said about the physicians, and that's been the probably most consistent pressure point that I felt in hospital administration of wanting to be able to see people and make it simpler. So I think whatever form that gets overlooked, but to pull that group in, because most of them are employed now.
And then I would just add that beyond the industry, we should just note that the work of consumer advocates, particularly in states, have done phenomenal work in passing legislation, which I think that work is continuing, and that everybody's looking to the states to kind of, set the standard for helping guide some of the things like a uniform application, for example, right? That's something that can come from that space. I would also highlight too, like what LA County is doing, which I think is really phenomenal, and I think offers a model for counties and other states to look at it, how they're thinking about the arc of work and bringing in the hospital stakeholders as a partner to provide data and information around addressing this income issue. They're building their own kind of presumptive eligibility universe in LA County, and doing some extraordinary work to sort of think about making sure that they're the safety net of the safety net is how Dr. Shaw, who helps lead that work, talks about it. And then, yes, I think that there's also room for physicians to play and clinicians to play a really robust role, but we need more spaces for practice change. And we're hoping in our work with the Healthcare Anchor Network, too, that there'll be other spaces like that that can float and lift up some of those things.
Yeah. So locally, we passed an ordinance where hospitals are going to report their financial assistance and collections activities, and included in the variables that we're asking for, they're going to include if people were insured and who the insurance was, because now hospitals have always said denials are a reason why we go after patients. So if we see a trend in a particular payer being the issue, that gives us another lever that's not only going to help the patient, but the hospitals too, because we want you to keep your doors open. We just don't want the patients to pay the ultimate price.
I just want to add Maryland as well collects data through our Health Services Cost Review Commission on charity care, the number of applications, the number of denials, and through legislation in the past few years, there's a deep kind of granular demographic picture that is being collected as well in terms of how many of these are going to debt collection as well as charity care. But I love the idea of also looking at the insurance companies and adding that in and like seeing which ones are denying. And
all right, thank you all. It's time for lunch. Oh yeah, let's give the panel a great round of applause. Thank you all. Panelists, you can leave the mics on and just leave them on your chair. And we'll go to lunch, and we'll come back at 1 p.m. for our next panel on state policy. I'd like to introduce Anthony Wright, who's going to moderate our next panel. He's Executive Director of Families USA. Before joining the organization, he served 22 years as Executive Director of Health Access California, the statewide healthcare consumer advocacy coalition. Under Wright's leadership, Health Access California led state efforts to win patient protections, fight budget cuts, invest in the safety net, and expand coverage. So thanks for moderating this panel.
Good afternoon. All right, all right. I know it's after lunch for you folks, but we're gonna have to. Good afternoon. All right, can I have the speakers come up? And obviously in my federal role, a lot of the things that would be weird if I didn't acknowledge the fight that we're going on literally as we speak. In Congress with regard to Medicaid that has such an impact on this conversation just in terms of the substance. And, we saw the chart about what Medicaid expansion means or doesn't mean for medical debt, the specific provisions of the bill that include increasing cost sharing for some of our lowest income people. That could be $35, could be over $1,000 added up. For a low-income person, but also just even the theme of the conversations about what kind of burdens do people have in terms of paperwork to prove income, and all sorts of other verifications. And should the burden of these systems be on the individual patient or on the system? The burden of just proving your income, proving your eligibility, when so much of our life is automated, but to get health care, it seems to be so complex, confusing, even Kafkaesque. But I am really here and excited about this panel because, as much as I enjoy my new federal role, I spent the last 30 years as a community organizer and state advocate, working with some great people in this room. Can I actually raise hands for folks who are state advocates in the room? Yes. Because it's always been the case, but especially now in the next several weeks, that the action is in the states. That's where, especially with some of the dreariness of the federal landscape, that there is a lot of activity in the states about where we can make progress. And we have great examples here that we're going to get into in a second. Again, my own background, having privilege to be a state advocate for 30 years in New Jersey, and then for the last 2 decades in California, was on issues, whether it was last year on California passing a bill to take the medical debt off credit scores, or in 2006, the Hospital Fair Pricing Act that set in place policies so that the uninsured cannot charge more than Medicaid or Medicare for hospital care. But I will contain myself from interjecting too much about my California experience because let me quickly introduce them. Again, some of the best and brightest in this field, starting with Elisabeth Benjamin, Vice President of Health Initiatives at the Community Service Society of New York. Then Nicole Dozier, the Director of Health Advocacy Project at the North Carolina Justice Center. Then Luvia Quinones, the Senior Director of Health Policy at the Illinois Coalition for Immigrant and Refugee Rights. And then Manasa Kona, the Associate Research Professor at the Georgetown University Center for Health Insurance Reforms, who will give us a broader perspective of what's going on in all 50 states. But my first question that just have is for each person to name, and Manasa might be able to have a broader view, but for in each of your states, one exciting policy development happening in your state on medical debt that you want everybody to know about. Who wants to start?
I just got voluntold to go first. That happens often. Thank you, everyone. So, because of the great work that advocates did around Medicaid expansion, when we would travel the state, medical debt came up very often. And so, in meeting with HHS leadership and asking us what was next for the Justice Center, we said, let's work on attacking medical debt. And that individual said, "Oh, I like that idea." And so from that, we have a really exciting HHS medical debt program, and it's so much to it. I do have to look at my notes, but I mean, essentially, you're talking about all the 99 hospitals, critical care hospitals, signed on to this. Some were happier than others. We can talk about how we got to 99 later. But by January 2025, each of the hospitals had to have a mitigation program, and that had to be in plain language, which we know doesn't happen very often. But the goal is to have presumptive eligibility, to cut red tape, and also thinking about that hospitals had to provide discounts for people at 50 to 75 and 100% of based on their income and family size. And then interest rates capped at 3%, payment plans capped at 36 months, not to exceed 5% of the total household income for people at 200 to 300% of federal poverty level. And then rolling out other things, through July 2025 and 2026. I don't want to talk longer than I need to, but it's exciting. I don't think there's anything like that in the country. For that to happen in the South, it happened in North Carolina. Yeah. That really is due to the funders who supported us, like Community Catalyst, Arnold Ventures, and other partners like Bernita in the room, to help us look at some of the things that we're looking at, and got us to even some more exciting things later that are actually proposals in the legislature. So I'll stop there.
Thank you. Livia, do you want to go next?
Sure. So I'll focus on one of our successful campaigns. So quick background, we're a statewide advocacy coalition. And even though our main, you could say, audience and people that we serve are immigrants, when it comes to our medical debt work, we made the strategic decision to focus on uninsured when it comes to the messaging. For many reasons that I won't get into. So over the years, one of the things that we continue to find is despite having all these different state laws that said a hospital is supposed to have a sign that promotes financial assistance, the hospital is supposed to put this in a medical bill that people could call. I won't get into the language barriers and many other issues our community face, but I want to focus a little bit both on the different state laws that we technically have and the lack of enforcement. One of the things that we continued to find is the number of people that had both hospital bills and were in medical debt, despite being eligible 100% for hospital financial assistance. So we're talking about people in our state, hospital financial assistance, anyone that lives in Illinois, is uninsured and is under 200% of the federal poverty level, qualifies for a 100% discount. Unfortunately, many hospitals, not all, but many hospitals do not tell uninsured that this is available. They just send them a bill. And I think across communities, specifically in the immigrant community, there is this notion of wanting to do everything right in case there's a chance of getting a green card in the future, okay? So when they would get a hospital bill, despite being very, very low income, they would set up a payment plan for $20, for $50, never probably being able to pay this $20,000, $50,000, or even higher bill. And what we kept on finding is because of that lack of information, and we do a lot of health know your rights presentations, webinars, et cetera, there was no standardization. So we introduced a bill that would require hospitals to screen anyone that was uninsured. And if the person was found to be eligible, then the hospital would have the legal obligation to help the person apply for hospital financial assistance. I will say that as an advocate, for a person to actually submit all the required documentation is very burdensome. Imagine if you don't speak the language. Imagine if the application is only accessible on the website. So a lot of different issues. But after many negotiations with our hospital association, we were able to be successful and pass the law, and actually took effect in July 2024. And as of then, all hospitals have to screen uninsured and have to help people apply for financial assistance. If they're found eligible for other stuff, then they may be referred to the state Medicaid agency to buy insurance, et cetera. But at a minimum, at least people now have that opportunity, and it's lesser of the obligation, responsibility on the patient, and more so on the hospital.
Elisabeth.
I don't know. Oh, it is on. Okay, hi. So I think I'd like to talk about it. The one thing was our strategy. And we started an medical debt campaign because our consumer assistance program started seeing a 64% increase in medical debt cases in 2019. We're like, we don't see a 64% increase in anything, but we love to run data. And so it really inspired us to work on this issue because it was really something that was being experienced by our clients. And Kelly, was doing that work every single day. And we were just so grateful to her. And our strategy sort of we started out with kind of an omnibus bill and then peeled off the part. So it's really 8 bills in one, but we just wanted to focus everybody's brains with the big omnibus Patient Medical Debt Protection Act. And then there were sort of 3 areas that we really worked on. We passed, by the way, 8 bills in 4 years, and I can get into the details. But what we figured out that about 15,000 people were being sued a year when we started in 2019 by all of our hospitals in New York State are supposed to have already had a financial aid application and are all 501c3 not-for-profit charities under state law. So we were like, wow, that's a big number. By the time we ended with our campaign, as of April in 2025, 125 people have been sued. So that's just it's literally like that. And so the strategy is basically 3 buckets. 1, work on what's going on with those lawsuits. Why are they, there's a bunch of sort of things that are very creditor friendly in our debt reform court, what goes on in court. And we just like went through a punch list, like no liens, no wage guardians, reduce the statute of limitations from 6 to 3 years, no judgment interest rate, 9%. Ha, no one pays 9% interest. Let's do 2%. You know, like just work that whole list. And then the second bucket of issues was really, and so that really impacts people who are being sued, like the most egregious cases. But then there's another way to get at medical debt is to really look at the credit report. And we love Colorado because they beat us by 2 months. But we were the second state to ban credit reporting. But we did a little different than Colorado because we made it illegal for the providers to report the debt as well as the credit reporting agencies to report it out. And so, I would love to take credit for that idea, but it was Bernita's colleague, Chi Wu at National Consumer Law Center that helped us write that. And we were so proud to get it over and it also covers care credit, by the way, which, so just saying. And then the third thing, which was our holy grail, was really reforming our hospital financial aid law. And so uniform hospital financial aid application, all uniform eligibility standard, uniform documentation request, they can only follow these things, and burden of proof. Nobody is allowed to be sued below 400% of poverty, and the burden of proof's on the hospitals if they do it. So in those 125 lawsuits that have happened this year, there will be an affidavit from the CFO claiming, I don't know how they're going to know it, that person has an income over 400% of poverty. So I think it's the strategy. And then there's there's a whole organizing strategy that was a companion with that vision of what we wanted. And it's made a big difference. I mean, we can prove it. So.
No, it's great. And we will absolutely get to the organizing and strategy in a section, but I want to turn to Manasa, who can talk about her medical debt work at Georgetown and this, because you study state policies across 50 states, and to tell us a little bit how these three examples fit into a larger tableau.
Yeah, sure. So just for a little bit of background, we do 50-state research on various medical debt policies and publish it through Commonwealth Fund. Our last report came out in September 2023. So I thought that it would be interesting to talk about what we've seen since then and what we've been tracking. An update is forthcoming shortly, but just to give you a little bit of preview of the sort of trends in state legislation that we've seen since then, I think it's helpful to think of it as the really super upstream measures and then going down to downstream measures. So the really upstream is, of course, strengthening coverage and then dealing with high hospital costs. And that I'm not going to steal the thunder of the systems panel that's coming up next. But moving one step down, you've got community benefits, a little bit attenuated from, solving the medical debt problem, but it still does contribute. The big goal is, to put money into the community in lieu of receiving preferential tax treatment. And the hope is that, tide will lift all boats. Have we seen any action on this front? Very little. This seems to me like an area that states just don't seem to have as much appetite for enacting, just as of yet. Moving one step lower, we've got financial assistance, of course, also prevents the accrual of medical debt. We've, of course, seen New York as the one and only shining example for the most part that has done both pieces of it, which is to kind of target the standards of financial assistance, kind of expanding who's eligible for it and how much they get, but then also to kind of tackle some of the more procedural side of things. We've also seen some financial assistance procedural developments from California and Maryland, of course. I think they have limited monetary asset consideration in the application, which does kind of ease the path a little bit. And then moving one step down, we've got billing and collections. Here we've seen definitely a lot more action. We've seen Delaware and Maine have the prohibited interest, and New Jersey and New York have limited and capped the interest. We've seen reasonable payment plan requirements. I know that Nicole was talking about North Carolina doing this. Also saw that from Delaware and New Jersey. But of course, the most active space, as everybody here probably knows, is the credit reporting ban. As Elisabeth was mentioning, we've seen a rise of sort of the belt and suspenders approach of, on the one hand, prohibiting providers from supplying the information and then from credit reporting agencies from using that information. And occasionally we're starting to see a little mix of states also prohibiting the end user of the credit reports from considering that information in making their decisions as well. And this has been a completely active space. I think we're now up to 12, with Maryland and Washington just joining the ranks as of a couple weeks ago, which is fantastic. Congratulations. Then moving further downstream, you've got the lawsuit protections, which Elisabeth was talking about. We've seen some great movement, and especially Delaware. They now fully prohibit wage garnishment and foreclosure. California kind of tightened up their liens and wage garnishment protections. And then we, of course, saw measures like in New Jersey where, those below 600% of federal poverty level cannot be, their wages cannot be garnished. So we've kind of seen activity across the board. And then much further downstream, we've got the debt forgiveness angle of it. And that is something that's also been equally as active as the credit reporting space in terms of states enacting a bunch of medical debt relief programs, which basically like buys and forgives. And I know Undue medical debt has been very involved in helping states do this. And we've seen it not only at the state level, but also sort of like local and county levels as well. So we've got kind of action sprinkled across the spectrum, but it's been really focused so far on the credit reporting, billing, and collection side, except for New York, which does this great thing. They keep doing these recursive bills that like kind of plug holes as they go along, which is a great strategy, and it's a delight to see.
No, that's great. I mean, a lot of activity, and I think if you patch these together, it really does provide a whole like action agenda of what states can do in all these realms up and down the spectrum. And obviously, some of them are admittedly more piecemeal. Some of them are broader. Some of them are broken down into pieces, but build toward a bigger system of protection for patients. And so when we get to questions and answers, we'd love folks to dive into fleshing out what does this ongoing, evolving, and emerging agenda for state advocates and legislators and policymakers could look like. But I do want to move the conversation a little because I want this to be both about information but also inspiration for what is for how, not just the what, but the how. How do we get this? So I would love to just also ask, what is one or two things that you thought was particularly successful, in terms of a strategy, in terms of information that you collected, in terms of specific type of coalition that you built? Anything that specifically comes to mind? Levey, it looks like I've intrigued you. Go ahead.
Yeah, as you were speaking, I was thinking of all the stuff we had to do to get this over. And I'll say our approach was piecemeal, unfortunately, just because of the opposition. So I'll just say that because what we started with was also probably at least 2-3 bills, but we just had to compromise a lot to get something. So for us, even before we introduced the legislation, as has previously said, I think it was in the morning session, when it comes to medical debt, we know that those that are affected the most are communities of color. So keeping that in mind, even before, again, we introduced legislation, we were very intentional on who were going to be our chief sponsors in the bill. So we chose somebody from the Senate side that is African American, and from the House side, somebody that's Latina. Because not only do they also come from the community, so understand the issue, but also to get the different caucuses on board. Additionally, we had, I don't know how many stories lined up from across the state, so they wouldn't think that, again, it was only a Chicago issue, because that's usually what we're told. It's the city issue. So we had from downstate, Illinois, et cetera. And to make sure that people knew, again, it was across counties, from different income levels, and even as many of us may know, the immigrant community is also very diverse. So making sure that the stories were not only Latino, but also from the Asian community, Arab community, et cetera. The other thing is that as we were going through the whole legislative process, committee hearings, et cetera, our main opposition, as has been said in other conversations, we did have to, I'll put it nicely, fight with the hospital association that was very against many, many things in our bill, including private right to action, which we tried, but had a compromise on that one. But one of the things that they kept on saying in the various hearings was hospitals were doing everything. There was no issue. People were not in medical debt. People can access the services. And in our experience, and it wasn't 1 year, it was several years of having to help individuals navigate financial assistance, despite us not being a direct service organization, that through the help of many different partners, many of you in the room that we had to consult, we actually, right before the bill was going to be heard in the House, we organized not only a press conference, but a report that focus both on the national data on medical debt, but also on the Illinois data. Thanks to Community Catalyst, thanks to, I'm going to draw a blank on the different names of people that I reached out to here, to really put in the focus on medical debt, that it was really about just this increased issue. And after the release of that, we took the various news articles. We got pretty much published in every newspaper in Illinois, as well as I think there was one at the national level, but I can't remember. And we started just distributing those news articles in the different offices, in addition to an executive summary. And the conversation shifted right away. Then it was pretty much no denying that it was an issue.
Great. Why don't you go?
So we definitely had a really, is this on? Yeah. We had like a ground game, and so I'm going to, yes, we did that. We love, all of that stuff and town halls. And we also had like a really vibrant, We the Patients social media platform that had like client videos and stuff like that we got from the town halls that we did in all different areas of the states. Also, very important, not just having it be a downstate issue. 50% of the population lives in New York City in the state, and then the rest of it's like Appalachia, right? So with some pockets at like a couple of other urban places. So very different thing, but you have to win the whole state to win legislation. And I have to say medical debt is a wonderful issue in New York because it's a bipartisan issue. We had Republicans voting for it out of committee. We had Republicans voting for it on the floor. I think the strategy that I'd like to talk about that hasn't been talked about, I'm not sure anybody else will talk about, is we did this kind of a very ambitious thing, which is we have 210 hospitals in New York State, all of which are nonprofits, and we looked up every single hospital name in every single civil court database and amassed a universe of all the medical debt lawsuits. And then we started looking who was suing the most people. So what we did is, for example, SUNY Upstate, for example, is in Syracuse. And we could show, actually, let's do Albany. In Albany County, we did Trinity hospitals. We looked at the 3 hospital systems in Albany County, and we could show that they were suing more people of color than anybody else. It was like majority minority zip codes. And so we would analyze the zip codes of where the defendants were. And then we would write these letters to the hospital. And we do hospital system after hospital system. And it was kind of like, I'm a recovering UAW legal aid staff attorneys health delegate union member. And so we did pattern bargaining. And so we would go to one hospital and say, we'd write these sort of non-demand man letters as a recovering litigator. So instead of saying, we're going to sue you at the end, it was like, we'd like to have a phone call. But meanwhile, we had all the evidence how they were suing only poor people, essentially, and only people of color. And it's not a good look when these hospitals are getting $1 billion a year to incentivize them for complying with our bad old state financial assistance law. And we would say, you got whatever it was, $60 million, New York Presbyterian, and yet you sued 1,400 people. What's up? And look at the zip codes of where these people that you're suing are. And by the way, this other hospital system, NYU, just withdrew all their lawsuits. So don't you want to be as good as NYU? And look at their charity care schedule. So we kept like playing them off each other one by one. We only had one hospital system threaten us with defamation. That would be Northwell. But then after they were on, which is our largest healthcare system, and then after they put us, after they threatened us with defamation, my boss, David Jones, is the world's classiest actor. He's like, oh, that would be great. Think of all the press we'd get if Northwell sued us for defamation. I'm like, I love you, David. They never sued us. Meanwhile, what then happened is we worked with Brian Rosenthal, a New York Times Pulitzer Prize winning reporter, and got Northwell on the front page of the New York Times for suing 4,000, 5,000 people during the pandemic when the courts in New York were closed because, of course, the pandemic was very bad in New York. And they looked so bad that they used a sewer service thing where they would actually not really serve people, like their process server was being sued in federal court for not actually serving people with these lawsuits, and they just were like, okay, we're just out of this business. So instead of suing us for defamation, even though we met with them many times, saying they were like, I can't even tell you some of the things they said to us because maybe I really would get sued for defamation, but anyway, they just some of the things they said to us. I mean, I'll come up to you later. I'll tell you, but anyway. but they just finally just stood down. And that we would see that happen. Even the cancer facility out in Buffalo, the top zip code they sued in had a median income of 87% of poverty. It's a cancer facility. Kelly had a great client story from there. The client that they had on their homepage profiled, they wouldn't give financial assistance to. I mean, it was just unbelievable. So, in New York, the trade groups had a hard time rebutting all this. I mean, like, they are so powerful in New York. I mean, there's no one that spends more money lobbying in New York than Greater New York Hospital Association in 1199. And they were like, yeah. They kept trying to go behind. They wouldn't even put their letterhead on their memos. They wouldn't even do memos of opposition. They would just have these memos, and then we'd have to it's unbelievable. So anyway, I think that was the strategy, was just really getting the data, because it's so hard. I mean, the hard facts are the hard facts, right? You don't have to believe me. You can just believe the data.
No, thank you. Lots of things in there from the corporate campaign angle, the data stuff, the stories. I remember doing this work, and as an organizer, you always collect stories. I didn't think, but in this issue, you can get your stories from court filings, from who is being filed for bankruptcy or for liens or whatever because of.
One hospital had sued 12 people in jail. I'm like, it wasn't John Gotti. That was not the defendant in these cases. I'm like, it was really awful. I mean,
I want to ask Nicole about some of the strategies and tactics that you all use in North Carolina, which is a different political environment.
Yes. I'll focus on how we try to keep people at the center of what we try to do. So that is just the stories. And one of our stories was Mr. Terry Belk, and he was someone HM Health had sued. So we had done a little bit of research, not exhausted like you did, but found his name and then actually had him letter write to other people. And that wasn't successful. They probably didn't believe it was him. They probably thought it was a creditor. But so with Mr. Belk, he was really compelling because his wife, who was insured, had breast cancer and they were not able to pay their bills. So HM Health or Advocate Health thought it was a good idea to put a lien on his home and then have his debt go to collections. And his wife ended up passing away anyway. And so then thinking about the work that Undue Medical Debt does and then Dollar for just, we thought that it was a great opportunity for us to work with Community Catalyst on stories to profile Mr. Belk and also Reverend Jackman at Trinity Moravian Church for the less than pennies on the dollar that they were buying all people's debt. And by the way, we went to church there a few weeks ago and saw them burn the debt. That was amazing. Yeah. So Mr. Belk, his story was compelling and got him in local media. But what really turned the tide is that NBC News with Lester Holt got a hold of it. And it was a beautiful story. And there was, the quote from Mr. Belk saying, that he was going to take his debt because he actually ended up having prostate cancer into the afterlife. Gives me chills. So I guess HM Advocate Health didn't like that. So that was part of our pressure campaign to get them to sign on to the program. And so Mr. Belk got a call from them, and they were going to remove the lien, also take his debt out of collections, and not just for him, but everyone else situated similarly to him. And not just North Carolina, but because they're Advocate Health, every state where they were doing that. So this was over 11,000 people. This is beyond the program. And so what I had done previous to that is we did a few things with our coalition. So we had a coalition of medical students and other health professionals and students, but mostly the students driving a letter to the CEOs of the top hospitals. They did not release theirs to the media, but they did get a response from their future employers, essentially. But a letter came from my email to the hospital association and all the CEOs. It was a Black CEO letter, essentially, is what we called it, because we said the whole messaging was, yes, we all worked together on expansion, and they didn't know because of relationships. I knew exactly who was trying to sue HHS, who was complaining to CMS. I knew all of that. And so, the CEO letter was signed by 5 Black CEOs of nonprofit organizations. And so that, and I was nice about it, but I did say, this will be released to the media in the next 2 hours. So just so you know. And so, I didn't get a response from those CEOs, but then we did another one with our coalition partners for our more direct action coalition that's been in existence for a long time. And that letter was saying, let's just go ahead and do the program, let's sign on to it. And then after what happened with Atrium Health / Advocate Health, then other hospitals saying, we're going to do the same thing. And so then I would write a letter to that hospital, hey, these 2 hospitals are doing that. You're going to do it too. So it ended up that these hospitals went beyond that program because of that, the stories and then sort of that pressure campaign. And the whole thing around the Black CEOs is you talk about health equities, and we know what we're talking about then. Let's just not mix words. And so that was that language. They had to lean into what they say in their mission and vision statements. And so then the other group of, we did faith leaders, pastors, and patients. And so while we were working on those letters, we had people who were actually picked up the phone and calling and saying, Mr. CEO, this is what is happening in my church or in my community. So those are some of the tactics around coalitions and keeping people at the center.
I was just going to say, I think one of the things I really want to make it very clear, like CSS, my organization was in partnership with incredible partners, AARP, Consumer Reports, Northwest Bronx Clergy Coalition, the Labor Religion Coalition. I think it was just such a Make the Road New York, South Asian Council for Social Service. I mean, it was just an incredibly broad, geographically diverse groups. I mean, it was just, it's so powerful when all of those groups are united. NIPIRG, sorry, I didn't mean to forget the PIRGs. Anyway, it was incredible. Original in the early days, RIP Medical Debt would support us and on our work. And it was really, really powerful and it made a big difference to have these memos of support from, 30 organizations.
Yeah, I'm loving some of the themes here, both of coalition, but also being grounded in specific communities, whether it's, immigrant community, communities of color, the building of relationships through other campaigns. I actually do want one more thing with regard to North Carolina, both in terms of how this played off of the fight that I know that North Carolina Justice Center did off of the Medicaid expansion fight and those relationships built, and also the role of the governor I think from afar we saw that he played a leadership role, and you can tell us how much of that, and how much, and what was the relationship and working together with a champ.
Yeah.
When you have a champion, how do you use them?
Yeah, that's great. I mean, Governor Cooper he became one of the most popular people wherever we went, in the country. They would talk about Governor Cooper. But yeah, day one, that was his priority, and lawmakers didn't like him. He used to be one of them. He was in the General Assembly and he was the AG, and he is from Rocky Mount. His mom was a teacher. He has a way, he has a lot of, and he was a lawyer, but a lot of charisma, and really strategic. And so, so he doing this program, going around the legislature, that didn't get him any favors for that. But at the end, you can see him saying, you know what, I'm out of here. I couldn't even take a vacation because he didn't want the lieutenant governor to become our governor for any time. And so, I probably shouldn't have said that, but we're not on Facebook Live, right? For him to take that on, and then with Secretary Cody Kinsley, for them to be together, but also we knew where, I'll say, progressive people were on this issue for a while on expansion and then medical debt, right? But also a lot of the people in the conservative party and in leadership as health chairs, those relationships were very strong. And so I think that also helped. And for me with relationships is I am a retired elected official. So helping to run a small affluent town outside of Raleigh and having relationships, I always had both name tags, and I just roll up in there like, we represent same people. And I would just start talking to people like, oh, you were a mayor? Oh, and they'd be like, yeah, they don't know how to do stuff here unless you were local. I know, right? You just use those relationships to get people to trust you. So in that case, then you have people providing information to you that normally you wouldn't ever have and getting things to you embargoed. That's how we were able to defeat the whole building a casino in North Carolina with what money? Expansion money, And then just this program called the NC Leadership Forum is what the folks on my team, like Rebecca and Han, really feel like that is what helped me with these relationships, because in that room, I feel like we were almost a shadow committee of the General Assembly. It started out with all these issue areas, and it's like conservative people and progressive people who are considered health leaders. But at the end, it was expansion. It was, advanced nurse practitioners, for example, and then certificate of need at the end. But I was able to use one of our stories and then show at the end how this woman of color died because she wasn't listened to by her provider, and so did her baby. And when she didn't have a baby anymore, they snatched her Medicaid. So, just to share that story in the room, all these folks who were like, the Speaker of the Houses, Chief of Staff, Deputy Chief of Staff, hospital CEOs, Chambers of Commerce, county commissioners, there was just like in the room from everyone. And at the end, the question was, is there anyone who does not support Medicaid expansion? And no one said that. And so we got a lot of people who did signed on, and they said it's because they got a chance to learn from me, and we were all on first name basis too. And I told every Republican lawmaker that I would come and see them the first day of session. And every first day of session, I go around and talk to each one of them. And that's how I was able to draft the medical debt bill. I never had an opportunity to draft anything with anyone. So
thank you so much. Manasa, can you tell us from your vantage point some of the other trends that you see with regard to strategies or tactics?
Sure. I mean, I think now that we've spoken about what's been going on, I think it might be helpful to think about what the gaps, or maybe you can call them opportunities, are moving forward. I think it's helpful to think about them in maybe three buckets. So there's first of all, even the states that are really ahead in the game, there's still substantive sort of standards gaps, right? You've got population carve-outs, you've got provider carve-outs, and you've got debt type carve-outs. So it's you've got populations, you might exclude immigrant populations or not explicitly tell hospitals to provide these services to immigrant populations. You might have, folks who are who have faced a lot of medical expenses, out-of-pocket medical expenses, but might not qualify under the income threshold. They might be kind of left out. And I know New York recently closed that gap. And then there is, of course, the provider, gap. I think the newer bills, we're starting to see a little bit more to be a little bit broader, but are you covering hospital outpatient departments? Are you covering physician, groups? Are you covering ambulances? They're the big carve out of NSA. Yes, exactly. So ambulance bills and then labs, imaging, all of that stuff. So kind of being more holistic in that approach. And then the debt type, of course. I mean, a lot of this debt goes on credit cards, whether it's medical credit cards or general purpose credit cards. You've got all these buy now, pay later plans and various medical financing products. How are you covering debt in those vehicles? Then you've got your procedural gaps, which is wonky, and no one wants to talk about this. But as I already mentioned, it's the burdensome financial assistance process is a major one. And then of course there's a lot of weak speed bumps before proceeding to collections and lawsuits. States have tried to kind of add these guardrails, you need to do the screening or whatever. But it's kind of few states do this, and I don't know how well any of it is happening in practice. So there's sort of that is an issue. And then court process kind of came up. Elisabeth was talking about it a little bit, but default judgments are a huge problem. It's an assembly line. So it doesn't matter what standards you have. If that information is somehow not being transferred over to the judge, that, they're protected in some way, nothing's going to happen. You're going to get that default judgment. So that entire like line. There needs to be like a fix there where, they have to either attest in their complaint or whatever, that, they've done the screenings required by the state. So just kind of preserving those protections. And the third biggest gap is, of course, like enforcement and oversight, which I know Levey was talking about a little bit earlier. This is like one of the major things is jurisdiction problem, right? So it's like, there's the departments of health are hospital regulators, and they're, license them and have a variety of, there's a varying level of cozy relationship between departments of health and the regulated entities. There is the Attorney General's office. If they make it their thing, like, Keith Ellison did in Minnesota, great, we get some movement. I think we saw that in Washington as well. But if they don't, and that's like deprioritized, you're not going to get much movement from them in terms of like enforcing a lot of the consumer protections side of things. And then lastly, and this is a little bit wonky too, but like there's just no oversight or understanding of like the tech and the AI tools that are being used, especially predictive analytics, to kind of, so a lot of hospitals kind of subcontract with revenue cycle management companies, which are largely, all have a lot of private equity investment kind of rolling through them. And they use various predictive analytics tools to figure out who to sue and whom to go after more. And sometimes they use this for the good, which is to figure out, who should be eligible for financial assistance, but at other times they use a propensity to pay score, which is who are you likely going to get squeeze money out of, and they kind of go after those people, which is the way that we don't want it to be. And so there's like the lack of transparency in that space, I think, is like something that we should be kind of shedding some light on.
Great. That adds to this agenda of like what can and should be done at the states, and I may ask our other panelists to talk about what's next up on queue in their states, but I want to open this up to the audience because I know there's tons of questions out there, and I see people already raising their hands, so let's just get to it, and then we'll see them. But I have tons of questions if you don't, but I don't think this is a shy group.
Yeah. Hi, Zoe Gallagher with Economic Action Maryland Fund. This question's for Elisabeth. So we were able to, in Maryland, pass a bill to ban adverse credit reporting, but at the last minute, Care Credit and other medical debt credit card companies were able to get themselves exempt. I guess I was wondering if you faced similar challenges, like how you were able to get them added in.
We did. I mean, I'm sorry for every state that came after us because we were able to include Care Credit because it was all happening so fast. I think our governor, I didn't mention it, but our governor had been she is the accidental governor. Andrew Cuomo went down in disgrace. And so our governor is Kathy Hochul. And this is something she really did embrace. So she wasn't a Roy Cooper, but she did come to our office to sign the credit reporting bill. And it was really exciting. And I think it was, Colorado hadn't I think for some reason Colorado couldn't deal with it, but the original credit card companies came to us and the reason why I was at APRINT is the original ones made a pretty good case. And I wish I'd called Fred, by the way, from Urban Institute, because they made the case that how can you segregate a Starbucks charge from a medical charge and when you're suing for like $1,000 end of the month bill that hasn't been paid. And we thought, gee, they might be right about that. And so we gave up on regular credit cards right away. But we said, but medical credit cards, working with our colleagues at the National Consumer Law Center, again, Chi-Chi Wu, my hero, or Shiro, said we were able to make a really good case that, Care credit cards are for medical care. Towards the end of it, they tried to say, well, you could use it at the pharmacy to buy bubble gum at the same time. We're like, it's really not what they're for. And we had enough cases where like doctors and dentists and opticians had sort of creepily said, sign this, we'll do a prior authorization request in one case or something else like really. And then people suddenly found themselves with these 26% interest rates. And we had to go to like a charity, the Sussman Trust, to get like that dental bill paid and stuff like that. So we had enough of those little cases to kind of beat it back, but it was all moving so fast because it was the end of session and everybody kind of wanted to catch up with Colorado and so I think we just got kind of lucky. I would love to say it was my brilliant reasoning, but I think it was really, we were able to keep Care Credit in. And then they, I think, really woke up with that. And I don't know how, I was so disappointed, but I was really disappointed that CFPB caved on Care Credit. I don't know why they did, but I thought it was pretty clear. It's for medical care. Like, that's what they say they're for. Why should they be exempted?
Yeah, no, in California, that was actually the argument they used to say, if you want to codify the federal rules, that's fine, but don't go beyond them. And in fact, our legislative change committee was willing to tank the whole bill, but then at the end of the day didn't, and probably better because now with the CFPB proposal not going forward, then that at least provided that protection. But
Well, it wasn't even a twinkle in CFPB's eye. I
right,
think,
at the
back in
time.
early 23. So I don't think that came along.
Well, oh, yes, next question.
Yeah, hi, Ed Weisbart from Physicians for a National Health Program. I'm wondering if you have any. I live in Missouri, and I spent a lot of time speaking across the political aisle. And I'm wondering if you have any insights into how to get your sort of strategies to be embraced by more conservative members of your state legislature.
Both Nicole and Luvia were talking about that. Once you get outside the big city.
I'll say that I think most of us have been saying the importance of the stories, and making sure that the stories also are somewhat diverse. Two, I think even being able to organize within the legislators. I mean, we are very fortunate in Illinois that we have a lot of great champions when it comes to our state legislature. Some of them are actually former colleagues. So it's sometimes it's also that way. So kind of like the internal as well as external strategy. But I think as much as you're able to make it about issues that they care about. So for us, again, it wasn't about the immigrant issue. It was about the uninsured. And it was about those that are low income. I know that across the states, there has been more interest around just consumer rights. So maybe it's just changing it a little bit, again, depending on who the audience is. For us, it was about the uninsured. But I know according to our state legislators, there's across the aisle, it's about consumers. So for me, I think I would say it's both, again, the internal, external, as well as the messaging.
Nicole?
I think it's a great question. I do think that being in that leadership forum that I was in helped people who may have had an opinion about the Justice Center or about me, oh, there's that left-leaning place. And, and I never describe myself because I feel like you're unbalanced if you're leaning over to the left. So, I just describe myself as being progressive, and we don't describe our work that way. So I think that was one of them. And then for me, I started thinking about, I can't just talk to our friends, and we can't ignore our friends either. Whoever's in power, you can't just ignore the other party either. So just really continuing to talk to the minority leaders and let them know what we were doing, and then saying, hey, we want to provide questions to you, even though the other folks are not going to let you really run an amendment. And then when I talk to the other folks, for some I trust, I have told them, I have given certain questions, and this is very narrow. I probably with two people I would have done this with, to say, I'm going to provide you the exact questions, but here's the amendment, and I want you to push for this amendment, Mr. Health Chair. And that happened related to managed care. I think the other thing is thinking about stop making assumptions myself about people. So, for example, it is challenging to see people who, and I'm a person of faith, but when you pray at the beginning of session and you do everything to tear down the people that God talks about, it's a problem for me. And when red lines for us is like women's health. And can we just say that the head is attached to the body? Why do we have dental health and visual health and reproductive health and health? Like, can we just stop doing that? But I decided that was disrespectful to the people impacted, to the people who invest in our work, and to our colleagues, to not walk into the Freedom Caucus member's office and say, here's our information on this particular bill. What do you think about this? And so we took those chances and just pretend that yesterday I didn't just do something terrible, but I'm in here today because people are working and I'm in here. This is my work. Our other people have clients, and our clients are the people in North Carolina. And we did have someone who leads the Freedom Caucus to remove his name from a bill. So, and then we went back to him and said, would you take this information on medical debt? They not only took it, but actually voted on it in the Freedom Caucus and said it was going to be a priority for them in this session. So those are the kind of things I think we just have to remind ourselves is to through this and get through what happened yesterday to tear down low income communities and women's reproductive rights.
Just to quickly add on to Nicole's, I heard the treasurer Dale Folwell speak. He was like a one-man tour de force in North Carolina for a long time, and I just remember him mentioning how he was moved by his faith essentially, and he thought it was deeply unchristian that anybody was getting into medical debt at all, which I thought was, I was like, yeah, it's great. Yeah.
Very not unlocked by the speaker, and so when we started working with the bill filer, the speaker pretty much said, "Stop! I'm not going to let this bill go," which it had already passed unanimously through the Senate, and there was one absence, and so it's because of relationships, and so that's when we decided to stop and just do the groundswell of support.
It is interesting. I mean, as opposed to the broader philosophical questions of what is the role of government and healthcare, this is very grounded and visceral, right? Like you have a person with the debt, and hopefully it's a way that brings people into the broader conversations. But
there
it has
isn't
that.
a person in this room that hasn't been frustrated with a medical bill, and that's true in the legislature too. It's just medical
Among the
billing.
staffers.
It's just like it's just like so.
We have another. Yes.
We've been talking a lot about state policies that address provider billing, but have there been any interesting state policies to address regulations on insurance companies or gaps like higher copays and deductibles and that kind of thing?
We did something that our insurance industry didn't like very much. After we've been winning all these medical debt bills, we thought we really started looking a lot closer at insurance design, because I think insurance is designed poorly, right? When you have a deductible, you don't have people getting insulin, for example. And why would you have any dollar copay attached to insulin? And there had been all this discussion in Washington, even in our own state, we had done like $100 a month cap and stuff like that. And so we went to the superintendent of financial services under the Cuomo administration, a woman named Adrienne Harris. And Superintendent Harris, we said, why don't you do something really radical? Why don't you go for $0 copay for all state regulated insurance products in New York for insulin? And she was like, and I made the case that, diabetes disproportionately impacts people of color, but also low income people, very much a huge issue for rural white New Yorkers. It was a great issue that had a lot of traction, and she went for it, and she got the governor, and her whole department staff was like really mad because it's extremely hard to implement a single insurance mandate like that basically overnight, but she did it. And so I think we would really like to start looking more at insurance product design, like why, if medication adherence is so tied in with medical debt, why are we having any deductibles for things like insulin, sick visits? Everything in our current system is just forcing people into hospitals because of the deductible, right? You wait till you get super, super sick, and you're not, because you don't want to go to the doctor, urgent care. So I think really we should all be looking closer at insurance design. And we are fortunate, in our 1332 waiver, we got rid of a bunch of cost sharing within that effort. And I know the DC Exchange has done a lot of great work in this area about redesigning their insurance products and what is pre-deductible, accessible or not. So.
No, I think that the Affordable Care Act provides a scaffolding that I think states can work on, whether it's standardized benefits and additional subsidies like California and other states like Colorado have been doing, and other efforts to try to get into the world of employer-based coverage is something that is. So, do you want to say a second about that?
Bring up. I was like, we do a lot of the tracking of coverage policies as well, and states have been, very active and been doing a lot. But at the end of the day, it's like the majority of people are covered under ERISA governed plans, and there has been, limited to no movement. I know they've done some good things in mental health parity and stuff like that, which God knows where that's going to go now. But yeah, I think that's like a major block either way to really tackling the insurance problem.
Michelle from Community Catalyst.
Yes. As we segue into federal solutions, I'm really interested in if there have been any unintended consequences of state policies regarding medical debt, where you've been like, oh, I didn't realize that was going to happen. That actually hurts. And this is related to a conversation we've had together where there are some even potentially well-meaning staffers on the Hill who are nervous, for example, about having floor for financial assistance they're like, if that happens to the hospitals, then the insurance companies are going to go and they're going to increase their prices because, patients aren't going to, or they're going to cut their reimbursement to hospitals because patients aren't going to really care, and patients can't cost shift because if they have certain financial assistance, and the whole ripple effect. That's just one example of like where we're getting it. So I'm just wondering, as we look at it, are there cases where you're like, oh, that was designed in a way that we didn't anticipate, that it was actually negative? And then conversely, if you have evidence that it was actually great, let's talk afterwards about continuing to uplift that, because we're getting.
I mean, I think the research, and I think there's a lot of researchers in this room will say there's a real myth around cost shifting and whether that's really occurring or not. And so I would really invite people to revisit that whole myth. And I would say, to answer to your original question, no, we have seen no unintended consequences. We've been really thrilled with our work. I mean, and the impact on it. I'm sorry. I know that sounds so arrogant. I didn't mean it that way.
Question there, but go ahead.
Vague. Maybe, I don't know if this is a theory or something that's happening, but I do know that a lot of the times hospitals and debt collectors use the threat of two things, right? It's either I'm going to put it on your credit report, or I'm going to sue you to kind of get paid back. And there's been, ideas in the air that putting the credit reporting bans out there is going to increase the amount of litigation. I don't have any evidence that it's happening, but I would love to hear from legal services advocates and what they see on the ground and on the basis of that.
I mean, the one thing that I have heard is sometimes when, like, a couple of things go viral in California, where the law in California sets that somebody who's under 400% of poverty level can't get charged more than the Medicaid or Medicare rate, and so then there. If people notice that, then there's people who are above that who are actually paying a much higher rate, maybe because of the design of their insurance. And so if you're insured, and then you're actually paying more than if you're uninsured there. But I think that's a problem that is about the broader structure, and we need to solve that broader structural system rather than take it away from the people who need it. But that's a very small piece. Barack.
So. Both you and I think a previous panel talked about the proliferation of wage garnishments that have accrued from medical debt lawsuits. Have any of you engaged with the business community, in particular large employers in the retail sector, about trying to combat those garnishments? Because I imagine they're not crazy about doing that to their own employees.
No, I mean, we did it. We analyzed the 5 hospitals' wage garnishment practices and issued a report on that. And it was hard to get that data. And it really didn't tell you very much about the defendants. But the one thing it told you is who they worked for. And I can tell you Goldman Sachs was not on that list. It was, school districts, the hospitals themselves, union factories, local mom and pops, little, TGIFs. And so you could just tell. And then this is like the worst. Fred, close your ears. People, any researcher in here, close your ears, because what I would do is I would look up on Idealist, like the offering wages at these various places. And that was our analytics. And so I would look, and that's how we would figure out these are all low wage workers. And that's when we got rid of wage garnishments. That one went along. And then the liens, the hospitals themselves reported on those and made them, why were they taking 2,400 liens a year? It just looked bad.
We were just talking about this with another researcher and a legal professor the other day who works in consumer protection laws. And a lot of large employers just use payroll processors. So it's kind of just automated anyway. So they don't really have the pressure point. When you come to bank account garnishment, you might have more like pressure points, because it's like, if it goes into a joint bank account, what happens? And there's a lot more like that nuance that they have to deal with when it comes to that kind of thing. So banks are not thrilled about that, is what I hear. But for whatever purposes, like employers seem not particularly bothered by it.
Before you guys go, I just want to give you a last word, like seconds, not minutes, on this. Like, what's next for y'all? Like, what's the big thing that you're coming up on? You mentioned some gaps. I don't know if there's anything else. So anything else?
We have an updated report coming up soon, so keep an eye out for it.
Keep an eye for it. All right, great.
We're going to hold a stakeholder, like a work session, all the folks who say like it's just not just the hospitals, but other entities that and impact high prices cost for healthcare. So bring them together and let's find a solution together.
For us, this year we launched a multi-year campaign when it comes to outsourced care. I think many of us know that unfortunately across the country, more hospitals are outsourcing care, whether it be emergency departments or certain services, and those things are not covered under hospitals' financial assistance policy. So as a result, the person goes to the ER. All they care about getting stabilized, and all of a sudden, when they get discharged, they find out that the anesthesiologist is not on staff, etc. So we're trying to hold hospitals accountable that if they are going to choose to do that, then those services have to be covered under hospital financial assistance. It's a big fight. So that's what we're saying. It's a multi-year campaign, but it's important to our community, especially with now what's going on at the federal level.
And we're working on a No Blank Checks Act. I think every person in this room, if you've gone to a doctor in the last couple of years, you've been asked to assign an assumption, unlimited financial liability, even though at that moment you don't know what they're going to do to you and how much it's going to cost and whether your insurance is going to pay it, or if you're essentially indemnifying that provider for their billing errors, right? Because you've just assumed all financial liability. So we're going for trying to get a standardized assumption of financial liability form issued by the Superintendent of Financial Services that does not guarantee unlimited financial liability. So it's a challenge, but we would be the first state to do it if we win. So No Blank Checks Act. That's us.
Great. Well, so just I want to say this gives me hope, and especially in a time of, again, where what's happening at the federal level, it can be very, very bleak. Like you see what's happening, and I think the two lessons I come away with is that the power of persistence. These are multi-year campaigns, each one building on each other, and that at the end of the day, progress is possible. And it may be at the state level for a long time, and then sometimes it breaks through at the national level. But just give them a great round of applause for their great work. Now I'll hand it to our Vikas. Hand it to our host.
All right.
Just leave it on. Great. So Michelle and Blair, come on up. All right. We're going to move on to talk about solutions at the federal level. And I guess the empty chair there is symbolic of the fact that we actually had a number of Hill staffers who signed up to be here. But given what's going on right now in this town, they couldn't. They have a reconciliation bill to review and talk about. So maybe we'll talk about that a little bit since it's the elephant in the room. But really, we have Blair Elliott, who's a health policy advisor for Third Way's economic program, but also previously had a role.
I previously served on the healthcare team at the Domestic Policy Council in the Biden admin. So now working at Third Way, but also previously wore the Biden admin hat.
Yep. And Michelle Sternthal, who is Director of Government Affairs at Community Catalyst, as you heard previously. So let's just dive right in. The question we had teed up was, what does the landscape for medical debt solutions look like under the current administration? But in all seriousness, there's a lot happening right now. I can't keep up hour to hour, but if you all have a view, maybe this is a good time to tell us where you think things are and where they might be headed. Why don't we start with you, Michelle?
Thank you. Is the microphone on? Okay. Things are really dark. Right now, there is a proposal that is serious in the House that estimates are at least almost 14 million people would be losing coverage for no good reason, for cruelty. And that, let's be very clear, that will explode medical debt, and people are going to die. CAP has an estimate, sort of, I don't know how they did it. They did some estimates on the number of people who will die as a result of this. They're trying to, through a death by 1,000 cuts, roll back Medicaid. They're also stripping away affordability on the ACA, so on the exchange. They are penalizing and trying to dissuade states from using their own revenue, their own sources to cover immigrants who are undocumented. And they are trying to put provisions that would ban any dollars towards gender affirming care, as an example. So I'm a big picture visionary person. And in this moment, there is like an all hands on deck defense. So all of you, especially if you don't live in DC and are enfranchised, I encourage you to call your member of Congress and senator and just, yeah, outrage. Go ahead.
Yeah, so I think Michelle hit the major points. Maybe I'll hit on a few more of the stats and the specifics here. So the overall, the Energy and Commerce Committee yesterday for over 24 hours marked up their portion of the budget, and that includes a $715 billion proposed cut to Medicaid, which is about an 8% cut over 10 years. So every year there would be 8% less Medicaid funding, and that's sort of a conservative estimate. The things in there are included are nationwide work requirements, like more strict and more frequent eligibility checks, other things that make enrollment more difficult. There's also increase of cost sharing for enrollees. So this is people making, I think Vikas, you mentioned this earlier, $15,000 to $16,000 a year having to pay $35 out of pocket for services. Medicaid enrollees, yes, that are like expansion population folks, and also just some other provisions that are going to increase the burden on state budgets. So this is really harming everyone, and that's just on the ENC side. On the Ways and Means side, which I think has gotten less attention, there are also some really damaging things that Michelle, as she mentioned, are going to impact marketplace enrollment for kind of that like middle income Americans. It's going to make enrollment a lot harder. It basically shortens the open enrollment period, takes away provisions that help lower income people enroll in marketplace coverage when they need it. And that just those things alone that are basically just rolling back some Biden era regs will lead to about 2 million people losing their coverage. And that doesn't include all the indications that we've gotten from the Republican side that they do not plan to extend premium tax credits, which will make marketplace coverage unaffordable for millions of families. So all the things taken together will be about 14 million people expected to lose coverage. And we did an analysis at Third Way. Obviously, there's a huge association between coverage and protection from medical debt. We were using the $880 billion number, so a little bit higher of Medicaid cuts. So this number might change a little bit, but we estimated that 2.8 million more families will have household medical debt, which would be a 10% jump and $26 billion overall increased medical debt. So sorry to throw a lot of statistics at you, very depressing, a lot different tenor than the last panel. But I think it's just important that we have that context before we jump into talking about, where do we go from here? So thanks.
Great, thank you. I'm just going to break from the script a little and just say, I'm not a Democrat. I'm not a Republican. I like Elisabeth's approach, which is let's just go with the facts and see how and where they lead us. In particular around Medicaid, I think there's a lot of factual information that needs to get shared. And I think, as I said in my opening remarks, this is not a session to talk about strategy or political tactics or anything like that. But I think it's self-evident that, there's a huge voter base that is going to be affected by this on both sides of the aisle. I just make that point. So I'm interested in talking about, maybe one way to organize this is to talk about where were we at the end of the Biden administration, in particular the CFPB ruling, and then where could we be if we had a really proactive, solid approach to this question, whether it's, the Democratic Party or Josh Hawley's new Republican Party or whatever the hell it is. What could we be doing at the federal level, given everything you heard about what's going on at the states? And I'll just close that thought with pointing out that there was an entrepreneur who realized that going state by state was too damn expensive. So he bought himself a ticket to federal preemption. And that's Elon Musk.
Just on the Hawley, last week I met with Hawley staffer to talk about consolidation, healthcare issues. So there is just to say that while we are doing defense, we are also seeding the ground for what we're calling the new common sense. It's not Democrat, it's not Republican. It's just people want healthcare. It's too damn expensive, and there's corporate greed, there's polling to show, no matter what side of the aisle you're on, there's outrage. And so right now, I know this isn't an answer to your question, but I'm going to say it. From a strategy level, there is a way in figuring out what is the right way to talk on both sides of the aisle to people about the outrage that they and their constituents feel. So I just wanted to name that, and we can talk more about that later. I would just say up until now, we are in an exciting moment, and we can both talk to different pieces. The CFPB finalized a rule that, while not perfect, really went a huge way in banning medical debt from credit reporting, or having it be considered in terms of credit worthiness. We were also, there was huge political momentum had the elections gone a different way. I was in conversation, I'm sure you were also, with Harris folks about medical debt being one of the singular issues that they were going to focus on from a wealth and racial wealth distribution component. And we were also working behind the scenes to get the IRS to step up its compliance, which was sorely lacking on very mealy financial assistance enforcement policies. And so there were things being teed up. The CFPB also issued an advisory that sort of gets to the private right of action component, where they basically were saying, debt collection that is wrong is illegal. Whoever is doing that, they will be held responsible. Hey, folks, you should know that. And using that, again, as another point to say that this is something that you can push back against. There's more, but I'll shut up and let you continue for some of that.
Thanks, Michelle. Michelle was working with our team on everything that we were working on from the Biden admin side, so you've covered a lot of it. I think just a couple other things is when you have an administration that is excited about an issue and engaged, even if there is not movement on the legislative side or even through formal regulation, there is a lot of power in just the bureaucracy that is the federal government, like really leaning into an issue. So as Michelle touched on, CFPB was working on things, engagement from IRS and other agencies. CMS definitely has a role to play here. We even had some engagement from like VA and DOD healthcare providers. So when there is an admin that's super interested in medical debt, there are improvements to be made on the margins through guidance documents and agency enforcement, and just time and money being invested from the agency perspective that can really move the needle in ways that don't necessarily permeate, the national headlines. So I will say that is one thing, and that work maybe will continue in this next administration, but I don't see indications that it will. But you never know, and sometimes those things can continue to happen in a way that we aren't reading about every day in the New York Times. So we'll say that. And then secondly, outside of the medical debt specific context, just to share a little bit about where we were from healthcare as a whole. During the Biden administration, really proud that we reached historic rates of uninsured rates. So it is the lowest it has ever been in the history of our country. That's because because the enrollment in the marketplace doubled during the Biden administration from about 12 million to 24 million. A lot of that is due to premium tax credits and just a lot of investment from CMS on outreach and getting the right people enrolled. So that was a huge success for us. Also, additional states expanded Medicaid, which also had a huge impact. And a lot of those things, I think, as we've discussed with the 14 million people likely to lose coverage if this reconciliation package goes through, like that progress will roll back as well. But I think that gives a decent picture.
And on the future, so I'm going to be a little bit spicy here and say that I tend to really hate looking at healthcare policy when I'm, as a public health person, when I look at health outcomes and I look at health coverage, I often find that healthcare policy is way too narrow. And so I want to propose some ideas that I think both in the political window, but that also we as health advocates have missed the boat on, is looking at healthcare as an industrial policy framework, as a sector that has issues on the supply and the demand side, that like any other sector has a role in terms of the government's relationship to it in terms of markets, and that it should be treated in that way, and it hasn't been. And what we have right now are a series of monopolies, mega conglomerates, vertically and horizontally integrated, consolidated, that are using their excess market power in ways to spike costs. We all know that. So we should be looking at antitrust policy, FTC. We should be looking at DOJ. We should be looking at tax policy. We should be looking at labor policy. We should be looking at, and I think maybe we should instead of, and my organization is doing this, so I don't mean to trash on myself or them, but essential health benefits as a component or actuarial value is one conversation. Banning, profiteering is another conversation. So I would look at what are the tax policies that from a pre-distributional perspective discourage mergers? What are the policies, what are antitrust policies that make it so that it's harder for hospitals to merge? What about having the threshold for mergers with FTC authority be lowered so that more hospitals are accounted for? So I'd look at carried interest loophole. Anyway, those are the types of things that I'd be really excited about in rethinking about our healthcare system to really get at the major drivers of the cost and access.
I think we have now I work at Third Way. We have a series called Fixing America's Broken Hospital System. So we do a lot of work looking at why hospital costs are so high and how we can bring those down. I think the competition point that you brought up, Michelle, is definitely something that we're working on and support. More competitive markets are more affordable markets. So that's something that I think we need to continue to promote. A couple other things that we've worked on that I think could help address the root cause of the incredible cost of care at hospitals. Just taking a look at nonprofit status for hospitals that are nonprofits, which is about half of hospitals, they're getting $15 billion or more in federal tax benefits, and then $15 billion or more of state and local tax benefits each year. So just making sure that we are giving those benefits and having requirements that those hospitals are providing community benefits in a way that is real and is impacting people and helping their communities through, maybe that's charity care, maybe that's other things, but just making sure those requirements to get that IRS status as a nonprofit hospital are clear and require transparency and reporting so that we can have the data on the government side to make sure that these hospitals are meeting standards. Some other things that we can talk about more, but I know it was brought up in an earlier panel. Facility fees are something that are driving up costs for so many people, and oftentimes they may even be baked into the overall cost of the service, so someone doesn't even know they're getting charged a facility fee. But there's a million examples, but patients are charged double when they go to get an ultrasound at a hospital or a hospital-owned clinic as opposed to a freestanding independent physician office. For chemotherapy infusions for cancer patients, they can pay triple if they're at a hospital. And sometimes also a hospital-owned clinic, so not just the physical hospital building, but these facility fees are being tacked on. Yes, that's what I was gonna bring up as well. There's also stories of people getting charged a facility fee for a telehealth appointment, so they're getting their service in their home, which. Yep.
Yeah, so these are, I think, all interesting examples, and I suspect we in the audience could crowdsource a federal program that would really take a huge leap forward in this problem. Michelle, I was really interested in what you said because last fall, I think it was at a conference here, Jerry Anderson of Hopkins was talking about how he saw a kind of cyclical phase of thinking about healthcare reform, and we may be in an upcycle of that. And I think it was there I made a similar point, which is that, the thing that no one dare speak its name, industrial policy, has increasingly become the official policy of the Democratic and Republican parties. If you look at a lot of what Trump's doing now, regardless of whether you think it's effective, but the thrust of it is a form of industrial policy. Same is true for the Inflation Reduction Act. So we're seeing a sea change, in my view, at least compared to 10, 20 years ago, of where and how people are willing to rethink some of these things. And I think healthcare, is ripe for that kind of rethink on both sides of the aisle and all across the country. And, I had a $150 facility fee for a telehealth visit for 15 minutes in Boston. But let's be clear, it's not going to be coverage. Like, even if the Medicaid cuts happen, which it looks like they will, most of the country is covered. In Boston, in Massachusetts, we have something like 98.5% insurance coverage. I think Hawaii is higher, and that's about it. And yet, independent of KFF, we've done a survey in which 40%, interestingly, almost the same number of people, are very concerned and avoiding health care because of the threat of debt. So we're going to have to tackle costs. We're going to have to tackle insurance design. We're going to have to tackle all of those things. So I want to hear, I think we got plenty of time. I think in this audience, we probably have a lot of people who have thoughts and ideas. What could we do at the federal level that doesn't have to go state by state by state? Could we have a standardized, like a FAFSA for college? Could we have a standardized financial assistance application form that's national? There's a range of things we could do.
I think we start off with, there are low-hanging fruits to start off with. Like, let's look at the most egregious actors. Let's look at the most egregious excesses and let's regulate that. And then I think whoever talked about insulin, was it you? I don't remember who it was, Elisabeth, but talking about insulin, like, why don't we, again, industrial policy, why don't we have sort of the, generic public provisioning of basic life-saving medicines? Like, it's not going to kill the industry. They're not making profit. Like, what are some things that we could do actually that is actually under, the Defense Production Act? We could probably do it anyway right now if we had a different president. What are some of the low-hanging fruits? Like, let's.
And this president's taken a leaf out of Bernie Sanders on some of the drug pricing things. So lots of things could happen. Let's hear from the audience. Who's got questions? Who's got comments? What a shy bunch.
Chuck Bell from Consumer Reports. So one of the reasons we have high medical costs in the U.S. is high unit prices. Our unit prices for many things like MRIs or COVID tests are much higher than the costs in other countries. So that is an issue that I would think would appeal to people who design the economy and thinking about how could we get greater efficiencies, economies of scale, perhaps by insourcing or onshoring some of these production things. One example might be pharmaceuticals. On the one hand, we're putting tariffs on imported drugs, which would probably be a big hit to consumers. But there have been recent efforts for nonprofit companies to manufacture generic medicines that are often in short supply. So that would be something that I would think would fit into this the line of thinking that you're articulating here.
Also including the workforce side, as we talk about industrial policy, and whoever's talked about one of the challenges, I think you said it, one of the challenges of like a Medicare for all would be the pressure it would place on providers. Like, what are the workforce development components of it? Like, why do doctors have medical debt? I mean, or debt from medical school? Like, that feels really stupid to me in terms of like, as we're thinking about what we want to be incentivizing,
Cancel student loan debt, but that's a whole other
right
beast, and free tuition at public universities, but that's a whole other beast. But connected. I wanted to go back to something you said, Vikas, which is that in Boston area, like 90-something% of people are covered, yet 40% still avoid healthcare because they're worried about debts. Is there any breakdown to show how much of that are the people who are covered via Medicare, Medicaid, or the VA system? Because I'm wondering how much those individuals worry about incurring debt compared to people who are privately insured. And I'm asking that because I'm married to a veteran who constantly goes to his appointments with no fear at all, and I'm always jealous. So that's my question.
Yeah, I don't have those breakdowns. It's something we can
I
look
have
at.
them.
But 40%.
It's on one of my note cards. This is the national, not the Massachusetts number, but 30% of adults with employer-based coverage and 33% of adults with Medicare or marketplace coverage. And again, that's people who currently have coverage. Does that mean the debt was incurred when they were uninsured? Maybe. So it's not a perfect picture, but definitely people who are uninsured have more medical debt. But like we were saying, coverage does not necessarily protect you. Adequate coverage protects you. So we talk about it from the third way perspective of the cure for the short-term cure for medical debt is adequate coverage. The long-term is obviously bringing down the costs on the hospital side. Sorry, if you had other things to add about Massachusetts, I just have the stats right here, so I wanted to share.
For instance, the folks who are publicly covered, is their debt like a fraction essentially of the kind of debt that the privately insured folks have? Like, do you do any breakdown in terms of how much debt this group has?
I would just say there's a conflation factor. If by definition, if you're going to be eligible for Medicare, you're going to be older, which so you'd have to also just like, it's a harder thing given its universal program to be comparing. I'm not adding a complicated.
I know when we were trying to aggregate veterans healthcare system issues and debt, we were talking to a lot of VSOs, veteran service organizations, and they were all like, none of our people are worried about medical debt. Like, folks have maybe $200-300 in copays, but compared to the privately insured people who, receive $500,000, that kind of thing. So that's the kind of data that.
Yeah. Well, this sort of harkens to something I was saying earlier, which is a lot of times when we talk about these and talk about the numbers, we talk about rates. And really in epidemiology, there's a difference between the rate and the burden. And we really should be talking about the burden. And when you look at the burden, that's what I found so astonishing when I was looking through the numbers. Whether or not the numbers are slightly off in one direction or another, what's really clear is that the burden, in my view, happy to be corrected, the burden is substantial on working people in this country, insured working people.
The VA, by the way, I said my parents are like my focus group, so my dad worked is a doctor at the VA. He was also in Boston at the Joslin Diabetes Center, nonprofit, and then at BU Medical Center. He's like, the VA was the best experience ever, like from all the reasons. And so I'm like on the VA bandwagon for like a model of public.
Hi, I'm Aija with People's Action. We've got a Care Over Cost campaign focused on, insurance. And when you're talking about insurance, that made me perk up a little extra. Because a lot of what we're seeing is claim denials. Like in addition to the issue of deductibles and copays, claim denials themselves and prior authorization denials are a huge driver of medical debt. We've got a new report coming out about that Mike has done some research on in New York State. So would love to talk with folks about that. But I'm curious, how y'all see the way that insurers are not necessarily living up to their end of the bargain being part of all of this equation.
Well, and by the way, Mike, you should share some of your findings, even if it's not yet published. We can get you the mic. My own view is that the insurance well, I have a real bias here. My own view is that the insurance companies have dropped the ball on any kind of their social responsibility relative to the cost issue. They have become content, and I learned this the hard way. I'm not talking just ideologically. In practice, in talking to them and working with them, I learned the hard way that they actually have zero interest in cost control. They have interest in cost control for the year of the contract. Yeah, of course. So they can control it. But after that, it doesn't matter. It's an elevator and they're happy to ride it up. And so in many ways, I think the question of cost, in the sort of Godzilla versus Mothra between big hospital systems and big insurance companies, that issue is left hanging and the consumer is left holding the bag. Mike, I want you to share that data because I think it's a mixed bag. What it shows in part is that a lot of the denials are from the obvious fragmentation of the system as a whole. Mike, you want to give us a quick précis?
Sure. Thank you so much. So we are preparing to release this report about data in New York. Covers primarily post-service coverage denials. And as no surprise, the denial rates are very high and the appeal rates are very low. But perhaps surprising is the amount of money tied up in appeal overturns in New York. Not maybe surprising to people who are very familiar with this space, but maybe to the general public. So in this report, we found that roughly $3 billion were overturned via internal appeal processes in 1 year in New York. And the appeals that are not sought for wrongful denials often lead to medical debt in commercial contexts, at least. So I think the relation here is to what extent do wrongful denials and lack of enforcement contribute to this major medical debt problem that we see? And maybe on the federal pathways question, I'm very curious as to your thoughts about whether, for example, like the HHS-OIG approach to overturn inappropriate denials and overturns, and maybe also DOJ investigation into False Claims Act types of approaches are going to continue, or whether that landscape has shifted enough to make it unlikely. I'd have to look at the report. I don't know off the top of my head. Yeah, the appeal rates are between like 0.5% and 2%.
You see,
Yeah, to me, the most striking thing is the appeals rates.
Yeah.
These are tiny appeals rates, but if you appeal, the overturning of the original decision is huge, which tells you, a lot of these
are wrongful.
A lot of these denials are wrongful. Yep.
I think we're thinking about this. I think there's whoever mentioned, was it ERISA, as like the stepchild that never really gets focused on. That is an area we're really concerned with. I think that there is looking at claims denials or prior auth in that area. It's harder because like there's a big focus right now on Medicare Advantage as a tool, but we think that's a critical area. And we should talk because I think this is something that we're looking at the least. There is some transparency requirements that could be upheld, that if we again had a HHS that was resourced, we would push them on in terms of reporting of non-qualified health plans, but like broader. And on the other, like to your point about no interest in healthcare, just like a quick anecdote. I'm a cancer survivor. I'm supposed to get, right after my cancer treatment, I was supposed to get PET scans every 3 months because there was still some residual, whatever they call it, radioactivity or whatever. And the United Health Insurance, which People's Action has a campaign against, said that it was not part of the standard of practice. So my oncologist called and said, no, this is important. And they said, no, I'm sorry, we don't do it. And they said, no, really, this is quite important. We need to do it. They're like, you're being overly, whatever the term is, like overly cautious. But instead, what we will authorize is a separate MRI and PET scan. MRI and CT scan. So instead of getting the PET scan, they authorize 2 separate, more costly tests that I had to have, that I ended up having, that was substandard and cost more. And so to me, this epitomizes the sort of the stupidity of a system that, yes, all of the things there.
So, yeah, I know we have lots of them, and I want to get to them. I can't see who has the mic, unfortunately. Okay, great. The one thing I wanted to say about your data, Mike, that struck me as related to what Michelle just said is that the number of claims that were officially denied for medical necessity, I was actually surprised at how small that was. Most of the reasons for the denials were all about the fragmentation of the system. This is a duplicate claim. Your coverage date was not right. This happened, that happened. It was all about administrative trivia and not really about clinical care, as you outlined. So I think this whole area just illustrates, how messed up it is. Sorry.
Yeah, so I think to that point, and I raised it this morning, but simplifying billing is really key, and that's really key for the insurers, the providers, and of course the patient at the end to actually understand and find the errors and find the and be able to scrape data in a way that everyone can understand it and know about it. And then yes, for sure, we have AI bots talking. That have denied a claim, talking to the doctors, AI bots that are saying, no, this is why it's medically necessary. So this is a situation we're in, and it's not going to get better. But one thing I would like to flag, and I'd love to hear from anybody who's hearing this, but what I'm starting to hear about now are these one-off weird charges that patients who are insured are getting charged directly to them. These bills are not being sent to insurance companies, they're just being sent to individuals. And you may have experienced this yourself, but I hear it particularly with OBGYNs charging kind of like a maintenance fee or, stay an active patient fee, even though the provider is in network. They're being charged, patients are being charged, and I think it's, I'm sure they've done the market research. I've heard $350 a year in California and $150 in the DC area. And, if you have ever had a child or an OBGYN problem, you love your OBGYN. You do not want to go through the process of finding someone else. And I don't know that everyone gets kicked off their list if they don't pay, but why not charge people $350 a year? If only 10% pay it, great. I think our insurance contracts should be prohibiting these additional charges for any in-network provider. And people need to know that they're illegal. I mean, they aren't right now, but this should be in a contract by our insurers. If you're going to be in network, the only thing you can charge a patient is, based on our negotiated rate. So,
well, I'm not a lawyer, thank God, but that was, and I suspect remains, illegal if it is assumed to be just part of a fee in the kind of relationship between the practice and the patient without an additional contract. The model you're describing 10 or 15 years ago became a model of concierge care in which you provided a fee. The East Coast version was, it's $20,000 a year. The West Coast version was it's, $50 a month. But either way, this was a form of a wraparound service with a separate contract, which then allowed the physicians and the practices to say, hey, we'll actually return your calls. That's not actually part of our contract with the insurance company. But for a fee, we'll give you a great deal. So it sounds to me it's something like that, but maybe it's morphed into something that is so, completely beyond the pale. So that's a concierge.
We haven't done any specific work on this, so I can't speak to this specifically, but I will just say, especially for OBGYN services, especially in more rural parts of the country, there is such a shortage of providers. I think it's about 1,000 counties in the country that have no obstetric unit, so they have no ability to help a woman give birth. So I think especially just sympathizing with this, you feel as though you have to pay it because you don't want to lose your provider. And I mean, if you live in DC, maybe you can go see another provider, but if you live in the middle of nowhere, you have to pay it if you want to be able to drive 2 hours to birth your baby as opposed to 4. So I think that is just speaks to our need for more providers, especially in care deserts, especially for maternity care. Again, not really what we're talking about today, but just wanted to call it out because it's such a big problem.
Well, it is what we're talking about today because one of the drivers of that is hospital consolidation, the acquisition of private equity, and profit-driven medicine, which is saying that maternity wards are not profitable, so they close, and then you end up with things. It's not a coincidence on where it's happening. Yeah, and exactly, and it's related to that. So it's all one circle of misery.
Well, speaking of one circle, I mean, this is where you need a whole system approach because the issue of community benefits, precisely those services that are not, quote, profitable are services that are meant to be part and parcel of a community benefit package, and it's erratic how that's enforced or not enforced or reported or not reported. Question back there.
Hi. I have a question. It's kind of related to the last discussion we had here. So I will make a reference to something that Fred said in the beginning. We have done a lot of studies on the determinants of medical debt, and consolidation is important, price of care is important, health insurance coverage important, but the most important thing is the health status of the population. And I think there is always a lack of discussion of how can we promote better health behaviors, how can we do better in terms of preventive care. And I think addressing those would be core, especially when you think about other countries too. So I was just wondering in terms of federal policy, state policy, I haven't heard anything about that.
I feel very strongly about this. So I'll just say two things. This is what I got my PhD in. So health disparities, even if there's 100% coverage, there would be glaring disparities because the drivers of health and poor health is not having health insurance. That exacerbates it. These are economic, and this is about social and physical environment. So I would say to you, it's not about health behaviors. People don't say, oh, I really want to be lazy and sick. It's what are the material and economic conditions that enable certain people to go to my favorite bougie bar 3, which I love to go to, versus I'm working 3 jobs I can't afford. I'm living in a place that is higher, propensity of having asthma, and there's no grocery in the location. So I would say the major factors are, let's look at eradicating poverty. Income. There's Richard Wilkinson is one of the researchers who's talked about how income disparities are associated with health outcomes. You can look at stuff like my advisor David Williams will talk about this, neighborhood segregation. So it's very easy. So I would 100% agree, and let's do that. And I would say let's move away from cooking without salt, which is important, or whatever. But there's all these other factors that at a population level are going to move the needle.
Oh, yeah. The Spirit Level, great book. Let me just add a little to that because, Brenna, I think in a system I'm going to sound like a broken record, in a system in which the patient is expected to fork over some money when they're sick. I think it's impossible to disaggregate the confounding that you're talking about. Confounding of, social determinants in a population with low income, health, behaviors that are not necessarily healthy, conditions in which they're not really healthy. All of those factors, to disaggregate them, no matter how good the study is, I think it's impossible. You're going to have a ton of correlation, and there's just no way to sort of say, well, that the medical debt part of that, could be alleviated if they were healthier. If grandpa had a beard, if grandma had a beard, she'd be grandpa. So.
I think that epidemiologically, though, you do know that there's racial disparities in health outcomes in morbidity and mortality. And if we have correlations between morbidity and mortality and medical debt, right, people who are sicker tend to accrue more medical debt, which is what we talked about, then if you have people become less sick, definitionally, I think you would get less. So like the first thing is, people who are, if there are certain communities, low income, people who've been discriminated against, people who have multiple morbidities, and they're the ones who are eventually going to the ER because of lack of coverage and then exploding their debts and all that. Like these are patterned, socially patterned. Cancer is like lots of things are patterned. So address the patterning and then you'll address the debt.
I also think this is not exactly related to your point, but something I feel about the medical debt discussion. I think because it's medical debt, it's financial, people think that this is something that only impacts low-income communities, and that's not true. Data from the SIP data actually shows that the rate of medical debt among middle-class households is actually a little bit higher than in low-income households. It's 23.5% or 17 million middle-class Americans, and compared to 22% low-income Americans. So I think we have to talk about health outcomes. I think we have to talk about a lot of things that are driving medical debt. But one thing that I think kind of gets lost in this discussion is that this is not something that just impacts the poorest of folks. It impacts people across incomes, even people with really high incomes. It impacts like 1 in 8 of those folks because the cost of care is so high. So.
Hi there. I'm Jessica. I'm a student at Rutgers School of Public Health. My question is about, someone mentioned like OB-GYN departments closing because they're less profitable. I'm also a medical student, so I've been in some conversations with older physicians who would say things like, hospitals used to understand that some departments were less profitable than others. And that was just a norm, and everybody understood that was the cost of running a hospital. And that in recent years, there's been more and more and more pressure for each department to create its own profit or increase revenue in any way that they can. And so I'm kind of curious, like we haven't yet talked about private equity in healthcare or venture capital in healthcare, like, and what are the forces that have changed these norms in hospitals where different kinds of behavior has become acceptable over time? So my question is about that.
Yeah, private equity is a huge component of this, generally of like the profit driven. You're seeing it penetrate now OB/GYN and women's health, but it's also in almost every other sector, ERs, if you look at where the fragmentation of care is another issue. So I would say I'm not going to speak to exactly why there are closures in different rural areas, because there's like a number of different factors in rural areas that make it complicated to fully say it's that, like losing population, maybe worse health, other things. But yes, the sort of the private equity and what are the policy drivers of how do you address that is an issue that we, along with our partners at the Private Equity Stakeholder Project, Americans for Financial Reform, and others are keenly aware of and working on, particularly because I see it, there's no net positive. Like I don't know any private equity intervention in healthcare. Say it again. Ooh, if there is a counterexample, I'd love to hear it. So I think my vision is like, I think we need to ban private equity in healthcare altogether.
And I know we've talked about it, but outside of just private equity, I think the larger consolidation issue is huge here. We have anti-competitive hospital markets, and when two big hospitals in a community merge, they may decide it's more economical to only have one obstetrics unit. And I think the fact there's a million factors that are sort of incentivizing more consolidation that I think we need to address through really smart policy decisions to make sure we are not losing access to care.
Well, I don't disagree with that. I want to add something, which is when you look at the trends, whether it's CEO compensation, administrative layers in hospitals, board composition, it didn't all begin with private equity or VCs. This has been going on now really since the 80s. It's part and parcel of a kind of sea change, both in the culture of the country, but also particularly in healthcare. And I raise that because when I look at this pattern in this picture, the reason private equity is there is something to be gotten. And that is because we've structured and organized, particularly the hospital sector, as if these are concerns like the local car dealership. And if you can make money, you make money. And if you make money, you get more money. Even if you're a nonprofit, you get a higher salary, you get this, you get that. And so fundamentally, and I think this is, I don't know how we get there politically, but fundamentally, this is about everybody, and I mean everybody in the country, thinks of healthcare in their heart of hearts as a social good and a public utility. When they're on the line, that's what it is. Left, right, Democrat, Republican, whatever. That's what they think and feel. But then when you look at what we've structured it as if it's this other thing. And that category error, I think, is the biggest driver. We expect hospitals to be in the black. And sure, they should be. They shouldn't be hemorrhaging money. But there's no reason in the world why they have to be in the black to the tune of hundreds of millions or billions of dollars. And that's all about the fact that if there's a surplus, it's private and somebody can do something with it. That structure of the healthcare, of the hospital marketplace is fundamental. And until that changes, we're going to have this problem.
So 2 things. One is Community Catalyst just did some polling on that. I was really interested in to what extent do Republicans, in addition to Democrats, think of healthcare as that's something that should be a public good? What should be the role of the government in intervening? And the results are really striking and exciting, and we're going to be sharing it. And I think it's part of the narrative component, which is really important to shift this. I would say at a policy level, let's start with under the TCJA, there's a requirement for an excise tax for CEOs who make above $1 million. That if a nonprofit entity has that, they're supposed to pay, I think it's about 20 to 30%, including hospitals. The form to report that is private. Why don't we have that be public? Let's see which hospitals are charging their CEOs. If they're charging them that much that they have to have an excise tax, maybe there should be some change in, let's do that. How much are they spending on advertisement? Should we have a requirement that on every advertisement there should be a line that says, by the way, there's financial assistance policies for each that we are legally obligated to provide? So I do think that there are small things getting us there that we could be doing, and happy to talk afterwards about them, because as you can see, I like to talk.
Our time is up. So this is a great segue. We have a break, but this is a great segue to the next session, which will be general systemic topics and issues on this issue of medical debt. So come right back.
And I'd like to welcome Bernita Haynes who's our moderator for the last panel. Bernita is a senior attorney at the National Consumer Law Center. In this role, she focuses on consumer energy policy and medical debt. So thank you so much for moderating this panel.
I don't know if this is on. Oh, it's on. Okay. Well, I'm going to sit down, and I have one at my seat, but I want to start here. Hi, everyone. Glad everybody's coming back in for the last session. We're going to try to rock this, go out with a bang here. I would like to introduce the lovely panelists for this session where we'll be talking about systemic solutions, some of the big hairy solutions to medical debt, long-term solutions. We have with us G. Bai, who is a professor of accounting at the Johns Hopkins Carey Business School, and she's a professor of health policy and management at Johns Hopkins. Sarah Collins from Commonwealth. She is a senior scholar for healthcare coverage and access at the Commonwealth Fund. Dr. Ed Weisberg from St. Louis is a national board secretary of the Physicians for a National Health Program. And last but certainly not least, we have Wes Ian, a professor of economics at the Anderson School of Management and Luskin School of Public Affairs at the University of California. Bless his heart for coming so far away. All right, we'll go ahead and get started. All right, so let's jump on into this. I don't think I need to even preface this by saying that medical debt is really about healthcare affordability because we've already covered that. So let's get right on into the questions. What are some of the causes that you all see? And I want to kind of popcorn this around. What are the causes and consequences of high prices that we see? And what can be done to address some of those problems? Let's start with Ed, and then we'll sort of popcorn it around.
Why, thank you. So, first of all, let me just say it's sort of my job to put all y'all out of business. You're all, everybody in this room is astonishingly well focused on solutions that are just spectacular. But I'm glad for this afternoon's this session where we can try to get upstream of that and figure out how y'all can do other stuff instead of the wonderful things we heard about. So one thing that's not the root cause is overutilization. And most of the strategies that we hear from people is that we need to put skin in the game. We need to cut back on utilization. And we're about average on that. But what the root causes are is directly from fragmentation. It's directly from fragmentation. So there's all of this overhead from operating this Byzantine system. There's a lack of an ability to price negotiate because of our fragmentation. And those things drive the vast majority of why we spend double. Most of the other solutions are just focusing on little pieces of it, but it's the fragmentation, the lack of negotiation, and the incredible administrative bureaucracy required for such a fragmented, profit-driven system.
Awesome. And Wes, would you like to offer some insights here too?
Yeah, I mean, can you hear me okay? Yeah, I mean, I like to think about like the medical debt issue at the tail end as the tail end of a healthcare financing pipeline. At the very, very end, you have medical debt. And then you have medical debt solutions such as, the credit reporting side, and you have issues of like medical debt relief. And I think all of that work has shown us like that's important, but we really have to, again, as everyone's echoed, like move upstream. And so obviously I focus on, the importance of coverage, but even in terms of coverage, it's one thing to have coverage, and it's also another issue to have good coverage. And one of the issues that we're seeing now is the increasing shifting of medical expenditure risk onto the consumers. And so why is that happening? We can then further go upstream, which we get to the issue of cost. Okay, so I'm going to quote a really good friend and mentor of mine who's passed, which is Uwe Reinhardt, who 20 years ago said, "It's the prices, stupid." When he said that 20 years ago, we had not seen the continued wave of consolidation, the horizontal consolidation. We had not seen the big wave of vertical integration, which has led to things like transfer pricing to related parties and weird things like PBMs restricting generic coverage. We had not seen at that time when he said that the big wave of private equity. And so there's a big issue of when we look at the pricing issues upstream is pricing and consolidation. So we really have to contend with that in a really fundamental way. And that's the issue of, okay, we've already let consolidation happen, okay? And we don't have the statutes that really address the types of consolidations that we're seeing because those statutes just weren't written in this context for the piecemeal consolidations that are death by 1,000 cuts. We also don't have the ability to then regulate the conduct of things that have already emerged. And so that's a really important thing for us to do, to examine that. The last thing I'll mention is one step further upstream than even that is people's like purchasing power and wages. And so I do think about the healthcare system in terms of the context of a larger sectoral input into the greater economy, and so the supply side efficiencies with the national economy. I'm wearing my OMB chief economist hat now, but we do have to think about like what consolidation is doing and the weakening of labor power in general, and what that means for the ability to purchase something that's also already becoming more expensive. So those are some of the root causes that I see. I'm happy to talk about solutions.
Yeah, I think I'm already getting a hint of one of the solutions. But before we go right to that next question about solutions, I want to see if Sarah or G have any comments on this question.
Sorry, I have it in my hand. Okay, so the Commonwealth Fund has been tracking both people who are uninsured, obviously, but also people who are underinsured. So we developed a measure a long time ago that we continue to track that looks at the share that people spend out of pocket relative to their income every year, and also the size of their deductibles. And our thresholds are 5%. If your deductible is over 5% of your income, we consider you underinsured. Or if you spent more than 10% of your income on out-of-pocket costs over the past 12 months. Or if you're low income, if your income's under 200% of poverty and you spent more than 5%, we consider you underinsured. So in 2024, about a quarter of the country was these are people who are insured all year, but underinsured. And when we ask about medical debt, 44% of people who were underinsured reported medical debt. 35% of people who were uninsured reported medical debt. That is really a reflection of use. People who don't have care, don't use that to have coverage, don't use that much care. And it points to the real serious issue in our healthcare system, which is our health benefits are not adequate. And I guess on prices, the thing that always gets me, if you think about it, prices. When we ask people about the source of their debt, the majority of debt, people report that hospital, outpatient or inpatient care is their primary source of debt. Prices, as panelists have been saying, are the major driver of healthcare costs in the system, and particularly the prices that hospitals charge. Okay, so those prices drive healthcare costs, which also in turn drive premiums, which in turn drive growth in deductibles and out-of-pocket costs, which in turn drive medical debt to the very institutions that started the problem in the first place. So it is shameful, I think, that hospitals actually go after patients for medical debt without recognizing their role in this problem.
I'll just quickly add, I believe it's purely a pricing issue, right? If we experience the very rapid decline in price as in other markets, think about storage, the cloud storage or iPhone or car, we would not have a medical debt discussion today, right? But then why is price so high? I'm looking at this from two ways. The first one, supply. We are having all sorts of, in my opinion, regulation related barriers for entrance, and also think about 340B, think about the physician in the hospital. Now we have the set-based payment, right? Set-based payment, not set-neutral payment. There are many other examples like certificate of needs law, many such examples. So those barriers really incentivize the providers to consolidate, as I said, consolidate and then raise the price. And then on the consumer side, in all other markets, we have very conscious consumers using their own money. So they put the pressure, this two-party payment system put pressure on the pricing, right? If you charge me, I'm going to leave and go to other places. But in healthcare, we kind of have patients insulated in many cases. And that's why on the two-party, when people pay cash, if you look at him and hers, right, the price is extremely efficient, very low, and decline quickly. But on the other hand, right, if we have this convoluted middleman in the middle, and then we are less likely to see price decline. So to me, it's really a pricing issue caused by distorted supply and distorted demand. Thank you.
Thank you. And so we'll move on to the solution part of this question. What's one policy you think is especially important then for bringing down the cost for patients? And I'll start with Wes.
That's a great question. So I think on the antitrust side, I think there's two issues. Like one is about how to prevent continued consolidation, and I think that there's probably a great scope for both federal and here's where state actions are really important. There's a lot of actions that can be taken on the state side to monitor mergers and acquisitions more aggressively, and I think that that's again forward-looking about like the prevention of anti-competitive mergers and acquisitions. There's also quite a bit that can be done on the monitoring of conduct, given that we already have 90% of hospital markets that are already highly concentrated by DOJ standards. So in that case, forward-looking reviews of future mergers really isn't so much the issue now. It's actually the conduct that's already happening, such as all or nothing contracting and cross-market consolidations that have led to extraction of rents from like larger employers, so on and so forth, and some of the other issues that I mentioned earlier about PBMs and related party transfers. I think another direction that we need to think about going, which is, well, let's think about different ways that we can regulate or provide discipline on prices. That could be out-of-network pricing caps, which then alters outside options and bargaining power. That could be on public options, which again inserts some sort of discipline in the market. But even then, you can have weak versions of public options, strong versions of public options. It has to have teeth to happen. We have some state innovations that are going on there. Then in the most extreme version, you can regulate prices. And so to me, it doesn't matter so much when we think about like wider coverage. It doesn't matter to me whether it's publicly administered insurance or privately administered insurance. What matters is that we're paying for it and that we're doing something about the pricing. And so those two things have to be done.
That's a great comment, and we'll get back to that question of public versus privately administered insurance as well. Any other responses to this question about solutions to bring the prices down?
I have one.
Ed?
So, the organization that I'm with, we're pretty well focused on the idea of a single-payer national health insurance program modeled on improving Medicare. So it would be first dollar coverage for a comprehensive suite of benefits, all the things that are really medically appropriate. So if you provided that around the country, the reason that's so important to me is that it actually does get at price. Even without tapping into the negotiating power, it gets at price. If a third of what we spend on healthcare today is going into the cost of propping up the administration, then if you can simplify that approach, you've captured most of the savings that we're trying to get through other less aggressive solutions. So we know that the insurance industry has let's call it a 15% SEC reported overhead and profits. And we know that Medicare operates with about a 2% overhead. So that right off is part of it. And we also know that another 15 or 20% of what we spend on healthcare today is really insurance overhead that's hidden and obscured on the delivery side. So it happens that we have about 900,000 hospital beds in the United States. I counted them, and I'm exhausted. We have about 900,000 hospital beds, and hospitals report roughly 900,000 full-time equivalents working in billing and insurance-related functions. Roughly one employee in billing, hospital billing, for every bed. We don't have doctors or nurses like that, but we do have billing staff like that. So one little example of that would be Duke has about 800 hospital beds, more or less, and the University of Toronto has about 800 hospital beds. Duke publicly stated that they have 1,600 billing people, and the University of Toronto has publicly stated that they have 7 billing people. And most of those 7 are to take care of Americans who came across the border. So, how do you pay for that? That gets embedded into the fee schedule. That gets embedded into the DRGs. That gets embedded into all of the overhead that then goes into the premiums, that goes into everything else that we were just hearing about. So the last time I saw an estimate from Milliman about physician practices, it was about $100,000 of office staff dealing with the insurance industry whereas in Canada, it was about $20,000. Where does that money come from? It comes from fee schedules. So that goes into premiums, and all of that adds up to about a third of what we spend on healthcare is this overt and hidden cost of our Byzantine, fragmented, profit-centric insurance model that would largely disappear under a single-payer Medicare for all system. So that's a big chunk. That's let's say 30% that we could save if we did that. Most of the other solutions you could compete for price on LASIK because you can shop around. I can compete for price on a phone because I know the features I want on my iPhone that are different from the ones my wife wants on her phone. But you can't compete when you're having a heart attack or when you need your cancer care. And I don't see, and that's where 80%, most of the money goes into severely sick people. And that's the last person you want to make price shop. So anyway, that's what I think.
They're going to call you a jobs killer if you start framing it that way.
You want me to answer that?
No, go right ahead then.
So that's been looked at. If you did do that, there would be about 1 million jobs that would be displaced, more or less. Understand, every year we have 20 million people that are fired, another 20 million people who quit, and another 20 million people who leave the workforce for whatever other reason. So every year we have 60 million, 60 million, 60 million job changing. This would be 61 million. 60, 66. So it's something that the bills that propose this model talk about income protection and retraining, and then with all this work we'd need to be doing in healthcare. So they would have all the nurses and stuff. They would have stuff to do, and the other functions are largely functions that could transfer into other industries. So yeah, it would be a little bump, but it would be a bump that oh my God, we have to get over that, and we can't stop adding. It's killing people, and we can't keep that up because it's too deadly.
I said that as a joke because it reminds me of I was an environmental attorney, and every time we talked about transitioning away from coal, it's like, you're going to kill all the jobs. And we always talked about how the bills have to include retraining people for other types of occupations, and also realistically recognizing that some people can't be retrained and so forth. But I could see the same argument happening. G and Sarah, I want to make sure you have a chance to answer that question too about what you think might be the one policy solution to bring down the cost.
Thank you. I think we should move healthcare as close as if we're buying a coffee. Think about the COVID-19 at-home test. One government worried about the affordability, so send us free test, right? That cost about $30. But once they open up, see what's the price in Europe is about 1 to 2 euros. So let the patient control their own money and make it as simple as possible. In terms of low income and high risk patients, we should absolutely give them comprehensive insurance and try to directly sponsor them, direct the money channel to them. Imagine you are Medicaid patients. If you have any money controlled in your hand, don't you think you have higher incentive to seek for better health status so you don't get sick, and then cheaper options? Right now, if you're a Medicaid patient, no matter how hard you try, you get no benefit. Like you cannot get any money left in your pocket. So that really reduces the incentive. So therefore, I believe the subsidy should try to not give to the system, but give to patients, and also move other healthcare items, like let's say primary care. We have a paper published in Journal Internal Medicine talking about how we should move primary care to direct pay. So we just pay the money, and then we get the primary care, and in return we get a lower premium, and that will be used, for us to have more dispensable income. Thank you.
And Sarah,
I might say something a little different than that, but I like that idea. But anyway, so I think healthcare is totally different from other industries. In most industries, costs drive prices. In the healthcare industry, prices drive costs. It is completely backwards. The prices bear very little relationship to costs. So we actually do have to do something about price. I agree on the consolidation issue. I think the train has kind of left the station at this point. So we are going to have to think more about Medicare prices and how are rates set in Medicare, and how can that inform where we might go forward. The Urban Institute did a couple years ago, or now going back to 2019, I guess, when Medicare for All was very prominent in the policy discussion in the 2020 election. Urban did some really nice work showing that you could reach universal coverage by building on the Affordable Care Act. You could also reach universal coverage with a Medicare for All approach. The big difference, unless you did something, was the cost. And Medicare for All achieved much lower costs. So you covered everybody at much lower costs. That was because of the price. And so what Urban did was let's place a public option, auto enrollment plus public option in the mix of things, so that you build the cloud of a public option, and you have negotiated rates at a percent of Medicare in the public option. So it was possible to get close to universal coverage, or at least near universal coverage, at a price that was close to the Medicare for All. So it really does come down to how much we are reimbursing providers, and we really do have to look. It's hard politically to talk about this. Even states are trying to do this with public options, but it's been difficult, and they've ended up with relatively weak public options. But I think driving the cost down is going to really require us to think hard about what we pay for healthcare and commercial insurance markets.
And that's a great segue into this broader discussion about public versus private insurance, and public structures potentially being a solution. There was a Gallup poll, the latest Gallup poll, I believe it was in December of last year, that showed about 62% of Americans believe that it is the federal government's job to ensure that all Americans have health coverage. Now, what that health coverage ends up looking like, the poll did not go into that level of detail. But I'm interested to hear from panelists here what your thoughts are in terms of whether you think a single-payer universal health coverage system would fix the problem of medical debt. And yes or no, what we could learn from other countries and what we could learn from our existing U.S. single-payer systems like the VA system and so forth. And I'll let anyone who wants to jump in first jump in there.
It will solve. Imagine tomorrow we have a insurance for our grocery, 100% covered, no out-of-pocket payment. There will be no grocery-related debt at all overnight, right? Yeah, for sure, because it's all covered. And then in return, we increase tax, right? We got the federal revenue, and then we just split, and then people can buy. No medical debt, no debt related to grocery overnight. But then what will come back? Imagine now the grocery stores get the money from the government, right? So what is the incentive for them to provide more variety, or better quality? There's no incentive, because if you leave, as a consumer, you leave the market, you go to another grocery store, does not affect the revenue. So that is, I think, the trade-off we have to face.
I think I know somebody who doesn't like to eat, but other than that one person that I can think of, everybody I know wants to eat. They eat as often as they can. I don't know anybody who likes to go get health care. If you took away the financial barriers, there would be some people who would. And indeed, I worked in a setting I practiced in a setting where we didn't have copays for a long time. And there were a few people who came in who probably didn't need to come in. But when you got to know them better, you found out that the reason they came in was there was a whole agenda of psychosocial problems that it took months of them coming in for silly things before they felt comfortable talking about the really fundamental things. And once you got to know them through primary care and got past that, then suddenly their utilization of these services started to go back down. So I don't see anybody waking up in the morning going, should I go golfing or go get a colonoscopy? Which is more fun? I just don't see that we need to do that. And instead, every time you put in financial barriers to care, most patients don't have the resources to adequately distinguish between whether this is life-saving. Is that statin really going to prevent that heart attack? I don't know if I really believe that. They'll adhere to their pain meds, but the other stuff, they will stop complying. We know this. I mean, I used to work at a large pharmacy benefit management company, and we know that if the copays reduce utilization across the board for things that are medically life-saving and things that are not anywhere near as health important. So that's just not the way forward. You know, that's just not, that doesn't get to the root problems that I was talking to.
I have a funny little comment about what you just said. I don't know anyone who likes to go seek healthcare. I have a friend who has lived in South Korea in Seoul for 20 years now. And he's married there. He's a permanent resident, thinking about getting his citizenship finally. And apparently there's a big screening thing that happens at some point when people hit a certain age for like stomach cancer or something like that. And he's like, my wife, her whole family, all my colleagues are so excited. He's like, they're all like, oh, I can't wait to get my screening. And he's like, I'm looking around like, why do you want to go to the doctor? And I politely told him, you're very American. And it's never going to get, that part of you is never going to leave you because we're permanently traumatized. But anyway, I just think that's a funny story because it's very American to not want to go to the doctor, I think. So, Wes.
Yeah, I want to come back to your question about public or private. And I think like ultimately an important aspect of this is that there's some strong aspect of public subsidies and public support, because as I'm echoing a lot of what I've said earlier, I mean, in some sense, it's not just a free market, there's a distributional aspect of healthcare in our system. We have to recognize that. And in some sense, the way that you build in subsidies oftentimes is distortionary, but we have to be okay with that as a value statement in society. We all have different views on that, but I think we have to just accept that. So an important aspect of public or private is, you know what, it kind of doesn't matter as long as we do have that the financing of it. Now, whether it's administered publicly or not, whether it's a single payer or not, I think it still comes down to like how we administer the prices and what types of, even in a publicly run insurance, we still have to incentivize the providers in some ways. So we always have these incentive issues that we have to deal with, and we can imagine, well, we can get it wrong in either way. We can get it right in either way. So in Medicare pricing, we have a long history of struggling and contend with how do we set those prices correctly. And then we said, you know what, let's have the private market do this. We have competition run. But you know what, like, okay, then we have to worry about the provider incentives and things like that. So we have capitated payments. Then we just overpay Medicare Advantage. So like it's always a struggle, and it's a political process ultimately, given how much the public pays for it. So to me, whether it's a single payer public insurer or a private insurer, it's just a different set of issues that we have to contend with when it comes to the issue of setting prices and price growth. So
Appreciate that perspective. Yeah. Sarah?
So we have an international survey that we run every other year. And we have a question on that survey that it's kind of like medical debt. It's just, do you have problems paying your bills, or you're not able to pay your bills over the last couple of years or so? And the U.S. obviously is highest, about 22%. Some of other survey data, our survey data, national survey, a little bit higher than that. Kaiser's a little bit higher than that. But in any case, for this particular survey, about 22%. This was about 9 percentage points higher than the worst country, Australia. It was 4 percentage points higher than the UK. So that's the rates are obviously quite a lot higher in the United States. And so if you look at internationally and the differences between the U.S. and OECD countries with universal health systems, it's the 22% reflects our uninsured rate, but it also reflects cost sharing. The average deductible in employer-based plans right now, this is the latest 2023 MAPS data, ranges from $1,200 in Hawaii to $2,600 in South Dakota. That's just the average. In 24 states, the average deductible for employer-based plans exceeds our underinsured threshold, so 5% of state median income. So if you look at OECD countries, with the exception of UK and Canada, there is minimal cost sharing. So primary care, there's never cost sharing for primary care, or it's quite minimal. Specialty care, a little bit of cost sharing, maybe in Australia, $56, France, 17 to 26, Netherlands, up to a $468 mandatory deductible. Compare that to the average deductible in employer-based plans. Okay. And then Switzerland is always held up. Often, this is going years ago during discussions before the Affordable Care Act, as a model that conservatives pointed to as potentially, one that could fit the United States. And it is true. Switzerland does have higher copays than other universal healthcare systems. 131 to 200. These are 2023. Actually, earlier than that, but anyway, you get the point. $200 visits for physician services. So full cost up to a deductible plus 10% coinsurance. The out-of-pocket max in Switzerland is $2,600. Okay, compare that to the new out-of-pocket max in the administration's marketplace rule for next year. For individuals, $10,600 and $2,100 for a family. So, and then just one more interesting statistic about the Netherlands. So Netherlands, this is Germany. Excuse me. Germany caps their out-of-pocket costs. This is not including premiums. This is just out-of-pocket at 2% of household income and 1% if you have chronic health problem. Compare that to our underinsured measures. Compare that to what people pay even in marketplace plans. So we are obviously so far behind other countries in our rational, in our approach to making sure people have adequate health insurance coverage. And I'll say one more thing, because everyone always says, well, we'll pay more taxes. That is true. However, we also pay a lot in premiums. Yes. And you look at the Affordable Care Act's schedule, you pay up to 8.5% now until the tax credits will probably go away. The enhanced tax credits will probably go away at the end of this year. And then we're back up to a maximum at 9% and a cliff at 400% of poverty. So we are paying a lot in premiums for coverage that is really not very good.
You asked, the question you were asking was about public versus private insurance as a fundamental model, and it's really hard for me to understand what value the commercial insurance industry is adding to this equation and how they can. And I grew up as a zealot fan of the commercial insurance industry. I was a senior executive at a regional health maintenance organization. I got recruited then to go into being the chief medical officer of a large pharmacy benefit manager. And I was excited, right? I thought I can do all kinds of good public good. And so I'll give you one example of where I kind of really went far down into, no, that's not really a good solution. So I went to work there, and I thought, well, one of the first things I would do is put in a campaign to encourage people to adhere to their cholesterol medications. At the time, those were all statins, and I was a believer that statins really prevented heart disease. So let's do a campaign to increase adherence to cholesterol medications. Great, we'll sell more cholesterol medications. We'll make more money. Our clients, the employers, will have fewer heart attacks to deal with, and then they'll be great. So everybody wins. Patients will do. I was really excited. The problem we had was that our clients, in this fragmented world we live in, our clients knew that they had about 20% annual turnover of membership every year. People coming in, people leaving, people changing jobs, employers changing. So the question that they all asked was, okay, you want us to pay for this program to increase adherence to this life-saving cholesterol medication, without even questioning that part of it. You want us to pay for that program. How long will you have to be on this program? How long do you have to take a statin to prevent a heart attack? And I said, about 10 years. They said, great. So that 2 or 3 years from now, half of our employees won't work here. So we'll have done this campaign that we spent money on to improve the health of our employees, who by the time the benefit comes in, they'll be working for our competition. Why would we pay you for that? And that was, so the fragmentation of our insurance system, which is key to having a commercial insurance model, the fragmentation is corrosive to public health. It's not just neutral to it, it corrodes public health. It undermines any long-term public health policies that if we want to make America healthy again, I'm sorry to use that phrase. If we want, God, that infested my head. If we want to improve public health, the commercial insurance industry is one of the biggest barriers, and it's really hard for me to see the value that they're adding in exchange for killing us.
And I think that is a really perfect segue to like talking a bit about what is the value then that we see in systems like Medicare, Medicaid, and the VA the Veterans Administration, like how those are technically single payer systems. They're not universal, but they're single payer systems. What's the value we see there, and what are some of the, potential like things we can learn from those systems if we wanted to have a more expansive universal single payer system in this country? Oh no, anyone who wants to jump in.
I feel like I've been talking a lot, but I'm glad to have. Okay, so the first thing is that the details really, really matter.
Yeah.
So the details really, really matter. So Medicare doesn't cover a lot of things that are really important because in 1965 we didn't know that they were that important and they weren't very expensive. So the details of what you actually cover matter. Your ability to access care really matters. So in some geographies, the VA has tremendously good access, and in some areas it doesn't, because in some areas it's funded adequately to support the veterans that they have, and depending on the severity of the veterans' health status, they can really get access, and in some areas they can't. So the details of how it gets set up really matter, which means we should set up a system that's cohesive and consistent around the country all the same. Your diabetes in Texas is pretty much the same illness as diabetes in Alaska. Not exactly, but almost.
Any other comments on that question?
Yeah. I think Medicaid, I'm really worried about.
I think is it on?
Okay, great. Thank you. I think sorry. Think on Medicaid, we taxpayers pay so much to individuals, but they don't see the money. So what is the incentive there for them to shop cheaper services? There's zero, right? No matter what they do, my problem is that they cannot get any personal financial benefit out of it, no matter how much money we taxpayers pay. Another problem, they cannot go there to see a provider they want. Let's say there's a famous doctor. The doctors just want the money, right? I mean, not all one, but if you pay, they're going to see you, right? But the Medicaid patients cannot see that doctor. Like in Bethesda, where I live, many doctors don't even see Medicare patients, let alone Medicaid. But if the patients have money in their hand, they'll be treated equal. There's no reason a doctor will not see them, right? You pay the money. So that's why I think we have to maintain our subsidization of Medicaid patients, but we have to give them freedom so that they can be untied from right now the very restrictive network and their inability to benefit from lower price or better health.
Thanks. And I do think that the point that you made about restrictive networks is really critical. That's a problem we see in Georgia a lot. And I don't think it gets talked about quite enough when we're talking about the insurance issues, is how restrictive networks are.
And that actually gets back to one response I have to the benefits of a public system. Is it's easier to bargain in bilateral negotiations if you have a government purchaser. And so one of the reasons why we have these narrow networks is precisely because they're bargaining separately. And so they're, positioning their network, the other guy as an outside option to the negotiations at hand. And so you get around a lot of these issues when you just have, like a strong negotiating position. So that narrowness of the networks really comes out as a byproduct of the types of bargaining that can happen at like a public level. So there's that one issue. I'd also say that your point about the incentives that like fragmented insurers have, and I get that. That's definitely one of the issues, that you don't have these long-term incentives. A public insurer also hasn't been great about doing that either. So, even within the systems that we have, with like fee for service, we haven't really developed systems that incentivize like long-term care. But I will say, and I wish there was a political scientist here, like probably much more valuable than economists up here, is thinking about a long-term solution. Is it harder or easier to effectuate like smart changes when we have an idea of, let's say, we need to reduce cost sharing for really high valuable drugs that have no moral hazard aspects like diabetes? Is it easier to do in an environment we have one public payer, or is it easier to promote it through regulations onto private insurers? And what does that lobbying process look like? And so I think we need to think about like the long-term political processes of regulatory changes as new ideas come about. And it's not clear to me whether one system is better than the other. My inclination is probably, single payer offers a lot of advantages there, but I think that political process is really important.
Okay, that sounds, and I think that's getting us towards the end of our questions as well. You actually kind of already started answering the next question I had, which was about Medicare for All, since it's been brought up. As folks in the room probably know, Senator Sanders and Jayapal reintroduced Medicare for All companion bills, I believe. But is there a way to eliminate medical debt without something like Medicare for All? We've talked about the public option. We've talked about pricing controls and things like that. What ideas do you all have in that respect about how to eliminate medical debt without something that's big and hairy like single payer or Medicare for All?
I think there are other ways, but I think they're bigger and hairier. You could put in so Medicare for All is based on the idea of private delivery but public funding.
Mm-hmm.
Private delivery but public funding. And the simplified funding means that physicians would no longer feel compelled to be employed. They could be out in private practice in small groups and individuals, which is kind of disappearing today. So Medicare for All would preserve the private delivery system and actually enhance the private delivery system, but create public funding of it. How else can you get, but the key is it's first dollar coverage of a comprehensive benefit design for the entire country. So you can do those three characteristics and get rid of the private delivery model and have it be a public delivery model. So you could do a national health service like they do in Great Britain. I'm not a fan of that. That would be less expensive than what we have today, than what Medicare for All would be, but that's culturally inconsistent, and it's not my personal preference, and it's not what our organization. So you could do a national health service rather than national health insurance. That would be
similar to like the VA system,
like a VA system for all. That's bigger and hairier. You could do other intermediate things like an all-payer model, which is kind of emerging, and that would get to some of the value. But if you set up an all-payer with first dollar coverage for comprehensive benefits, that would be too, but it wouldn't capture all of the savings and all of the value. So there's other strategies, but they're not as robust, or they're worse in my mind.
Thanks for that insight. Sarah?
Yeah, so I think it's important. I agree with everything that Ed said. I think it's also important to look at where we are right now. And if let's just say we have the Affordable Care Act. The Affordable Care Act is actually working relatively well in terms of the marketplaces, and Medicaid has issues, obviously, and if we had that framework to work within, there are clear ways of improving benefits that are really driving the problem, aside from the pricing issue. So we could improve the benefits in the marketplaces. It needs serious attention. There have been bills. Senator Shaheen had a bill that we always go back to, that Urban's also done a lot of modeling on, just improving the cost sharing requirements. It's extended further up the income scale. Change the benchmark from silver to gold. Silver plans have really, really high deductibles that people are dealing with. In the employer-based area where most people get their coverage, we also need to address the out-of-pocket costs that a lot of people, particularly lower-income people, are dealing with. The problem right now is that we are seeing bills that are actually putting cost sharing into Medicaid, which is extraordinary. We are seeing bills that are actually going to make affordable coverage for the marketplaces less affordable. Less people in, probably even drive premiums up, driving people down into even more people choosing for bronze plans just to get. So the policy direction is completely going where it's going to make things worse, and we're just going to see a lot more medical debt. So then you get back to the bigger question is, let's see what the damage is, when the dust settles, and then ask the question, where do we go from here? And I think it is going to be questions about, we have a very fragmented system. It has not worked well at all. And so asking these really big questions about what has worked well, what has not worked well. The Affordable Care Act was never a perfect solution. It was the only solution politically at the time. But we really are going to have to look hard at what we're going to do next.
And I think that is a great point to open it up to the audience, since we have 15 minutes left. So I'll open it up.
I wanted to ask about a workaround that I thought we were going to talk about in this conference, and that is the purchasing of medical debt.
Yes.
A lot of states now are actually, legislatures are actually donating money for this purpose. And quite frankly, I question it. But a lot of I'm from the University of Florida, Dr. Fred Southwick, and a lot of medical students are really attracted to this. They're starting to campaign our legislator in Florida to consider paying out medical debt. But it seems to me that's a serious workaround, but I wondered what everybody thought.
I'll just jump in and say that was actually a question we had, but in the interest of time, I decided to forego it. So I'm glad you asked it. Wes?
I would say that there's an asymmetry in forgiveness versus prevention. Okay, so you dig this hole in the ground, and then after the damage has been done, you try to fill the hole later. And I think that that's a really beneficial thing to do. But a lot of damage has already been done already. I think there's a lot of emphasis, and the great folks at Undue Medical Debt would support this, to say that medical debt relief is an important aspect of it, but it really is a tail end solution to a problem that we need to solve upstream. And so there's a lot of damage that will happen. And so how about this? Why don't we relieve medical debt instead of 5 years after the debt? How about 2 years? Or how about 1 year? How about at the point of service? Oh, then we're talking about insurance. So that's the reason. And I think one of the reasons why we have a lot of debt forgiveness is really because, the folks are using ARP money on this. They see the 100-to-1 leverage and say that we're getting rid of a lot of debt. And that really resonates with people. And I think that's an important thing. It resonates with people in the same way that there's a lot of energy in this room. It resonates with people because we just think it's unfair. Well, okay, why don't we take that energy and apply it to like the prevention side? And I think that's where we need to focus our attention.
Yeah, actually, so since our last panel, I'd love to get to people who haven't had a chance to ask a question yet. So if you haven't gotten to ask a question yet, well, I'll go to you first, but then if you have, I'll go to you second. Yeah, great.
Okay, so since I'm the organization that does do the tail end work and is getting all those government funds, I just want to say I completely agree, and I think everyone knows that we do not think that we are the solution by any stretch to this problem. But I think our work is bringing a lot of air to this conversation, which is really important. What I'd like to ask, though, also is is there a combination? I really am here today because I'm extremely frustrated, like everybody else. I'm worried about the current situation. What's the political angle here? what is the Republican side of things thinking since they're in charge right now? And what are I can't help it. I'm an optimist, and I'm okay, the world feels like it's on fire and it's blowing up, but maybe that's an opportunity. Maybe because, and I think you said this a little bit, there's opportunities, there's changes. We can see how the dust settles and then move on. But what is that moving on? Is there a we talking about public-private option. Is there a public option that sort of run by the government? I'm making this up, but that employers can buy into, so it's cheaper than the private. Has that been talked about? Those are the kinds of things I'd like to hear.
Yeah, there's a lot of versions of this, and I think I just alluded to them earlier on, which is you could, on the pricing side at least, you can think of just public procurement. You can also think of having private plans be given publicly negotiated rates. So the government is setting the rates. That could be voluntary participation by hospitals, in which case it's considered quote unquote a weak public option, or they have to eat it. They have to take it. And that's a stronger one, which is essentially rate negotiations and rate setting. And that's still a softer version of just setting rates, because what we're doing is we're having a public option go into a market, and then that's providing discipline to the private insurers and whatever, and so on and so forth. And that's kind of a lighter version of that. We could also have a situation where, let's say we have a government option, we have a government-run PBM, and then employers can hop onto it. There's a lot of different things that we can think about. I put it all under the class of rate regulations. It's just different ways of doing that. Yeah. Yeah, I mean, I think you'd have to talk to someone out of the caucus there. I mean, there's folks here in Ledge Affairs that know a lot more about this than I do, but you know, I see there's a tension on the Tea Party populist side, and then you have a corporatist side, and I think they're at odds right now, and there's a lot of opportunities for odd bedfellows at this point. But I'd leave it to the Ledge Affair folks to talk about that.
I think that's true. I think the odds that we're going to get a public option or Medicare for all in the next 4-6 years is pretty low. But I want to say two things. First, you know, a thought about the public option strategically, and then sort of a description of what a good public option would be. Strategically, the reason I'm not eager to see us chase a public option, it'll take 4 to 6 years to pass one. It'll take another 2 to 5 years to implement it. And then it'll take another 3 to 5 years to assess the value. So 10, 12, I don't know, years from now, we would then be looking at a program that's never going to get us to where we really want to get. And then we'd be back, like Winston Churchill said, doing the last right thing. So, but if we did want to go down, if there are three key characteristics of a good public option, the first, I think, is that it has to be tied to Medicare, to regular Medicare, not to Medicare Advantage, but to Medicare. And that means use Medicare rates. That means a physician or hospital would have to accept the public option and traditional Medicare, or accept neither. So then you would have the full network of traditional Medicare. So the first key is it's got to be strongly tied to Medicare, not to Medicaid. Medicaid, then you would have it varying from state to state, and the states that most need the value would be the states that would be the last ones to adopt it. I live in Missouri. Trust me, that's really true.
Georgia.
The second piece, it has to be better than Medicare. So a good public option would have 0 copays, 0 deductibles. It would have comprehensive benefits, you know, hearing, vision, dental, nursing care, all of that stuff. And then the third piece, which is probably the most important, is it would have to have a strategy to mitigate adverse risk. And the way you can do that, I think, is to design it so that it would start large and continue to grow. So starting large means let anybody who wants to be in it. Let any individual, be they insured today or not insured today, let them opt into it. Let an employer decide to shift their whole book of business from commercial insurance into this, and then they can stop negotiating all this nonsense. Let states shift their Medicaid business into it if they want to. So the benefit design would have to be as robust as Medicaid's is. So let a state shift in. But then probably the most important and most difficult piece is it would have to auto-enroll all of the uninsured today. Oh my God, a mandate. But make it really easy for anybody who's auto-enrolled to opt out. And then you have the behavioral economics principle that people of inertia. So people, if you make it opt in, you get 10%, 15% of the uninsured. If you make it opt out, you would retain 85 to 90% of the people. And if you did those things, it would be large enough to mitigate the adverse risk. So it's got to be tied to Medicare, not Medicare Advantage, not Medicaid. It's got to be better than Medicare, and it's got to be large and able to keep growing.
That's a great point. If assume for a second we are the hospital CEO, what would you do? If I am the CEO, I would not sell my debt to you because you're a private buyer. I'm going to work with my regulator in my state to ask taxpayer money to buy. Why? It's much easier to work through, right? They will not pay market rate. They will pay much higher than what I could have collected if I go through the process. By this way, I will get more money from the government, right? From taxpayers. But at the same time, patients understand if I don't pay, government is going to pay. So the collection rate will drop. But that's amazing for me because why? I will ask taxpayers to keep funding me. then eventually we'll in effect go into a single payer system.
Perfect.
And then, yeah, I would say that's probably what a CEO want to do. You might say, this rate might be too low if we go single payer. I don't think so. I believe right now the price setting process extremely captured by hospitals. That's why we're seeing hospital price, if you look at the trend, right, very, very high and rapidly increasing, because they really are very, very powerful, capturing the process. So they would love to, I'm talking about powerful hospitals, they would love to have government pay off the debt and then influence the pricing process. So that just from a purely, self-interested CEO's perspective.
Oh, Sarah, go ahead.
Just so one thing obviously that's got to determine what happens is these are always political political decisions and political environment. And the Affordable Care Act, if you remember, there was we got to a point where there was just momentum and it was in all the candidates' health plans in a couple election cycles. Where finally so we are doing focus groups right now with people with medical debt, people with collection, people who have claims denials, and then and billing mistakes. And so we're asking them, well, what do you think the government should do? What do you think should be done about this problem? And a lot of people are saying, I think we should think about other countries. I think we should have systems maybe and these are not informed. These are people who are not informed about health policy the way we all are, obviously. And thinking that way, that something big needs to be done because this is intolerable and it's not fair. I pay my premium and yet I'm having all these problems. These are people with employer-based coverage. So is it, and the medical debt has been catalyzing, I think, on both sides. Are we at a place, and what we saw in December and January about the United Healthcare, are we at a moment where the frustration is so high that people are open to thinking a little bit differently about our system?
Christine has a question here. As you're walking over, I would just like to say that I want everyone to take a look at an article in the New York Times called "Why Doesn't the United States Have Universal Care? The Answer Has Everything to Do with Race." Please Google that article. Because I think it is extremely important that we haven't really addressed race in this conversation today, because it really is at the heart of why we have these problems, and particularly anti-Blackness. I just want to make sure I uplift that. But it's called "Why Doesn't the United States Have Universal Health Care? The Answer Has Everything to Do with Race." New York Times. Christine.
Yeah, it'd be great if you could email that to, or if there's a sharing of resources after the conference, I'd love to.
I'll send it to Vikas.
Thank you. What I wanted to mention about the politics of this issue, kind of a good news, bad news, not to be Pollyanna-ish, but if you think about the CFPB rules, the Consumer Financial Protection rules that were, overturned by Congress recently, medical debt, the wonderful CFPB rule to take medical debt completely off credit reports, that has not, even though it's been introduced, that has not, been up for a vote at all. And I think that's very telling, because no politician wants to tell their constituents, hey, I'm voting against this proposal that would take medical debts off your credit reports. And I think when you think about the Republican frame of mind or viewpoint of life, I don't want to generalize, I'm not a Republican, but what I've observed is unless someone has felt that harm personally, that harm may not be real for them. And, hearing a lot of your stories, there's obviously medical debt is something that we're all very familiar with. So I think I wanted to just say thank you. Like so many of you in this room have done really great work to get the stories out there. And I think that's ultimately going to be what moves the needle and what has moved the needle. Michelle's group, Community Catalyst, there's been a lot of stories out there. NCLC has pushed out stories that make this issue very relatable. Now, here's the warning part. When those stories aren't being pushed out there, I think, and we're not really paying careful attention to the process, that's where the danger lies. So right now, in the House version of the reconciliation bill, there is a provision in there that would preempt all state cases having to do with AI. So I've heard like 3 of you in the room today talk about the dangers of AI, especially as private equity is taking over so much of the healthcare space and they're trying to save money using AI. You know, what does that mean, especially for communities of color? How are they going to be shortchanged? How are consumer rights going to be put at risk because AI is now being used to determine who gets care or how it's administered? And there is a provision in the House reconciliation bill that hopefully will not go through the Senate version, hopefully would get killed by the parliamentarian, but it would essentially for 10 years not allow any kind of state, state causes of action that have to do with AI, and would preempt all those state cases. So again, preemption is, I think, another part of the problem as well.
And it looks like we have 50 seconds left, so we have a little bit of time. And it looks like Elisabeth maybe has a question.
Sorry. One of the things that I keep thinking would be an interim path, and I guess this is for Sarah or maybe I don't know, Wes, Ed, I don't think I probably know your answer, is that, it seems to me that like one of the interim things that the United States could consider if we weren't able to do Medicare for all would be something like the Switzerland model, which is we would use private insurance with provider rate setting, because I really believe Yui Reinhardt was right with it's the price is stupid. And so it seems to me that would be a really interesting approach that possibly we could get some bipartisan, so I'm just curious if what you all think about that, or is that just delusional hopefulness on my part?
It is probably the closest to our system, and in fact, it's basically nonprofit insurers on exchanges. So it's a model that I think people, because of the Affordable Care Act and all the people that have coverage through the marketplaces now, seems less foreign to them. So in that sense, and there is cost sharing, but it's capped, and there's nowhere near as high as what we have right now. So I that to me seems like right, exactly. Yep.
At least the reference basis.
Yeah, that's right.
Yeah.
Well, I think that is our time. Hopefully we rocked it on this last session. I would like to thank all of our lovely panelists for this very robust conversation. Sarah, G, Ed, and Wes, thank you so much. Thank you.
Get on out of your way. All right. Well, we're right on time. So once more, I want to thank all of you for coming today. I think this has been a tremendous session. My job is to summarize it, but I'm going to use ChatGPT, who's recorded the whole thing and reporting it out to everybody. Before I do anything, though, I want to thank the Lown Institute staff who put this together. So Noel Serino, Kelsey Chalmers, Judith. Where's Paula? Paula. Maybe Paula's outside. You can say on your way out. Thank you. Aaron Tolio's here. So thank you all. I'm not going to be able to summarize what we talked about, but let me offer you a few thoughts. I have one or two quibbles that I'm going to suppress because I think this is not the time or place. But I'll just tell a story. And the story is that I happened to be having dinner with the former Minister of Health of Switzerland and he was at Harvard, and he told me how they realized that it looked like there was a somewhat excess utilization of a certain test in primary care offices. And he said, so what they decided to do was use a price mechanism to address that. And so what they did was they just cut the reimbursement of that by 10%. And what happened the next year was the volume went up by 10%, evened out, exactly even, which just tells you it had nothing to do with clinical care. You can extrapolate that to a lot of things in American healthcare. And I think, I have huge respect for Uli Reinhardt and the work he did around prices. But I think the shocking thing, at least to those clinicians who've really kind of looked at how this works all over the world, the really shocking thing is not that the prices are high here or that the utilization here is similar to the utilization elsewhere. The real shock is you have small inklings in various settings, small experiments that show utilization is high everywhere for a lot of stuff. So I don't have the time to go into that, but it's an important dimension to think about. There's a lot of clinical waste in our system. But that's not why we're here today. So what do we learn? One thing we learned right at the outset is that employers can take the bull by the horns if they're motivated, if they have the right circumstances, but it is not their job to get all the rest of their tribe to become healthcare experts. Nevertheless, it's clear that there are pathways available, and if we were to replicate some of those, we might start getting a snowball effect that would be important. Not necessarily on the economic side, but certainly on the cultural and political side. So that's the first thing I'd say. The other thing we learned is that hospital leadership can be a key part of the solution. Emphasis on can be, and there it's a similar story. What we need is exemplary leaders, then we need a little replication, and we need pathways to the rest of the community to begin tackling this question. Of course, we had a lot of talk, particularly this afternoon, about the circumstances of Medicaid and the current bill in Congress and the prospects of cuts and what the consequences of that will be. And I share with everyone the concern about what we'll see with regard to medical debt. But one thing we did here, not just in the results of some successful state-based initiatives, but the methods that were used, is that there really is a path forward. And that has to do with something I pointed out earlier, but which I think all recognize, and that is the scale and scope of this problem is such that tens of millions of people are on the receiving end. Public opinion hasn't been mobilized around this, but were it to be, then those are constituencies on both the Republican and the Democratic side. And the stories we heard from the states is the pathway to that is not facts and figures. The pathway to that is really creating the common human connection through storytelling, of course. That's sort of become almost de rigueur these days, but sure, through storytelling. But primarily the key aspect is that as anybody who pauses, puts down the ideological blinkers and thinks about the issue, takes a moment to think about it, and hears from somebody they know or somebody they're face to face with on these questions, minds change, hearts change, and you can build coalitions. That's what I heard about what happened in the States. And I don't see any reason why that couldn't happen at the federal level. Now, maybe I'm a little optimistic, but I think there's opportunity there. We heard of a lot of incremental solutions, and they're probably good stepping stones to try to build these coalitions. We also heard about some systemic, comprehensive solutions of varying flavors. And I think what we recognized is that the ROI of those is potentially massive, but the pathway is very murky. And it's clear that, as Don Berwick likes to say, quoting many others, probably Charles Deming, that the system is perfectly configured to give the results that it gives. Well, one of the results that it gives is fragmentation, and there's a reason for that fragmentation. The way to overcome that is not through a thought experiment about the perfect unfragmented system. The way to overcome that is to apply energy, an energy of activation, to that fragmentation. That's political energy. And I think that's the only way we'll get the larger ROI that I think everyone senses. That's not going to be short. That's not going to be easy. But it seems to me we're starting to see inklings of how that might work, certainly for the problem of medical debt. So I just leave you all with that idea of hope and the fact that working together and working with colleagues of whatever political persuasion is probably going to yield results. And that's what we all have to resolve to do. I'm going to close things out now by just saying that we don't have a clear set of next steps to offer you, but what we do have, and your program has it, is a QR code. And if you look at that, you can get the final working paper of the working group here on medical debt, which you'll have and you'll be able to utilize. You can also be in touch with Lown. We'll be releasing our database of the hospitals and their financial assistance policies. It'll be interactive, and I think it'll be useful for many people. So if you want to be on the list for that, go to the QR code and get with it. Regarding what happens in the next weeks, months, and year, I think we all would agree it's a very fluid, dynamic situation. It's not clear how it's going to turn out. So we're all going to have to monitor that carefully. We're all going to have to be in touch with each other. But as they used to say, and hopefully we'll keep saying, at the end of the day, it's not about mourning. Don't mourn. Organize. Thank you for being here.